Ừ.
Hello everyone, good morning. I'm Hoài from VSM 2021. I will be here to support and during the sessions I will mute myself and
Hello, Hoài. How are you?
yes, I'm fine.
Are there Vietnamese doctor in your hospital?
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách, nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
At Viatris, we aim to empower people worldwide to live healthier at every stage of life. We're dedicated to delivering increased access to the medicines patients need, regardless of geography or circumstance. Because at Viatris, we believe in healthcare, not as it is, but as it should be.
I'm sorry, I repeat it. Good morning, everyone, and good evening for another doctor from United States. Today is our session about cardio-oncology imaging. For our co-chair today is Dr. Arthur and Dr. Vũ Quỳnh Nga. For the first speaker today, we have three speakers today. I would like to introduce the first speaker. The first speaker is Dr. Liu from Taiwan. Please show Dr. Liu for me. Dr. Hua, can you show it? I would like to introduce Dr. Liu. Dr. Liu is from Taiwan, Chung Chang Sin General Hospital, Taipei, Taiwan. His specialty is cardiology. He is an academy appointment of Taiwan Society of Internal Medicine. So the topic of Dr. Liu today is intervention.
Hello everyone, I'm
of
Dr. Liu
rigor
from
orthopedic
Chengxin General
total
Hospital.
occlusion.
Today, I would like to share my case with you. This is a case with RCA total occlusion with moderate diseased Lehmann disease, and intervention for all three vessels. This is a 66-year-old male who presented to our hospital because of unstable angina for a month and prior to this admission. His risk factors include hyperlipidemia, and his serum creatinine was 0.09 milligram per deciliter. It was normal. And the echocardiogram shows that the LVEF was normal and there was no wall motion abnormalities. And the ECG showed that no Q wave in precordial lead and very, very small Q wave in lead 3. And so we sent him to the cath lab because of unstable angina. And as you can see that from the angiogram, the three vessels include LAD, circumflex, and RCA was all were very severe diseased. Especially RCA was totally occluded. And you can see that LAD has a 90% stenosis and mid part, and the circumflex around 70% stenosis and mid part. And there are collateral circulation from LAD to RCA, and the RCA showed that it was severe diseased at the mid part and totally occluded at the distal part. And there are some collateral from RV branch to distal LAD. So we consulted our cardiosurgeon, and we had a heart team meeting, and the patient refused bypass surgery. So we decided to perform PCI for him. And our strategy was that we do the LAD first, and then we perform intervention for RCA, and maybe do the Lehmann intervention as well. So our strategy was that we treat the LAD first, especially from very proximal LAD to the most critical part, the mid LAD. So we use transradial approach, and we use a 6 French sheath, and the guide was 6 French JL30, and with side holes, and we can pass the pilot 50 wire easily across the critical stenosis, and we also performed the IVUS for him, and as you can see that we put back the IVUS from the mid part, the healthy part, all the way to the left main. And there is some calcium there, but it's not circumferential. So we can we decide to use the balloon angioplasty and put a stent. That's our strategy. Well, that was our strategy. Yeah. As you can tell that the osteo LAD was diseased, severe disease, but the left main is diseased, but the diseased, but as you can see, the still image, the image I show you, that the left main stenosis is moderate diseased at that time, but obviously the LAD was critical stenosis, and so we performed the angioplasty with semi-compliant balloon, and then we still use the scoring balloon to ensure that we can have a better lesion preparation. And then we put a 25 by 30 DES, and finally we used the 275 balloon for post-dilatation. As you can see that we put the stent from the very proximal part of the LAD to mid-part LAD, and we solved the critical stenosis. And you can see at the right panel that later that you can see that the stent was well expanded and well opposed to the vessel wall, and the flow was the TIMI-3 flow. So we do the second procedure for RCA CTO, and around 1 month after the first procedure. And our default strategy was that we used the bilateral radial artery, and one is 2 6-French sheath, and one is we will try the anterior. We will try the integrate approach first, and we would use JR4 guiding catheter, and as a integrate for the integrate approach, and for the retrograde contralateral injections, we use the JL30 for diagnostic catheter for the contralateral injections. And maybe if we fail the integrate approach, then we will try retrograde approach. Yeah, as you can see that from the right panel and left panel, that the RCA is still critical stenosis, and the left main disease seems progressed. But at that time, when we engaged the guiding catheter, the diagnostic catheter, there was no pressure drop, or there's no damping or chest discomfort. So we tried the integrate first, and initially we used OTW as a support, and we used Gaia first, and we used Ultimate Bro 3, and finally used Gaia third. But we failed to penetrate we all penetrate into the false lumen. So we failed the integrate approach was failed, and so we decided to do the retrograde approach. And we, as you can see, that the septal branch to PDA was seems available, seems feasible for a retrograde approach. So we used the JL30 guiding catheter, and we use a 150 Corsair microcatheter, and we initially used the Sion wire, and then we crossed the septal collateral to PDA with XTR, and we can reach the RCA distal PDA PL branch bifurcation, but we failed to penetrate the most critical part of the bifurcation. So we used the kissing wire to use the Gaia third wire to puncture retrogradely to the integrate to the mid RCA, and we can reach the integrate the JR catheter JR guiding, and we use the externalization with the RG3 wire. And after the externalization, we use the 1.5 and 2.5 balloon to dilate all the RCA, and you can see the iris after we do the balloon angioplasty for RCA. From the very beginning, you can see that the iris was in the false lumen, because maybe when we puncture we try to puncture the distal bifurcation, RCA distal bifurcation, we create a big false lumen there. But from the distal RCA to proximal RCA, we are owing the true lumen. We try to advance another wire to re-entry the true lumen of the bifurcation, and try to attempt to go to the PL branch, but we fail to cross the PL branch, and we fail to reach the true lumen. So at that time, we think that the distal, the PL, the collateral flow from circumflex to PL was very good. So we decide to just do the intervention from PDA to all the way to the proximal RCA, and try since that the collateral to PL was very good. So we put two long stents. One is the first stent was 25 by 48 DES from PDA to distal RCA, and then another one is the 30 by 48 DES from distal RCA to proximal RCA. And we used the 3035 balloon for post dilatation. And as you can see that the final IVUS showed that the stent was all expanded well and well exposed to the vessel wall. Maybe we can see that you can see that the older stent was very circular and well expanded. During all procedures, patients have no chest pain or hypotension or any sign of shock. Anyway, yeah. From the final angel, you can see that the flow from the proximal RCA to the PDA was TIMI3, and the flow to PL was only TIMI2 because of the big dissection at the osteo PL. But I think the collateral is okay. So we just close the procedure, and the final angel from the left main, you can see that left main is still diseased, but the patient has no chest pain during the procedure. So we will follow up this patient several months later for the left main conditions. Yeah. So after the procedure, patient come back to the clinic several times, and he still say that he have a mild FA angina without any progression during the follow-up. But we still worry about the left main conditions. So we suggest that around 3 months later, we suggest that you should do the follow-up angio for left main. So we perform the angiogram for left main. And as you can see from the left to the mid to the right panel, you can see that the left main is quite significantly diseased. Yeah, very quickly diseased, but the LAD stain was patent. And also there is some lesion at the signal flags was also progressed. So we put a stent from osteo left main to the very proximal LAD, and also put a stent at the signal flags. And the final angiogram, as you can see, that the final angiogram was TIMI-3 flow of both LAD and signal flags. And as you can see from the right panel, the OCT shows that the stent was well expanded and at the left main and the LAD part, and well opposed to the vessel wall. He's still follow up at our hospital, and there's no chest pain for years. So the discussion point is that first one is the strategy of revascularization and the order of the revascularization. After these years, I keep thinking that maybe we should do the left main intervention before the RC intervention for the safety reasons. Yeah, if we perform the left main intervention first, and they will be much safer during we try any procedures to the RCA CTO. But I think there's still some challenges to complete this kind of severely diseased coronary arteries, include concomitant left main and RCA, or both diseased, and especially in RCA CTO. I think though that maybe we should do the left main disease first, but if we do the RCA CTO with the retrograde approach, it's still feasible, even if the left main coronary artery is moderate diseased or severe diseased. But I think for the safety reasons, for the more safe, we do the safe procedures to play safe. Actually, to play safe, we should do the left main coronary intervention first. Thank you for your listening.
Thank you, Dr. Liu. We will discuss after this. Now, I would like to introduce the second speaker of today. The second speaker is Dr. Arthur. Dr. Arthur will talk about circulating biomarker for cardiotoxicity risk prediction in oncology preparation. He is from Chicago, Illinois. Dr. Arthur, please.
Thank you so much to the organizers for the opportunity to speak on this important topic. My topic is circulating biomarkers and cardiotoxicity risk prediction in oncology patients. My name is Nosheen Akhtar, and I am an associate professor of medicine and the director of cardio-oncology at the Northwestern Feinberg School of Medicine. This is an area of great interest and needs more attention. These are my disclosures. So let's first start by defining what a biomarker is. It is any characteristic that can be objectively measured and evaluated as an indicator of normal biologic process, pathogenic process, or pharmacologic response to intervention. Biomarkers are proposed as a method to improve risk prediction in identifying subclinical disease in patients at high risk for cardiotoxicity from cancer therapy. This definition is intentionally broad and not limited to circulating biomarkers, but they have been what are primarily studied due to rapid, low-cost measurements. Biomarkers are most useful when they are accurate, easy to measure, and provide useful information. There have actually only been approximately 50 studies looking at biomarkers in the cardio-oncology space. And there are several limitations to these studies. Most are of a small sample size. There are no standardization of time points and when biomarkers have been checked. Heterogeneous assays have been used with differing positive and normal thresholds. Many non-cardiotoxic causes can cause elevation in biomarkers in the oncology population that need to be considered. And most of our data is with troponin and BNP. Most of the studies have been done on anthracyclines and trastuzumab. And the primary outcome that has been studied has been change in LV ejection fraction. For this talk, we will be focusing on 3 primary cancer therapies: anthracyclines, trastuzumab, and immune checkpoint inhibitors. So let's dive into circulating biomarkers for anthracycline therapy. Anthracyclines have been around for many decades and are used as a backbone for many different cancer therapies. Most of this audience is well aware that anthracycline toxicity can occur from acute to chronic phases. The acute phase is much less common and occurs in less than 1% of patients, usually causes a transient reversible decrease in LV ejection fraction. The subacute phase is really within the first year post-treatment. This tends to be dose-related and can cause an irreversible decrease in cardiac function, progress to heart failure, if not identified early. And there is always that chronic late possibility that anthracycline has contributed to the cardiomyopathy. And this is generally triggered by a secondary insult. This can occur decades later. These stages probably represent a continuous spectrum of pathophysiology going from the acute reversible injury to chronic irreversible injury, with increasing doses of anthracycline combined with coexisting cardiac risk factors determining the rate of progression to cardiac dysfunction. Some well-known risk factors for anthracycline toxicity include cumulative dose exposure, method of administration, IV bolus administration, higher single dose, dose-dense therapy, a low baseline ejection fraction, older age, pre-existing cardiovascular disease, prior or concomitant radiation treatment, and concomitant other cardiotoxic agents. So let's quickly review the cardiac troponin complex and how biomarkers can assist us in risk prediction for anthracycline-related cardiotoxicity. The cardiac troponin is a component of the sarcomere, which is the contractile unit of the heart. It has isoforms I and T. When calcium binds to the T isoform, it moves and exposes the myosin binding sites, and then myosin binds and leads to contraction. The early work was done by Dr. Daniela Cardinelli, looking at cardiac troponin I and cardiotoxicity in patients who received high-dose chemotherapy. They checked cardiac troponin I 72 hours prior to every chemotherapy cycle. What they found was that those patients with elevated cardiac troponin I had a more significant decrease in LVEF within the first 1 to 3 months after treatment, and that this persisted between months 7 to 12. They also found that patients with a positive cardiac troponin were more likely to have an LVEF that dropped less than 50%, and only those with a positive troponin had heart failure. Of note, a higher positive threshold for troponin, so a serum troponin level greater than 0.4, was used in this study, as well as these patients underwent treatment with high-dose chemotherapy regimens. These two factors really set apart the study from subsequent studies which have been unable to consistently replicate this data. In a subsequent study, when comparing contemporary assays with a threshold of 0.08, Dr. Cardinale and colleagues again looked at 703 patients who received high-dose chemotherapy, and this time they checked a pre-chemotherapy troponin as well as a troponin post-treatment approximately 1 month later, and followed these patients for 3 years. They divided their patients into 3 groups: those that had a troponin negative that remained negative, those that had a positive troponin that then became negative, and those with a positive troponin that was persistently positive. As you can see, the patients with a normal troponin before and after treatment had a very low incidence. In fact, the incidence was 1% of cardiovascular events within the first 3 years of follow-up. Those patients with a high troponin, a troponin that was positive 1 month after the end of chemo, these patients were more likely to experience a decrease in LV ejection fraction and also had adverse cardiovascular events, including heart failure, arrhythmia, and cardiac mortality. So it's important to note that this pattern of a rise and fall in troponin, as opposed to a persistent elevation, may be able to differentiate acute versus chronic myocardial injury, which may also be useful in using troponin in studying risk prediction for cardiotoxicity of cancer therapy. Few studies have been done with cardiac troponin T assays with mixed results, and there's also limited data with highly sensitive troponin. In the PRADA study, they did a sub-study evaluating highly sensitive troponin and cardiac troponin T in patients who received epirubicin, high dose versus low dose, and they found that there was really no association between elevation in these troponin assays and change in LV ejection fraction. In terms of natriuretic peptides, both BNP and NT-proBNP have been used for diagnosis and prediction of heart failure. They mainly are triggered by wall stretch and congestion. The use of NPs to identify those patients who are at risk for anthracycline-induced cardiac toxicity is less clear than troponin, but may be of value in high-risk patients. In this prospective study of 109 patients who received a point-of-care biomarker, cardiac troponin I and BNP before and within 24 hours post-anthracycline-based chemo, they found a 10% rate of cardiac events, and that all patients had at least one elevation BNP greater than 100 prior to a cardiac event, but only 2 patients had elevation in cardiac troponin I. In the box plots, figure A is pre-chemotherapy and figure B is post-chemotherapy, with the shaded boxes representing the patients with that had the adverse cardiovascular events per cycle being more elevated. So the major consensus recommendation regarding generally support the use of cardiac troponin or natriuretic peptides to identify patients at increased risk for cardiotoxicity from anthracyclines. There are several novel biomarkers that are being evaluated, such as ADMA and MMA, which may play a role in endothelial dysfunction from doxorubicin, which can be a potential mechanism of cardiotoxicity. And we're also looking at other proteins and genetic markers and microRNA levels. So let's switch gears now and start discuss trastuzumab. The FDA approved adjuvant trastuzumab, or Herceptin, on November 16, 2006, and this was really a milestone in cancer treatment for HER2-positive breast cancer. Trastuzumab is a monoclonal antibody that targets the ERBB2 oncogene, a receptor tyrosine kinase in the ERBB family. It is overexpressed in about 15 to 30% of human breast cancer and is associated with increased tumor aggressiveness, early disease progression, and a high risk of relapse and death. This was the phase 3 clinical trial published in the New England Journal of Medicine in 2005, which demonstrated a 50% reduction in disease recurrence and a 33% improvement in survival. Trastuzumab cardiotoxicity largely presents as an asymptomatic decline in LV function. Clinical heart failure is less common. It is not related to a cumulative dose and is largely reversible. We also see that the probability of cardiotoxicity is higher in patients who receive sequential therapy with anthracycline followed by trastuzumab. Therefore, it's really hard to tease out the role of biomarkers with trastuzumab alone because studies have largely enrolled patients who have been on serial treatment with anthracycline followed by trastuzumab. This was a prospective multicenter study done on 78 patients with HER2-positive breast cancer undergoing treatment with doxorubicin followed by trastuzumab. They looked at a suite of 8 biomarkers, and the biomarkers were checked at baseline and every 3 months. The difference between the baseline and visit 2, which was at 3 months, was then evaluated for an interval change. They found that the greatest risk for cardiotoxicity was seen with ultrasensitive troponin and with MPO, or myeloperoxidase. MPO is being studied to identify cardiotoxicity risk due to its role in the innate immune response, generating reactive oxidant species. So both ultrasensitive troponin and MPO together provided additive benefit. And these investigators found that the probability for cardiotoxicity at 15 months was greatest when both biomarkers were elevated at 46.5%. Given the role of oxidative stress in anthracycline cardiotoxicity, these findings likely reflect more a role of anthracycline than of trastuzumab. These findings still require independent validation. In this next study, 323 patients with HER2 with breast cancer were evaluated, and these patients were treated with anthracycline. You can see down here in the figure, which is represented by the red line. The blue line represents the sequential treatment with doxorubicin followed by trastuzumab, and the green line represents trastuzumab. You can see here that no biomarkers predicted cardiotoxicity with trastuzumab alone, but with highly sensitive troponin, which is in panel A, when that was elevated greater than 14 at anthracycline completion, either with anthracycline treatment alone or in combination with trastuzumab, there was a greater than 2-fold increased risk of cancer therapy-related cardiac dysfunction. In panel B, we see that the NT-proBNP predicted a risk for patients who went on to develop cancer therapy-related cardiac dysfunction. And this was seen in those patients who received sequential treatment with anthracycline followed by trastuzumab. And what if we combined an imaging biomarker like global longitudinal strain with circulating biomarkers, such as an ultrasensitive troponin? And this question was looked at by Dr. Sawaya and colleagues in this prospective study of HER2-positive breast cancer patients, 81 patients who received sequential treatment with doxorubicin or epirubicin, followed by trastuzumab. And what they found was that the negative predictive value was 91% if a patient had a reduced troponin, an elevated troponin or a reduced global longitudinal strain. The data are generally less robust for a use of biomarkers and monitoring for patients with trastuzumab-related cardiotoxicity. Studies are done primarily with because these studies have done primarily with serial anthracyclines. Also, the newer HER2 therapies and non-anthracycline-based regimens have less cardiotoxicity, and the utility of biomarkers with these regimens require more study. So let's switch gears now and discuss immune checkpoint inhibitors. Immune checkpoint inhibitors are a new category of cancer therapy that was approved in 2014 that can cause multi-organ side effects and have been reported in a majority of patients. Myocarditis, however, is rare, but it can be fatal, which has raised alarm. In 2014, immune checkpoint inhibitors were approved only for 3 cancer indications: melanoma, lung, and renal. By 2020, the numbers increased to more than 50 cancer types, and the percentage of patients who are eligible for ICI treatment has increased from 1.5% to over 40% in the most recent era. The 3 immune pathways that are exploited by cancer cells are CTLA4, PD-1, and PD-L1. And so when we think about possible mechanism for ICI myocarditis, the ICI essentially unleash an immune response on both cancer and normal tissue that also has a shared antigen. So you can see here on the injured myocyte, a PD-L1 antigen. These antigens increase with injury, leading to the activated T cell attacking the myocyte, leading to an autoimmune T cell lymphocytic myocarditis. In a multi-center registry of 8 sites between 2013 to 2017, 35 patients with ICI myocarditis were compared to 105 patients without myocarditis. And what they found was that the median onset for ICI myocarditis, when it occurred early on, and most patients presented within the first 3 months of therapy. Nearly all of the cases had elevated troponin, and nearly all of the cases had abnormal ECGs. LVEF, interestingly, was normal in about half the patients. You can see here the breakdown of MACE in this registry, and that about 38% of patients with MACE had a normal LVEF. So I think this is where biomarkers can be very helpful. And they found that a final discharge troponin greater than or equal to 1.5 nanograms per milliliter was associated with a 4-fold increased risk of MACE. Some risk factors associated with ICI myocarditis include pre-existing cardiovascular disease, pre-existing autoimmune disease, and dual immunotherapy. Also important to note that the concurrent rates of myositis are approximately seen in approximately quarter of these patients. So we know that cardiac troponin T also has some cross-reactivity with skeletal muscle. Cardiac troponin I may be more specific for myocardial injury in these patients. What is the experience with troponin surveillance for ICI myocarditis? The group from Memorial Sloan Kettering published their experience in 76 asymptomatic patients with advanced melanoma on combination ICI therapy. They were screened with cardiac troponin I and ECG and found that 17% of patients had elevated cardiac troponin I, but none of those patients went on to develop myocarditis. In another study looking at 59 patients with non-small cell lung cancer treated with nivolumab, only 1 patient who had a sustained elevation in cardiac troponin I went on to have subclinical myocarditis. So is there a need for biomarker surveillance in patients on immune checkpoint inhibitors? Well, this is an area of hot debate in cardio-oncology, whether we should be using troponin surveillance and how often, because the incidence of myocarditis is so low, but it can be clinically very significant when found. This was a management algorithm proposed by Dr. Mosley and colleagues, and they suggest checking a baseline troponin and then a troponin after every cycle within that first 4 to 6 week period where we know there's the highest incidence of patients developing ICI myocarditis. What about highly sensitive troponin and ICI myocarditis? This research letter was published in JACC Cardio-Oncology looking at 214 patients. And they then separated patients based on troponin threshold of 55, highly sensitive troponin threshold of 55 and 24 patients, then went on to have a real-time cardio-oncology evaluation. Of that group, 3 patients were found to have ICI-associated myocarditis with a peak troponin range between 4,078 to 11,780. So they found that the number needed to treat with highly sensitive troponin was 72 patients to detect 1 case of myocarditis. In summary, for ICI and biomarkers, routine screening with troponin and BNP for detection of ICI myocarditis is not currently indicated. For high-risk patients, we checking a troponin at baseline and then weekly for the first 4 to 6 weeks may be helpful, and more data is needed on highly sensitive troponin for detection of ICI myocarditis. This is a very nice figure with a pragmatic approach to NPs and troponin, which was published in JACC Cardio-Oncology, as well as differential to consider in the oncology patient population that I'd like to refer you to if you haven't already read this. In summary, for a pre-treatment evaluation, a pre-chemotherapy biomarkers, troponin and NPs may both be useful in risk stratifying patients for cardiotoxicity and those who are treated with anthracycline-based regimens. During treatment, elevation in cardiac troponins and NPs, specifically cardiac troponin I's, may be useful in helping risk stratify patients for cardiotoxicity, again, in anthracycline-based regimens. Elevated troponin during ICI therapy may also have potential utility in identifying patients at risk for ICI myocarditis. And post-treatment, really pay attention to the pattern of the biomarkers. If there's a rise and fall pattern or persistent elevation post-anthracycline-based chemotherapy, and possibly with immunotherapy, that can help risk stratify patients for cardiotoxicity and myocarditis. Thank you again for this opportunity. I'm sending you all well wishes to stay safe and healthy in the next year.
Thanks, Dr. Arthur, for your very excellent presentation today. Now I would like to invite Dr. Vũ Quỳnh Nga to introduce Dr. Laurent Bandasar. Dr. Nga.
Thầy em không...
Thầy để thầy nói luôn ha. Okay, for the talk today, I would like to introduce Dr. Laurent Bandasar from Yen, Connecticut. Please show the CV of Dr. Laurent. Okay. The topic today of Dr. Bandasar is application of cardiac MRI in cardio-oncology, when, why, and how. She's from New Haven, Connecticut, USA, Yale School of Medicine. Dr. Bandasar, please.
Great. Good morning. Thank you so much to the organizers of this conference for the opportunity to speak with you today about the applications of cardiac MRI in cardio-oncology, when, why, and how. I have no relevant disclosures. This is just a slide here to list some of the many different types of cancer therapies that can lead potentially to cardiotoxicities. You just heard an excellent talk from our prior speaker about some of these major categories of drugs. And what's important to take from this slide is that these drugs can affect all different parts of the cardiovascular system. They can affect the myocardium, causing fibrosis, inflammation, the vasculature, etc. And so what's important to understand is that cardiac imaging and cardiac MRI in particular is very central to this practice for us in cardio-oncology. So today we're going to touch on some of the major components of the cardiac MRI clinical and emerging research techniques. We'll talk a bit about LV systolic function, preclinical LV dysfunction, briefly diastolic dysfunction or heart failure with preserved EF, vascular assessment, cardiac tumors, pericardial disease, immunotherapy, and very briefly talk about COVID-19. So first to LV systolic function. This is one of the, there's multiple different guideline documents. This is sort of one of the main documents that we refer to in cardio-oncology for monitoring of left ventricular ejection fraction, which is primarily recommended with 3D echocardiography, as well as strain, and then cardiac MRI when needed. And hopefully you'll hear from me today about all the different times when cardiac MRI is needed in cardio-oncology for assessment. The important concept to take home from this document is the definition of CTR-CD, or cancer therapeutics related cardiac dysfunction, which is a decrease in the LVEF of greater than 10% to a value of less than 53%. It's important to understand the correlation between the different cardiac imaging modalities. This is a study done in breast cancer patients. And what you can see here on the left is using cardiac MRI as the gold standard for LVEF. There's not great correlation between 2D echocardiography and MRI. In the middle, however, you can see that there's pretty good correlation between 3D echo and cardiac MRI. And on the right, again, you see nice correlation between nuclear MUGA scanning and cardiac MRI for EF assessment in this study. This is a study of adult survivors of childhood cancer that received prior anthracycline or chest radiation, and all these patients had a cardiac MRI and an echo within 2 days. And the important take home from here is what you can see in the gray box. And what that shows you is over 10% of patients that actually had an EF less than 50% by MRI were misclassified as greater than 50% by 2D echo in this study. This is not for us to read, but just to show you how we've implemented a multimodality cardiac imaging algorithm in our cardio-oncology program. And I've just highlighted here for you some of the different steps when we would go from echocardiography to obtaining a cardiac MRI in patients with cardiomyopathy or when a diagnostic echo cannot be obtained. And what's important to see is that we looked at our data after implementing cardiac MRI into this algorithm. And you can see here in early 2014, the green bar is the percent of MRI studies in our patients significantly increased over time as expected. And then interestingly, what you can see on the right is that even though echocardiography remained the mainstay of our imaging modalities, the use slightly decreased over time, and this was statistically significant, which I think demonstrated that rather than just overutilizing imaging studies, we were ideally picking the right study for the right patient at the right time. As we talk about MRI, I'll just remind you of the different tissue characterization cardiomyopathic scar patterns that one can see with late gadolinium enhancement. On the left, this is a coronary disease pattern as seen here with subendocardial scar or near transmural scar. On the right, a non-coronary disease pattern that you can see with mid-myocardial scar or with subepicardial scar. And this is just one study that looked at patients with trastuzumab-induced cardiomyopathy. And what they saw here was this lateral wall mid-myocardial scar. But these patterns really are not specific, rather than telling us that it's a non-ischemic pattern. So shifting gears a bit to preclinical left ventricular dysfunction. So why is this important? We know that the earlier we get heart failure therapies on board, the better patients do. What you can see on the left in the yellow line is patients with trastuzumab-associated cardiomyopathy had worse survival than those without the cardiomyopathy. But importantly, what you see on the right is in those with no recovery in the yellow line, that recovery decreased over time and survival decreased over time, the longer that it was until initiation of heart failure therapies. So we really need more sensitive techniques to detect preclinical LV dysfunction and get therapies on board earlier. One way we can do this is with echocardiography to look at strain, looking at the myocardial deformation assessment. There are a lot of variabilities, however, that pose some challenges, such as differences in vendors and software, differences with loading conditions, and gender and age. However, this does show some promise in the field, and this is just an example here of tracking of global longitudinal strain in a patient. We won't go through these studies. It's just to show you that there's been a fair amount of heterogeneity in the cardio-oncology strain literature. However, in general, it has been decided that approximately -19 for global longitudinal strain is a normal cutoff point, and that reductions in greater than 15% are now seen in the guidelines for CTR-CD. And so I'll just bring your attention back to that guideline we were looking at earlier, which looked at LVEF, but also utilizes drop as greater than 15% for global longitudinal strain to detect cancer therapeutic related cardiac dysfunction. And this is just one recent study that came out, the SOCOR study, which looked at a global longitudinal strain guided therapy versus EF guided. There was, as highlighted in the pink bar here, a small decrease or small difference in the EFs in the patients, but it was just shy of reaching statistical significance. So I think there's still some data that to be obtained in this field. But it's important to understand that you can do strain by cardiac MRI as well, as seen here. And this is called tissue or feature tracking strain, similar to speckle tracking with echo, but with higher resolution images and more points for tracking. Other strain techniques by cardiac MR can be obtained as tagging, seen here on the left, and signal encoded imaging, as seen here on the right, which takes advantage of the difference between low and high tuning contractile tissue. These techniques may be more robust, but they do require dedicated sequence and more complex post-processing. One other technique is T1 mapping. What you see here is a series of images obtained. Then a pixel-wide curve fitting is applied to create a T1 map. You can see this color map here on a pixel by pixel basis of the myocardium. One can then put a region of interest in the myocardium or potentially measure the entire myocardium to then get these dedicated T1 values. So this T1 mapping has been validated now in myocardial infarction, as you can see here on the top panel. It's also been validated in amyloidosis and also in other non-ischemic cardiomyopathies, as seen here on the right, with the correlative late gadolinium enhancement images. This has been applied in cardio-oncology, where T1 mapping with MRI has been shown in a doxorubicin rat model to correspond to dysfunction on histology and actually to predict future events in this model. This has also been looked at in a patient population where it was shown that anthracycline dose correlated to extracellular volume as obtained by T1 mapping values, which also correlated to decreased peak VO2 max in these patients who had received anthracycline. There are still some limitations in T1 mapping, similar to strain as far as availability and standardization of protocols and need for more data on outcomes. This is one example of left ventricular mass assessment by cardiac MRI has been shown to correlate with anthracycline dose as far as loss of LV mass. And what you see here on the right is actually that LV mass has been predictive of major adverse cardiovascular events in patients who've received anthracycline. I'll just briefly touch on heart failure with preserved EF assessment. You can see here a thick ventricle with normal contractile function. On the right, this is the delayed enhancement image, which has a classic diffuse subendocardial hyperenhancement, as seen here. And this is classic for amyloidosis. This is another patient with concern for amyloidosis, but this patient was on dialysis and could not receive gadolinium enhancement at this time. So in this patient, we did that T1 mapping that we discussed, but non-contrast, so native T1 mapping, and put a region of interest here in the myocardial septum. And the values that we derived fit here, which according to this study are correlative with definitive cardiac involvement. So this is a nice sensitive way to pick up and do assessment of amyloid without the need for contrast. In this particular patient, we followed them over time with treatment, and you can see in the bar here that the T1 values decreased over time with treatment of the patient. What we showed here was that as those T1 values decreased, that decreased correlated with decreased LV mass, decreased BNP levels, as well as decreased kappa to lambda light chain ratios. We also, moving now to vascular assessment, we know that multiple different therapies can affect the vasculature from oxidative stress to endothelial dysfunction and via many other pathways. One way to assess is this via stress perfusion MRI. This test has no radiation and gives you structure, function, ischemia, and scar assessment in one test. And this is just a typical protocol of a Cine MRI, stress MRI, where we do Cine MRI, stress perfusion. You can do rest perfusion if you'd like, or you can skip it because you have viability assessment with delayed enhancement, all in under an hour. This is one of the major trials looking at cardiac MRI versus SPECT using invasive angiography as the gold standard. This is the CMARC trial. And what you can see here in the blue line is that stress cardiac MRI outperforms SPECT in both single and multi-vessel disease, as shown in these 4 panels. Importantly, as shown in a predefined secondary analysis of the CMARC trial, this is a very sensitive technique for detection of obstructive coronary disease in women. So again, blue line with cardiac MRI and the red line with SPECT. And this showed a sensitivity of almost 90% in women. We looked at a small cohort of patients with breast cancer who had received therapies and who developed a cardiomyopathy. We looked at assessment of microvascular dysfunction by looking at subepicardial to subendocardial ratios, which we found did correlate with the LVEF in these patients. And even though EF did recover over time, the GLS remained low at -15. And interestingly, a few of these patients did actually have ischemic scar, as shown in this patient here with an inferior MI, even though they had no known prior history of MI. This is just a case example here of one of our breast cancer patients, a 44-year-old with a new drop in EF on trastuzumab, aortic regurgitation that was difficult to quantify in echo, and the need to rule out ischemic heart disease as she was awaiting breast surgery. You can see here that the left ventricle is dilated and the function is somewhat down. You can see here with the arrow, this aortic regurgitation jet. We then use phase contrast imaging to put a region of interest over the aorta, and that gave us a regurgitant fraction of 11%. So we were able to quantify this in the mild range. We then performed stress vasodilatory perfusion MR, and you can see here on the left, this is first pass perfusion as the contrast comes in first to the RV and then to the LV. And on these short axis slices, you can see that there's uniform perfusion of the myocardium, showing no perfusion defects and no evidence of ischemia. On the right, we had a small little mid-myocardial scar, which has been seen in patients with trastuzumab cardiomyopathy. Now, a bit about cardiac tumors. We know that cardiac MRI is good for assessment of cardiac tumors, specifically in cardio-oncology. There's often a question following up the echo, is there really even a mass there? What about tumor versus thrombus? Sometimes we see port-associated thrombi. Distinguishing between primary tumors that are malignant versus benign is important, and then assessment of metastatic disease as well. This is one case here of a 47-year-old with breast cancer who presented with an acute ischemic stroke. The echo was very difficult to visualize the apex, and so an MRI was obtained. You can see that there's a mass here in the apex with a kind of component here that looks a little bit mobile. We did perfusion of the mass here, which did have some uptake. But importantly, you can see here this post-contrast cine that this more apical portion of the mass has a similar uptake to the myocardium, but that there's this mobile component at the top that's not taking up as much contrast. What we did here was in the bottom left is we use a dedicated thrombus imaging. It's a long inversion time MRI. And what that showed was, again, that this part of the tumor was more consistent with uptake in the myocardium, showing some gadolinium uptake, but that this tip here did not take up contrast, and that's more consistent with thrombus. So here we diagnosed a tumor with an associated thrombus. And just to highlight that here in the bottom right, this is standard delayed enhancement image where it's difficult to have tissue characterization of the two components of the tumor and the thrombus. So important to do that dedicated thrombus imaging. We can also visualize well the pericardium. What you see here at the arrow is a very thickened and pericardium with delayed enhancement of the visceral pericardium here, as well as the parietal pericardium. And we can see this with radiation therapy and some other therapies as well. This could lead to constrictive physiology in some patients. And this is real-time CMR imaging here with deep inspiratory maneuver. You can see that with deep inspiration, the diaphragm pushes down, and you can see this flattening here of the interventricular septum, which is demonstrating ventricular interdependence and constrictive physiology in this case. I'd like to touch now on immunotherapy. Dr. Akhtar, the prior speaker, did a wonderful job of explaining this to you, so I won't go in detail in these slides, and I'll just repeat what she said, which is that these therapies do affect the programmed cell death 1 protein pathway, and that this can essentially rev up the immune system as it blocks its normal checks and balances, and which can lead to autoimmunity. It's important, however, to understand that these therapies are really improving survival in patients. This is a study of non-small cell lung cancer. And in the blue line, these are patients treated with pembrolizumab. And you can see the significant increase in survival compared to those not treated with that therapy. This is not for you to read, but just for you to see that there are multiple different types of these immune checkpoint inhibitors that have already been FDA approved for many different cancers. And very impressively, you can see here, there's currently over 4,000 clinical trials utilizing these agents. And what the bar graphs show here with the colors is that these are being used in combination with other therapies that are known to have cardiotoxic side effects. So this is of great importance for us in the field of cardio-oncology. And as we discussed, these can cause autoimmunity and inflammation in pretty much any organ of the body. And of course, we're concerned about the cardiac portion, which of those fatal immune-related adverse events composes about 10%. And this is just some of the ways this can manifest, as the previous speaker described to you, with a T-cell infiltrative autoimmune-like myocarditis. This can have significant arrhythmias, can cause heart block. And we're learning now more about potentially atherosclerotic plaque rupture and acute MI, as well as Takotsubo presentation. So we know that cardiac MRI is the primary imaging tool for the diagnosis of clinical myocarditis. We apply the Lake Louise criteria, which looks at two tissue characterization criteria of T2 weighted, looking at edema and inflammation, as well as T1 weighted imaging, such as late gadolinium enhancement or extracellular volume as obtained from pre and post contrast T1 mapping. The recent updates have included these mapping techniques, T1 mapping, as you can see here, T2 mapping, and then on the right, this extracellular volume map that we can create from pre and post contrast T1 images. So the prior speaker went over this, some of this data with you. This is also an additional more recent study that looked at patients with immune checkpoint inhibitor associated myocarditis. This was a real world study where they used the clinical reports at each site rather than a core lab, and used qualitative LGE and T2 assessment This study showed that less than half had late gadolinium enhancement. And as you can see here on the right, this was not associated with major adverse cardiovascular events. And only a third had qualitatively abnormal T2-weighted imaging. So this is an important study. And I think what it demonstrated for us was that qualitative MRI assessment may be limited and future study with more quantitative techniques is needed. And this is our institution study here, where we looked at patients with ICI myocarditis. You can see in the bar graph that time to presentation was variable, and in the pie chart here that the presenting symptom also was very variable. We looked at quantitative assessment of percent LGE as seen here, as well as global longitudinal strain by feature tracking. We also looked at quantitative T2 ratios of the muscle to the skeletal muscle, of the myocardium to the skeletal muscle. And what we showed was that 85% met at least one criteria for myocarditis with this type of analysis. The overall LGE was just under 10% of the myocardium, and the average global longitudinal strain was decreased around -10. This is an example of positive T2 imaging on the top, and then some mid-myocardial delayed enhancement here. This would be a classic myocarditis case. This is showing how T2 mapping in the middle is much more sensitive to assess this area of increased edema and inflammation, which correlates on the right here with delayed enhancement. On the left with traditional T2 and qualitative assessment, you can see how that could be missed. And this is the feature tracking strain that we use in these patients, which again showed a low strain assessment, both in those with preserved EF, which in our sample was again, half of the patients had a normal EF. So echo alone is not sufficient for assessment in these patients. We really need MRI. And this is one of our cases that did have an acute MI, which you can see here, a transmural scar and some increased T2. This was a patient who presented with myocarditis. You can see very thickened pericardium and delayed enhancement of the pericardium. And this is just to highlight how we're learning more about increased myocardial infarction as seen in the red bar here after patients went on immunotherapy. So we're learning more about this in addition to myocarditis. And this is just a case that had tumor infiltration and developed a myocarditis from that while on immune therapy. One of our cases here where we took samples as correlated with delayed enhancement on the MRI from autopsy. And what we showed was that this delayed enhancement did directly correlate with increased T cells as well as fibrosis in this case. And this is just a recent pilot study using that more advanced strain, SANK, which looked at percent of dysfunctional segments as seen in red in immunotherapy patients, was significantly increased in those with myocarditis compared to controls. And those patients all had preserved EF. And this here is just to highlight that it's not just about immune checkpoint inhibitors, that other immunotherapies can cause myocarditis. This is a patient on mogamulizumab, which is a CCR4 inhibitor of T cells. And you can see the MRI images here are very similar to what you saw with the checkpoint inhibitors as far as myocarditis. And I'm lastly just going to make one small comment about COVID-19. There's multiple documents that have given some guidance to modifications to EF surveillance during the pandemic. And I'm just going to highlight one here from our ACC Council for your reference. And lastly, a case just sort of highlighting that of a patient with breast cancer who received anthracycline, also trastuzumab, but also had a recent COVID illness. And she actually didn't come in for her routine assessment and monitoring because of the height of the pandemic. And at the time she came to us, she had a cardiomyopathy and her MRI showed increased T2 signal as well as some delayed enhancement in the lateral wall. And it was kind of difficult for us to figure out, was this from her cancer therapy or was it from COVID-19? So that just kind of makes things a little bit more complicated. I'd like to lastly make a plug for our Society of Cardiac MRI Cardio-Oncology Special Interest Group. You can follow us on Twitter or you can email me if you're interested in getting involved with our group. And I'd just like to acknowledge my colleagues at my institution and MRI, Cardio-Oncology, MRI Research Center, and our Translational Research Imaging Center. And I'm happy to take any questions and feel free to email me as well.
Thanks, Dr. Badaksa, for your very excellent talk today. Now we have 5 minutes for question and answer. There is one question. One question. If the index of suspicion coronary artery disease increase, especially in patients over 50 years old, what imaging modality should be first priority? I would like to ask Dr. Laurent for this. Can you answer this question?
This is an excellent question, and I didn't have time, today to go through it, but we do, in the vast majority, if not all of our patients who present with concern of myocarditis, do an ischemic workup as well. We've had multiple patients that have had a concomitant myocarditis and ischemia, and we've demonstrated that with coronary CTA is what we use as a initial non-invasive workup. We pair that with FFR CT when indicated to evaluate the hemodynamic significance of lesions, and then we will send the patient for cardiac cath if indicated. So that is a part of our workup. We usually would get a cardiac MRI and a coronary CTA in these patients.
Dr. Akhtar, can you answer the third question? How to unify diagnostic threshold of biomarker and EF between oncology and cardiology department? Dr. Akhtar, are you there? No, Dr. Akhtar. So for the second question, can it potential for reversibility if 2D echo determine reduced EF in oncologic patients with chemotherapy? How about EF reduced 3D echo and CMR? Dr. Laurent, can you answer it?
Sure. I think the question is asking about, sorry, I didn't realize, if it, I think they're asking about if it can be reversible, the decrease in the LVEF, specifically comparing, asking about 2D, and then what about 3D and MRI. So I think what the question is sort of getting at is probably how do you, because there's different kind of accuracy and reproducibility of these different techniques, and how do you kind of handle that in patients, right? If you what if you got a 2D and it showed a decrease in the EF, what do you do next? It's all case by case, but in general, if we have a 2D, well, first of all, what I'll say is if we have a drop in an EF, whether it be via 2D or 3D, we're going to get a cardiac MRI in that patient for assessment of a cardiomyopathy. If it's a 2D echo and because a 3D echo could not be obtained, that would be the case in our scenario at our institution. We will get a cardiac MRI to validate that drop in EF. If you're looking, just for the EF assessment, you could do a non-contrast cardiac MRI because you don't need contrast for the EF assessment. But if you want to do the concomitant cardiomyopathy workup with bleed enhancement, obviously you'd have to give contrast. But the variability of 2D echo can be up to 10%. So it can be difficult to rely on that for drops in EF when 10% is what's clinically significant. If it's a 2D echo and we have a very normal EF, like 68%, and we look at the images and it looks okay, usually I don't do an MRI in that patient. Usually I feel comfortable in that patient, but again, ideally 3D and strain is nice to have.
Okay, thank you. Very, very good answer. Any question from the audience? Okay, I think that Dr. Nga would like to talk something. Dr. Quỳnh Nga. Okay, I think that today we have three talks. I am very pleased with our speaker, especially Professor Bandaksaka, for your very helpful talk about cardiac MRI. I think that in our country, it is not very developed about cardiac MRI, but we need to study more about it. Okay, thank you very much
Thank
for
you so
talking with
much.
us.
Take
Thank you.
care.
Okay. Chào Nga nhé, chào Nga.
Thầy ạ.
At Viatris, we aim to empower people worldwide to live healthier at every stage of life. We're dedicated to delivering increased access to the medicines patients need, regardless of geography or circumstance. Because at Viatris, we believe in healthcare, not as it is, but as it should be.
Recording in progress.
Hello everyone. My name is Twine. I'm from BSM 20 and 21. I will be here for support and during the sessions, I will mute myself. So just start with me if you need any help for support. BSM 20 and 21.
See, it looks like I need to switch it.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách, nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
giá như tôi được chẩn đoán bệnh tăng huyết áp sớm hơn và giá như tôi tuân thủ sự điều trị của bác sĩ tốt hơn thì tôi sẽ không bị biến chứng như vậy.
Hearts struggling to keep pace, gaining momentum at all cost, pushing boundaries, further and beyond. We are in overdrive. Time to take control.
Good morning in Vietnam and good evening in the USA. Welcome to the Joint Symposium of the American Society of Echocardiography and the Vietnamese Society of Echocardiography. I am Dr. Hoài Nguyễn from National Heart Institute in Bạch Mai Hospital. I am very honored to introduce our chairperson, Professor James Kirkpatrick, our dear friend, our dear professor and teacher who has had a great effort in medical education in Vietnam for many years. Professor James Kirkpatrick is a professor of medicine and cardiology and bioethics and humanities. He is also a section chief of cardiovascular imaging and the director of echocardiography laboratory in the University of Washington Medical Center. And he is also the chair of ethics committee of the University of Washington Medical Center. Dear Professor James Kirkpatrick and our distinguished guests from the ASE, this year in South Vietnam and in many parts of the world, we have experienced lots of challenges due to the COVID-19 pandemic, which have caused limitation of approach to in-person education and training opportunities. However, we are not left behind. Today, we are deeply moved by the presence of Professor James Kirkpatrick and the excellent speakers from ASE who will bring wonderful knowledge and updates in echocardiography to our Vietnamese cardiologists and physicians and echocardiographers. I would like to invite Professor James Kirkpatrick to chair the session.
Thank you so much, Dr. Hoài. I am so honored to be here. It is truly a pleasure to work with all of our wonderful colleagues in Vietnam. And the Vietnam Heart Association Congress is a highlight of the calendar for me and for many of us in the American Society of Echocardiography who cherish our opportunities to partner with you in education and research and clinical care. We're so sorry that we cannot be there in person because it is such a wonderful thing to travel to Vietnam. And I will have to assure all of our speakers from the United States that someday we will have the opportunity to introduce them all to you in person. But for now, I am very happy that we have the opportunity to participate in this session virtually and to hopefully engender discussion about many of the different things that we will be talking about today. Our first speaker is going to be Dr. Gary Huang, and he is going to talk about cardiac stress testing, particularly where do we stand in 2021. Dr. Huang is an assistant professor of clinical medicine at the University of Washington. He is the Echo Lab director at Harborview Medical Center in Seattle, where he does a wonderful job, particularly caring for some of the patients who are the most challenged in our area. Dr. Huang is a multimodality imager. He has experience not only in echocardiography, but also in other modalities, including computed tomography and nuclear scanning as well. It's wonderful to have him participating in this Congress. Welcome, Dr. Huang.
They would get a history, clinical examination, ECG, and cardiac biomarkers. If the patient has definite diagnosis of acute coronary syndrome, for example, an ST elevation myocardial infarction, then they would be admitted to the hospital for further testing and management. If the patients have low risk for Hi everyone, my name is Gary Huang, and I'll be talking today about cardiac stress testing. Where do we stand in 2021? So the various types of cardiac stress testing include exercise treadmill ECG, nuclear stress test, including single photon emission computed tomography or SPECT imaging, and positron emission tomography, or PET imaging. And we also have stress echocardiography. The indications for stress testing include the primary use of the diagnosis, exclusion, or evaluation of obstructive coronary artery disease, and for the management of established coronary artery disease. The contraindications to stress testing include acute myocardial infarction within 2 days, high-risk unstable angina, uncontrolled cardiac arrhythmia with hemodynamic compromise, patients with active endocarditis, symptomatic severe aortic stenosis, patients who have heart failure that's decompensated, acute pulmonary embolism, myocarditis or pericarditis, and patients who have physical disability that compromises safety. So for example, patients who cannot follow directions. So this is an example of a chest pain pathway in the emergency department in Europe. And so if a patient comes into the emergency department with chest pain and suspicion for acute coronary syndrome, they would get a history, clinical examination, ECG, and cardiac biomarkers. If the patient has definite diagnosis of acute coronary syndrome, for example, an ST elevation myocardial infarction, then they would be admitted to the hospital for further testing and management. If the patients have low risk for coronary artery disease, so for example, no objective evidence of ischemia and they're stable, then they would be admitted to the chest pain unit, which is an observational unit in the emergency department, where they would undergo an accelerated diagnostic protocol with serial ECGs, cardiac biomarkers, echocardiography, stress test, and chest imaging. If these tests are abnormal, then they would be admitted to the hospital and undergo further diagnosis and management. If these tests are normal, then the patient would be discharged early. The question that one would have, and that I'll be talking about today, is which stress test to choose and whether or not it would involve imaging or not. So the first stress test modality that I'll talk about is exercise treadmill ECG. And this is just a picture showing a patient walking on the treadmill, undergoing this test with electrodes on his chest. And you have the nurse acquiring vital signs and either the ECG technician or physician evaluating the ECG. The pros are it's a relatively easy and inexpensive test and no radiation is involved. The cons are not all patients can exercise, and patients who cannot exercise cannot undergo this test. And the patients must also have normal resting ECGs. One of the negatives of exercise stress ECG is the mediocre sensitivity and specificity of this test. So this table is from the exercise stress test guidelines in 2002. And it includes meta-analyses of exercise testing. And in this meta-analysis of standard exercise test, the sensitivity is only 68%, specificity is a bit higher at 77%, but the predictive accuracy is only 73%. So quite low. Regardless of the patient is on digoxin or not, if they have left ventricular hypertrophy or baseline ST changes, it's still quite low in terms of predictive accuracy. And that's why we often do stress testing with imaging modalities. And the first I'll talk about is nuclear stress testing. So nuclear stress testing involves evaluation of cardiac perfusion at rest and during exercise or with pharmacologic stress. And in this scenario, you're administering a radioactive perfusion tracer, after which the heart will emit gamma photons that's picked up by the SPECT or PET camera. And nuclear stress testing is based on this concept illustrated here. So this tube depicts a coronary artery, and this arrow is indicative of flow across the coronary artery. And in a normal patient at rest, you have a certain amount of blood flow and perfusion. And with stress, because you vasodilate and there's increased demand, you increase flow to about 3 or 4 times that of rest. However, in a patient with coronary artery stenosis, the coronary vasculature is already maximally vasodilated at rest. And so with stress, there's no coronary flow reserve. And basically, nuclear stress testing picks up this differential. In a normal coronary artery vasculature, you have increase in flow. In a stenotic vessel, you don't. And this difference is what you evaluate with this test. So there's a picture showing the technician or physician injecting the patient with a radioactive isotope. And this illustration shows what happens after that. So the heart emits gamma photons, again, correlates with the amount of perfusion or flow in the coronary vasculature. And these gamma photons are picked up by a SPECT or PET camera. And this information goes into a computer. And then after further analysis, you have a digital image of the heart. And so this is an example of a patient with normal perfusion and normal coronary arteries. And in a patient with normal perfusion, you have basically a donut-shaped heart here, in which all of the areas of the heart, the anterior wall, septum, lateral wall, and inferior wall, are well perfused. And even in the horizontal long axis view, in the septum here and lateral wall and the apex, again, good perfusion. And the vertical long axis, you have the anterior wall, inferior wall, and apex, all of which are well perfused. And here you have a polar map, which is basically a comparison of perfusion in our patient with normal patients. And again, it shows good perfusion. So in contrast with stress echocardiography, you're evaluating cardiac function at rest and during exercise or pharmacologic stress. With stress echo, you're detecting coronary artery disease by provoking ischemia with resulting wall motion abnormalities. So again, instead of perfusion and looking at flow across the coronary arteries, you're evaluating the downstream effect and wall motion abnormalities as a result of ischemia. And this is just a picture showing the personnel and equipment involved in this procedure. So you have an ECG tech evaluating the ECGs, while the nurse is administering medications, for example. And then you have the cardiac sonographer acquiring the echo images. This is an example of a stress echocardiogram that's done at the University of Washington. And this is an apical 4-chamber view in which we're looking at the septum of the left ventricle, lateral wall, and the apex. And this is at rest, and this is at mid-stress. This is at peak stress. This patient is getting dobutamine. So we're giving higher and higher doses of dobutamine, and then recovery. You can see that at rest, the walls are moving normally, normal contraction, and normal ejection fraction. With increasing doses of dobutamine, you can see that there's normal regional and global augmentation of wall motion, which again shows a normal stress echocardiogram. In the recovery, the augmentation is less apparent. So some factors to consider when acquiring a stress test. is 1, what's the pretest probability of ischemia? 2, can the patient exercise? And 3, is the resting ECG normal or not? Some other factors to consider are the clinical indication for the stress test, what the patient's body habitus is. Does the patient have known CAD or prior revascularization? What's the site expertise and the patient preference? And the features of chest pain are important to determine pretest probability. And there's three features of chest pain that we should be evaluating. Is the chest pain substernal or not? Is the chest pain provoked by exertion or emotional stress? And is the chest pain relieved by rest and or the administration of nitroglycerin? If 3 out of these 3 features are met, then it's likely cardiac chest pain. It's possibly cardiac if only 2 out of these 3 features are met, and non-cardiac if 1 or fewer than each of these features are met. So this terminology of cardiac chest pain and possible cardiac chest pain is different from the previous use, in which we're using the terms typical and atypical to make it more straightforward. And so what other factors are involved in pretest probability assessment? They include history, patient's risk factors, and ECG findings at baseline. The patients are determined to be at low risk for coronary artery disease if they have less than 10% pretest probability of CAD. And these patients typically have an absence of risk factors, so they're usually younger, they have normal cholesterol, normal blood pressures, no diabetes, and they don't smoke. The patients also have more atypical or non-cardiac symptoms. They're at intermediate risk, or 10 to 90% pretest probability of CAD. And in these patients, we would obtain a stress test, which I'll talk about the reason for that later. And the patients are at high risk if they have greater than 90% pretest probability of CAD. And these patients oftentimes have risk factors and have either typical or probable angina. So again, stress testing is most useful in patients at intermediate pretest probability because of what I'm going to show, which is a graph depicting Bayes' theorem. And in this illustration, pretest probability is on the x-axis and post-test probability is on the y-axis. And this green line up here is if you have a positive stress test result. This line down here is if you have a negative stress test result. And as you can see in patients at very high pretest probability, greater than 90%, a positive or negative stress test won't change the post-test probability very much. And so these patients should just undergo an invasive coronary angiogram because they're very certain to have some degree of coronary artery disease. Whereas in these patients who are at low pretest probability, in similar fashion, a positive or negative result of the stress test won't change the post-test probability much, and they likely don't have coronary artery disease. If they're young, female, no other risk factors, getting any test would not be useful. Whereas in this intermediate pretest probability area, so if a patient has a 50% pretest probability, a positive test will increase the post-test probability by more than 20%, for example, and negative test will decrease the post-test probability by a similar amount. So again, that's why stress testing is most importantly and most useful in patients at intermediate pretest probability. So another question is the baseline ECG normal or abnormal? And this patient has a baseline ECG showing ST depressions kind of diffusely and T wave inversions. This patient has a left bundle branch block at baseline, perhaps LVH as well. This patient has left bundle branch block. This patient has pace rhythm, ventricular pace, and this patient has an irregular rhythm with ST changes again at baseline. And in these patients, a exercise stress ECG is not sufficient, and you have to do stress testing with imaging modality such as nuclear or stress echocardiography. So the key points are stress testing should be obtained in patients at intermediate risk and in patients who can exercise with an interpretable ECG. Then an exercise ECG is sufficient. Or if you want a more accurate test, you can do an exercise imaging test with nuclear or echocardiography or coronary CTA, which I won't really discuss in today's talk. If a patient can exercise and their ECG is not interpretable, then you have to do exercise with imaging or get a coronary CTA. If the patient cannot exercise at all, then the patient has to undergo a pharmacologic imaging test and not do exercise, obviously, or they get a coronary CTA. So some of the advantages of nuclear stress testing are you can do it either with exercise or pharmacologic. It's a very accurate test for determining coronary artery disease and prognosis. You can even use it to assess left ventricular size and systolic function. And you can quantify the percentage of ischemic myocardium and assess myocardial viability. Some disadvantages are you are exposing the patient to radiation when you're injecting them with radioactive isotopes. If a patient is of larger body habitus, you can have attenuation artifacts, and it tends to be more costly than stress echocardiography. It also requires a longer time commitment and additional equipment and personnel. With stress echocardiography, again, you can do it either with exercise or pharmacologic. The sensitivity and specificity are comparable to nuclear stress testing. It does not involve radiation, which is a huge advantage. And it's typically a lower cost than nuclear stress testing. And in addition to left ventricular chamber size and function, you can also assess wall thickness and valvular function with stress echo. This modality is dependent on body habitus. In larger patients, the image may not be as crisp and clear. And in patients with arrhythmias or rapid heart rate recovery with stress, it may limit the accuracy of the test. And in patients with resting wall motion abnormalities, so patients with prior myocardial infarctions, it may not be easy to interpret. And again, it also requires additional equipment and personnel. So this figure basically just shows the difference in sensitivity and specificity of stress echo and nuclear stress testing. You can see that nuclear stress testing has higher sensitivity and stress echo has higher specificity typically. And the reason is because of the ischemic cascade. So this x-axis is time from onset of ischemia. And the first thing that happens when you have ischemia is you have a reduced perfusion to the heart, followed by diastolic dysfunction, and then systolic dysfunction, followed by ECG changes, and then angina. But the first thing that you would detect is actually reduced perfusion, which you can find on nuclear imaging. And only down the line do you see systolic dysfunction, which you pick up with stress echo. So nuclear is more sensitive because it's picks up ischemia earlier in the ischemic cascade, and stress echo picks it up later. It's more specific, but less sensitive. And another nuclear stress test modality is PET imaging, or positron emission tomography. And this is a patient with normal coronary arteries based on a left heart catheterization. And because of this patient's large body habitus and attenuation, with SPECT, you have this, it shows reduced perfusion in the inferior walls concerning for either infarct or ischemia. But with PET imaging, it shows a normal coronary artery distribution, which reflects the normal coronary arteries of the patient. So it's a better test overall. It involves higher energy radio tracers with short half-lives, and so image quality is superior. It's also lower radiation and also a faster test. You have higher spatial, temporal, and contrast resolution, and you have built-in attenuation correction for patients with large body habitus. So, indications are patients who are obese in whom you need a better test, and in younger patients in whom you don't want to expose them to as much radiation, PET imaging is ideal. Some limitations are it is high in cost, and similarly, it's you have limited availability, so not every center has access to PET. And just a comparison of the accuracy of PET compared to stress echo and SPECT. PET imaging has higher sensitivity and specificity than both. And this just shows in scans, percentage of scans graded excellent in quality, PET has a much higher percentage of good image quality compared to SPECT. All right, so some take-home points. The most common stress test modalities include 1, exercise treadmill ECG, 2, nuclear stress test, and 3, stress echocardiography. Each stress test modality has their own indications and characteristics, so the physician must tailor the decision of which stress test modality to proceed with to the individual patient. That's all I have. Thank you very much. My name, Gary Huang. My email address, garysh@uw.edu. You can follow me on Twitter at Gary S. Huang. Thank you again.
Excellent job, Gary. That is a fabulous overview of stress testing. I hope everybody got a good sense of the different modalities, the strengths and weaknesses of each one. Next up, we're going to hear from Dr. Michael Lanspa. Dr. Lanspa is an associate professor at the University of Utah and Intermountain Health in Utah. He is one of the experts in the United States and really in the world in critical care echocardiography. By training, he is pulmonary and critical care specialist, but he has spent many years both writing and publishing research, and especially in lecturing and teaching on the topic of how echocardiography is used in the critical care setting. We are very, very grateful to have him participating in this Congress and sharing his insights on this growing and important topic. So thank you so much, Michael. We really appreciate you being here.
All right, thank you, Dr. Kirkpatrick. And I am so thrilled to be here talking to you guys about emerging role of echocardiography in the ICU. This is a topic that is very dear to me. And so we'll be talking about a couple of things, but before I start, just want to make sure that everyone understands I have no commercial conflicts of interest that are relevant to this presentation, although I have some intellectual biases in that I teach ultrasound and echo, and I have received research support in critical care echocardiography. So what is critical care echocardiography? I'm going to start by comparing this to standard echocardiography. Standard echo is typically a comprehensive study, whereas critical care echo is typically goal-directed. We try to answer specific questions like, does this person have tamponade? Or is this person got hemodynamic compromise that is reversible to fluid? Standard echo tries to get a comprehensive picture of cardiac function. And while that's not necessarily ignored by critical care echo, the main emphasis for function is more on hemodynamics. Standard echo tries to do a summative exam, trying to get a comprehensive picture of what the patient is like at baseline or at their normal state, whereas critical care echo tries to emphasize serial exams. We will do a very brief limited ultrasound or echo and then do a change and see what happens. If I add epinephrine, what happens after that? Does the cardiac function improve? And again, subtle pathology is what we're really looking for with standard echo, but for most critical care echo, most of the stuff that we really care about is severe. There are a lot of different applications of critical care echo. but the ones I'm going to be focusing on are probably going to be these last two: fluid responsiveness and guidance of mechanical ventilation. And the reason for that is I presume that most of the audience here, being most likely cardiology and echocardiographer heavy, will be very familiar with how to treat or diagnose shock states and be very familiar with left ventricular filling pressures. And so I thought I would emphasize a few of the topics that are a little bit more evolving or emerging in the ICU. So let's talk about fluid responsiveness. I'm sure many of you are familiar with this curve. This is the Frank-Starling curve. And we can see here on the steep part of the curve, this is a person who has a fairly volume responsive state. And this is for a given amount of right atrial pressure or central venous pressure. They have a big change in cardiac output when I increase that right atrial pressure or if I give some fluid. Contrast that to the flat part of the Frank-Starling curve where a person's unresponsive. So for a lot of patients in shock, we really want to get them resuscitated up to about this inflection point, but not any further, because any additional increase in right atrial pressure offers very little to no improvement in cardiac output, with all the harms of excess pulmonary vascular hypertension or right atrial pressure congestion. The problem with looking at preload by itself is it doesn't really predict whether or not someone is going to respond to fluid. This is a compilation of 5 separate studies looking at central venous pressure or right atrial pressure and how likely it was that a patient would respond to fluid. In gray, we see the patients who did not respond to fluid, and in white, we see the patients who did. And you can see in 2 of the studies, there was a separation where the non-responders had higher central venous pressure, but in one of the studies, there was actually a counterintuitive response where the responders had higher central venous pressure. And we can see in this group here that we still had non-responders with a low central venous pressure, and we still have some who respond even with a central venous pressure of 9. So by itself, preload is not terribly predictive. One of the challenges is even if I knew what a given person's Frank-Starling curve was, when they get sick, for example, with sepsis, all these circulating cytokines can cause myocardial depression, and you actually can get a drop in ventricular function. In fact, one of the landmark studies here determined that about half of the patients who had septic shock had some hypokinesia, had some decreased ejection fraction. And so trying to make an assessment based off what a person is at health isn't as informative as what's going on when they're sick. So what we really need is a way to determine what that Frank-Starling curve is like while they're sick. So one of the easiest ways to do this is when someone is breathing, where that is a reversible change in their preload, and presumably it will change their stroke volume if they are fluid responsive, or if they're on the flat part, we won't see much change in stroke volume. The classic study that first described this was done in patients who were intubated, and they had mechanical ventilation at fairly large tidal volumes. And you can see that here is a respiratory tracing. And for a given breath, we have changes in the left ventricular outflow tract peak velocity, which would be a shorthand for our stroke volume, as the area above the curve is our stroke volume. But this was a study of about 19 septic patients who had a change in their stroke volume or a change in their peak velocity with breathing. And here we see that same patient, the exact same one, after getting fluid expansion, and we see no change whatsoever. In fact, the cardiac output has increased. So a delta of the velocity of about 12% seemed to correlate quite well with whether or not someone was fluid responsive. And we can see this turns out fairly predictive in the peak velocity correlating with a change in cardiac index. So this is one of the key markers that is done when assessing fluid responsiveness in a lot of our critically ill patients. And we can see variables like end diastolic area aren't terribly useful. So the static measure like end diastolic area index or end diastolic volume, which is actually preload. Preload is not typically predictive or as predictive as preload responsiveness. So one of the other classic ways that we can look at fluid responsiveness is also with the vena cava collapsing. And we can see here a subcostal view where the vena cava is collapsing with breath. And we can see as well that a delta vena cava diameter correlates quite well with cardiac index increase after giving fluid. In fact, when we look at a receiver operating characteristic curve, the central venous pressure has an area under the curve of about 0.5. It's about the same as a coin flip, whereas the change in vena cava was very predictive, had an area under the curve of about 0.9. Now, there are several limitations to this. It doesn't work in all patients. They need to be passively ventilated or truly spontaneously breathing. They have to have fairly large tidal volumes. There are limitations, so this isn't something that you can just apply to every single patient, but still it is better than the prior standard of care, which was static pressures like central venous pressure or right atrial pressure. We can even use this for patients where you can't get an adequate inferior vena cava view. And so a very cheap and easy way to look at this is to simply look at the internal jugular. This was a study of about 50 patients, and we can see here that the jugular vein collapses quite well. And when we have a group of patients who have variation in their jugular venous diameter, we see a substantial amount of fluid responsiveness here. The classic example, though, that's probably the most predictive and the most amount of physiologic situations is that of the passive leg raise. And this is simply a reversible fluid challenge. We give about 350 milliliters of blood when we lift the legs up. And we can do an assessment before and after, or before, after, and then going back to baseline. And you can see here, if I measure cardiac output at this state, and I measure cardiac output at this state, I will get two different cardiac outputs. And if there's a big change, that's presumably someone who's fluid responsive. And if I see there's no change, well, then I can feel comfortable not doing that fluid challenge. In fact, two meta-analyses both were done around the same time showing excellent predictive validity in this. We see a group of patients who have very high diagnostic accuracies here with areas under the curve of about 0.98. Now, one of the other things that can be used, this is an area of evolving evidence, is that you could use that same passive leg raise to guide diuresis or dialysis. This was a study done in France of about 30 or so patients who had a measurement of cardiac output and had that measurement done before and after a passive leg raise. And those who had very high changes in the passive leg raise were likely to be on the steep part of the Frank-Starling curve. And those were the same patients who are likely to become hypotensive when you dialyze them. This has been extrapolated out, and in practice, many people use this for guiding when to diurese or when to dialyze patients and how much fluid to take off and whether or not that might elicit shock. We can also use some interesting applications of ultrasound to help guide mechanical ventilation. And while this isn't entirely cardiac, there's enough overlap here. I think this would be of great interest for most cardiologists and cardiac intensivists to be familiar with. So a couple of decades ago, a physician, Lichtenstein, had described a bunch of lung ultrasound findings and was able to use this to guide and predict whether or not someone had a certain type of physiology that was consistent with pneumothorax or pulmonary edema or pneumonia. And he created this algorithm that seemed to be fairly predictive or fairly accurate at identifying different causes of respiratory failure. I'm going to go over a couple of these examples. One of these is the pneumothorax. And so here we see M mode on the left, and we see simple vascular ultrasound, two-dimensional on the right. And we can see here rib shadows, and we can see lung moving in and out of plane. This right here is called the lung point, where we can see pleura sliding, and now pleura is not sliding. When you see this, this is close as you can get to pathognomonic for pneumothorax. Now, if we just saw no lung sliding whatsoever, that could also be consistent with pneumothorax. But when you can see lung moving in and out, you can feel fairly certain that what you're seeing is a real problem. Here's an example of one where the lung is not sliding whatsoever. And so we can see on the right, pleural sliding, and on the left, no pleural sliding. Both have rib shadows, but here we see no lung sliding. We also see a couple of vertical lines here, which are B lines. They're essentially a little bit of pulmonary edema. So that also confirms that this is an inflated lung. When done correctly, this is actually better than chest X-ray. A study looking at about 300 patients found that it was 100% accurate. Now, again, if it's done correctly, it requires doing a fairly fastidious exam where you are ultrasounding several different locations of the lung, but still it outperformed chest X-ray. You can also use lung ultrasound to determine whether or not someone has pneumonia or consolidation. And while you can do a special setting for lung ultrasound, you can get by it with just the exact same cardiac setting on the echo probe. You can just take an echo probe and take a look at the lungs. Here we see a fully consolidated lung with some air bronchograms. And here we see a lung that's also fully consolidated with a small layer of pleural effusion surrounding it. Here's the diaphragm. This is subdiaphragmatic. And so in this case, this is actually quite useful because we can get an idea of what part of this is fluid and what part is a consolidated lung. And that is harder to detect on chest X-ray where they can look very similar. Here we see lung sliding as well, but now we see a lot of vertical lines, and these are called B lines. And these are exactly like curly B lines. What they are reverberation artifacts where the ultrasound is bouncing around between interlobular septa. And when I see that, that tells me, one, I'm seeing lung, but I'm also seeing a substantial amount of extravascular lung water, pulmonary edema. Now, whether this is cardiogenic or non-cardiogenic can't be determined necessarily by the ultrasound, but you can also use your cardiac ultrasound or echo to help make that diagnosis. This is extremely useful, I think, not only for patients with acute respiratory distress syndrome, but also those with heart failure. In a study looking at over 1,000 patients, almost 2,000 patients, it was fairly sensitive and specific for detecting extravascular lung water, and again, outperformed chest X-ray when CT scan was used as the gold standard. Another interesting application that's fairly new and fairly evolving is the ability to use lung ultrasound to help guide ventilator management. And this is something that is somewhat of a replacement for what we used to do. We used to take either patients to the CT scan, which had some problems of ionizing radiation, as well as the challenges of transporting a critically ill patient who's ventilator dependent, or we would look at these static pressure volume curves to try to tell what the right amount of tidal volume to deliver, the right amount of positive end expiratory pressure was. The problem with trying to measure these is it requires the patient to be deeply sedated or paralyzed to actually get these accurate measurements. So lung ultrasound can offer some of those values as well. And this is using the same cardiac probe that we would normally use without really any change. And we can see here an aerated lung with these nice reverberation artifacts. We call those A lines. And that's a nice aerated lung where we're seeing a reverberation artifact at the pleura. And here we see mild amount of B lines. And then here we see moderate to severe amount of B lines. And then here we see fully consolidated lung. So this group scored these as a scale of 1, 2, 3, and 4, and looked at changes in those scores when they administered higher lung pressures or higher ventilator pressures, higher PEEP. And they saw how much of the lung re-aerated. And so you can actually use this to help guide how much extra volume or pressure to deliver to the lungs. And one of the challenges with this, though, is that lung recruitment is somewhat controversial. There are some studies in the pulmonary critical care literature that suggest that it might be harmful. So I'm not advising that we do this, but I'm saying that it is an interesting and useful way to help guide your current management. The application that I find most useful, however, is when I have a patient who is severely ill and I want to deliver a little bit more pressure in that ventilator, but I'm worried about what might happen to the right heart. And we can do bedside ultrasound or echocardiography to assess the size of the right ventricle. And here we see a patient here who has a fairly engorged right ventricle and fairly underfilled left ventricle. And this is a patient in whom I might be a little bit more concerned about increasing the PEEP, because this right ventricle might be more susceptible to failure than one that looks like it's pumping away just happy and has no problem with afterload. I'm going to show you an interesting picture here of a patient who has initially a normal looking right ventricle when a collapsing inferior vena cava. And after we administered increased airway pressures, a positive end expiratory pressure of 14, tidal volume of 430, but they had fairly stiff lungs, we see that the right ventricle increased substantially with decreased functionality as well as IVC engorgement. And so in some patients where I feel that I need to increase the PEEP very rapidly, I may do bedside ultrasound to make sure that I'm not compromising the right ventricle as I do this. And if I see this, I may go a little bit more cautiously. We can also use echo, obviously, to assess for right to left shunt, which is a useful bit of information for a lot of intensivists when I have someone who is hypoxic and I'm curious whether or not this is due to lung disease or whether this is due to increased pulmonary pressures that are leading to shunt. And this is something very simple to be done. And then last, I'm going to show you an example of what's a remarkable case here of someone doing a recruitment maneuver. This is a patient who was about to get ECMO for severe ARDS. And they did transesophageal echo and did a recruitment maneuver to increase the pressure in the lungs. Now, this is not something I necessarily recommend. This is actually not advised by the critical care societies as a standard, but you can see we now inflated this consolidated lung. I'm going to go back here just so you can get appreciation. Here's consolidated lung, and it's going to inflate right now to right about now. We'll see inflated lung with a lot of B lines. So swollen lung, but now it's inflated. And the PF ratio or the oxygenation went from 78 to 270. This prevented the need for using extracorporeal membrane oxygenation. We can also use cardiac ultrasound, echo, to help guide weaning. And so diastolic assessments, E to E prime, can be useful to guide whether or not people will survive or be successfully liberated from the ventilator, or whether or not they may have problems with additional diuresis. So a high E to E prime ended up having much higher failure rates when they tried to liberate people from the ventilator, and a low E to E prime was associated with increased shock or increased hypotension when trying to diurese patients with ARDS. Now, as far as what's the emerging role of echo in the ICU, I bring this up because this is a growing field and it's still a fairly rare skill. Even though in the United States, at least, there's a lot of talk about this and every emergency medicine doc and intensive care doc seems very enthusiastic about it, there's still limited access to training on this in the community. And I would say that outside of academic programs, there's a lack of trained faculty to teach this. So a lot of physicians want this knowledge or they want this application, but they don't have it. And there is a standard for expertise, at least in the United States. We now offer a board certification in the in critical care echocardiography that at least offers some value, but still this is not a certification that a lot of people have obtained. So where's the gap? The gap here is that we have a need, and cardiology is certainly capable of expanding into this and offering some of these services. I think lung ultrasound is extremely easy. You could learn this in an afternoon. And the other thing to keep in mind is intensivists and emergency medicine doctors may want additional measurements that aren't part of your standard echo. So being aware of what things they may want, examples like hemodynamic assessments or dynamic parameters for fluid assessment, or when you give your report, you're incorporating vasopressor and ventilatory status, or doing serial measurements, understanding why an ICU doctor may want a measurement every so often rather than, well, we just got an echo 3 days ago, or we just got an echo this morning. There will be a reason for understanding why you want those serial measurements. But getting you involved in this will allow for standardized reports, better consults, higher quality, and better care. So you can train point of care ultrasound, POCUS, and critical care echo providers. In fact, Dr. Kirkpatrick has led a great set of guidelines on how an echo lab can help coordinate and incorporate education for those providers who want to learn this. And with that, if you have any questions, please feel free to email me. Thank you very much.
Thank you so much, Dr. Lanspa. That was absolutely amazing. Every time I listen to Dr. Lanspa, I learn so much. It's absolutely remarkable. We're so glad that he is a key member of the American Society of Echocardiography. Well, let's turn now to our next speaker, which will be James Lee. James Lee is a phenomenal young echocardiographer. He is multimodality trained, but he actually right now is spending a lot of his time in what's called interventional echo, and that is guiding interventional procedures. And he is the newly minted director of the Echo Lab at Henry Ford Hospital in Detroit, Michigan. I am so glad that he is going to have that opportunity today to talk to us about multimodality imaging approaches to left atrial appendage occluder closure devices. Please welcome Dr. Lee.
Hi, my name is James Lee, and I'm the Director of Echocardiography at the Henry Ford Heart and Vascular Institute. And today I'm going to talk about multimodality imaging for left atrial appendage occlusion. The learning points are to understand the rationale behind left atrial appendage occlusion procedures, introduce basic principles of pre-procedural imaging for left atrial appendage occlusion, identify challenging anatomy for LAO peri-procedural guidance, and highlight post-procedural imaging challenges for left atrial appendage occlusion. The left atrium has long been implicated as a nidus for cardioembolic strokes and atrial fibrillation, and surgical ligation of the left atrial appendage has routinely been performed during open heart surgery in the setting of atrial fibrillation. Advances in transcatheter therapies has really renewed interest in the left atrial appendage anatomy and physiology, and certainly novel imaging techniques are driving procedural development. The left atrium is located on the anterolateral surface of the left atrium, just adjacent to the left upper pulmonary vein. The inner surface is a complex trabecular network of pectinate muscles and multiple lobes, and it often overlies the left circumflex coronary artery and the great cardiac vein. The left atrium and the left atrial appendage are very volume-sensitive structures, and 500 to 1,000 milliliters of fluid can increase the dimensions of the left atrial appendage by 6 to 9%. You can see on the right some of the various morphologies of the left atrial appendage and the complexity of the trabecular network. The left atrial appendage contains a high concentration of atrial natriuretic peptide, and the distension of the left atrium from heart failure or volume can lead to release and diuresis of feedback loop. In non-valvular atrial fibrillation, the majority of thrombi are found in the left atrial appendage, and oral anticoagulation is a well-established therapy to lower the stroke risk. The thrombogenic nature of the left atrial appendage is thought to be primarily related to slow and sluggish flow, but may have a component of endothelial dysfunction. There's been a number of devices that are on the market and being developed for left atrial appendage occlusion from a percutaneous standpoint. On the top left in A and B, you can see the original Watchman device and the Watchman Flex device, which is a newer iteration. And the Amulet device on the top right in panel F was recently FDA approved in the United States. There are a number of other devices and manufacturers that are on the market or upcoming with clinical trials. You can see one commonly used device in the past called the Lariat device, which is the sort of only externally suture device, ligation device can be seen. The most commonly used devices in the United States are the Watchman devices, and the older device is now called the Watchman 2.5 device, and the Watchman Flex device is the more commonly used device at our institution at this point. You can see that the Watchman 2.5 device has more prominent distal tines, which during recapture can provide potential perforation of the distal appendage, as opposed to the more rounded appearance of the Watchman Flex, which provides a little bit of a safer zone during advancement of the device. You can see that the Watchman Flex also has more struts to allow for improved conformation to the complex shape of the left atrial appendage, and there's some other small changes to the structure. When you're imaging for left atrial appendage closure, the standard pre-procedural imaging methodology is to look at the appendage at 0, 45, 90, and 135 degrees on the omniplane. You also want to evaluate specifically for the left atrial appendage morphology, whether it's the so-called chicken wing morphology, cactus, windsock, and to look at the ideal landing zone of the device and the depth of the appendage. You want to look at the number of lobes, the size of these lobes, and the location from the ostium. And you want to look at the trabecular network of the left atrial appendage and see if there's something there that may cause a procedural impediment or complication during the case. You also want to make sure that there's no left atrial appendage thrombus and evaluate for any potential procedural impediments like a challenging transseptal morphology. The appendage, we have a case here. This is almost a windsock type appendage without a lot of trabecular complexities and a reasonably straight appearance. And you can see that on the far right, we're doing a transseptal puncture where the needle is crossing, followed by the delivery catheter, and will be exchanged up to the large bore delivery catheter that the appendage is going to, the device is going to be deployed through. Here on TEE, you can see that we have good coaxiality of the device in the 45-degree view as well as the biplane view, making sure that you're not stuck in any side lobes. And then on fluoroscopy, there generally is an injection of contrast into the left atrial appendage to ensure that, that the device is well visualized and the deployment angle looks good. On the left here, you'll see what it looks like when the device is first deployed. This deployment is just a hair deep, but is an acceptable position. And on the right, you can see what's called the tug test, where a small amount of pressure is pulled on the catheter to ensure that the anchors seat within the left atrial appendage and there's no migration as the catheter is tugged on slightly. This is formally evaluated in something called the PASS criteria, where we want to look at the adequate position of the device at the ostium or the landing zone, that the device is anchored well, meaning that the device is very stable on a gentle tug test, that there's good compression of the device, and that there's a good seal, meaning that when you evaluate the device on color Doppler in 0, 45, 90, and 135 degrees, there's no lobes that appear uncolored and there's no weak in color Doppler. Now, certainly not all appendages are so straightforward and easy. Here is a case where you have two separate lobes. The lobes are both small and there's a very proximal bifurcation. And you can see here during the initial deployment, the device got stuck in the anterior lobe and was not able to fully expand. And you can see at the yellow line where the ideal landing zone of this device really should have been. On the catheterization image on the right on fluoroscopy, you can see that there's a really tight waist in the mid portion of this device, indicative of poor expansion. And then, so this device was partially recaptured, migrated proximally, and you can see now we have a good deployment right at the ostium of the appendage at the landing zone. And landing zone is generally felt to be, oftentimes felt to be about 2 centimeters from the tip of the limbus or the Coumadin ridge, although in cases like this, maybe a little more proximal. And we like to use the location of the left circumflex coronary artery as a good landing zone. You can see on the fluoroscopy image on the right that there's much better expansion of the left atrial appendage occluder device. As the device is being tugged in this image, you can see very good stability and recoil of the device. So where can we find complementary value in other imaging modalities than just TEE? Well, using TEE, we can pre-identify challenging morphologies, like the case, the second case I showed you. You can ensure that you've got good, accurate device sizing the first time around. You can predict the fluoroscopy C-arm angle before the procedure to save the patient contrast and time during the case. You can pre-select the delivery catheter shape to ensure that the device goes a little more smoothly and quicker. And obviously evaluate for things like left atrial appendage thrombus and predict the TEE views. The reason that TEE can sometimes be challenging for ideal measurement of the sizing of the left atrial appendage occluder device is that you may not always be through the center of the appendage or identifying the maximal dimension in any of your standard 0, 45, 90, or 135 degree views. Whereas CT, due to multi-phase evaluation and high spatial resolution with isotropic voxels, you can really have a high resolution identification of the landing zone and a true accurate measurement. And the idea of a landing zone can be difficult if you're not in these procedures. And so I'm going to try to illustrate this concept. So the image on the left, you may want to think of the device as being adequately seated at any of those two positions. But if you look at the plane through that appendage, it's actually quite complex. And then where you actually seat the device may be more challenging, and it could be any of these orange positions. And you really want to find the position that's going to properly exclude the appendage from the rest of the left atrium without having a risk for leak or migration. Some of the other things that you can do on CT is look for thrombus. The traditional teaching is that if you have a filling defect on first pass contrast, but the filling defect persists on delay, it can be thrombus. Here's just a case to let you know that, that the convention is not always true in all cases, and there was no thrombus on TEE when there was a persistent filling defect on CT. And here's another case where we only had first pass perfusion, two different cases actually, where there was a discrete filling defect felt to be diagnostic of a discrete thrombus in both of these cases, even without a delayed phase. The idea of using CT to predict fluoroscopy C-arm angles is a powerful one. And here you can see in the center image, the predicted angle of RAO 8 and caudal 15 in this new case. And then we do this inverted MIP type image where we try to make the contrast in the image look like contrast will on the fluoroscopy. Here you can also predict what the C-arm angle is and what the landing zone should be. And on the left, you can see the ideal landing zone. And on the right, you can see the predicted dimensions of the left atrial appendage at that landing zone. And then based on the unusual shapes, you can pick the different types of catheters you want to use from the single curve or what we call the double curve or the anterior curve. And so for a challenging appendage like this with a very anterior chicken wing morphology, we may want to pick the anterior curve right off the bat. So here's how the case itself went. On the left, you can see the confirmation of the very acutely bent anterior chicken wing. You can see that we went as posterior and inferior possible on the transseptal puncture and the thin fossa to ensure we had good coaxiality. On the right, you can see on the 3D TEE, what we call our surgeon's view with the aortic valve at the top and the left atrial appendage on the left. And you can see again how going for a more posterior trajectory for the transseptal puncture allows better alignment through the ostium of the left atrial appendage. Here is the inverted MIP image on the left, and you can see that matches very nicely with the direct injection of contrast into the left atrial appendage on fluoroscopy, and then the corresponding image on the right on TEE. Now, you can see that the trajectory of the catheter on the fluoroscopy image and the TEE is very angulated and very posterior. And this is the predicted angle that we wanted for an ideal deployment of this device. And so you can see that even though we went as posterior as possible and used the anterior catheter, we still had difficulty achieving ideal coaxiality. If you had not done the CT beforehand and used a single or double curved sheath and not really tried to get as posterior as possible with your stick in the transseptal puncture, this would have been a very, very difficult case, so nearly impossible to do. Here you can see that our first attempt with this delivery, we were deep in the appendage, and the anterior edge of the device actually got caught under the limbus or under the Coumadin ridge. And this device is not going to be stable or adequate, including the left atrial appendage. Therefore, the device was recaptured, and after multiple attempts, we were able to see the catheter deeper, and you could see the amount of tension on the device in the 135-degree view. And then in the 3D TE view, during release of the device, how much tension is released on delivery. Now, this is a dramatic example for illustration purposes. You generally do not want this amount of tension on the device as you're deploying and releasing. But to show you that how CT can help and a skillful operator can really navigate some of these more difficult cases. And then on the right, you can see the well-deployed device that's well-seated on fluoroscopy in the right. Post-left atrial appendage deployment, about 45 days, we generally get a TEE to evaluate how this device is doing. And again, you want to image at the 0, 45, 90, and 135-degree views. You're going to try to identify the threaded insert or where the catheter was attached to ensure that you're cutting through the center of the device. And you want to look for evidence that the device may be migrating, have any thrombus on the surface, or if there's any residual flow around the device. Significant flow is felt to be anything greater than 5 millimeters in width on color Doppler around the edge of the device. And this can have implications for how long patients remain on anticoagulation post-device deployment. It's important to distinguish flow around the device from flow in the pericardial space around the appendage or nearby flow in the pulmonary vein, as in certain patients, these can be very difficult to distinguish. Here's an example of an appendage that was well deployed on the CT and on the TE on the left, and on the right, the 45-day follow-up. This patient had a CT, and you can see a filling defect at the superior edge near that gutter space that developed into a small thrombus. Other things that we can do with CT are looking at 3D printing. This is a novel emerging technique, and we can use this to fit test devices to ensure that the sizing is good. And we can pick different catheters to beforehand to ensure that the shape and the morphology and the direction are optimal for achieving the best coaxiality at the time of the procedure itself. So the final take-home point is high-quality imaging is key to left atrial appendage occlusion procedural success. Novel left atrial appendage occluder devices and delivery systems may improve left atrial appendage occlusion procedure itself, and particularly challenging morphologies. And CT, when available, can provide important complementary information for both pre-procedural planning as well as post-procedural follow-up. Thank you for your time today.
Thank you so much, Dr. James Lee, for the brilliant presentation about multimodality imaging approach to NAIO closure. Next speaker, we would like to introduce Professor James Kirkpatrick, who will speak about a very important topic, appropriate use criteria for multimodality imaging in heart failure patients. Professor James Kirkpatrick is a professor of medicine and cardiology and bioethics and humanities, and he's also a section chief of cardiovascular imaging and the director of echocardiography laboratory in the University of Washington Medical Center in Seattle. And Professor Kirkpatrick is also a chair of ethics committee of University of Washington Medical Center. Please, Professor James Kirkpatrick.
I want to thank the organizers of this excellent Congress for the opportunity to speak to you today. I have no relevant relationships with industry. Well, what are appropriate use criteria? And why are they important? Well, this is the question that I hope to answer for you today, particularly in relation to heart failure imaging. Appropriateness criteria should provide guidance to supplement the clinician's judgment as to whether a patient is a reasonable candidate for a given treatment, test, or procedure. This is the organizing principle and the underlying idea behind appropriate use criteria, that it provides this level of guidance for clinical judgment. But note that it is a supplementation of clinical judgment, not a replacement for clinical judgment. Furthermore, the appropriate use criteria are based on evidence-based medicine, and they acknowledge guidelines. And in many cases, the guidelines form the basis for some of the appropriate use criteria. But they also involve practice experience. And in fact, the appropriate use criteria are actually arrived at by what's called a modified Delphi exercise. Essentially, there is a rating panel that is composed of various experts from different disciplines. And the rating panel scores a series of indications. Basically, they're a little bit like scenarios for ordering testing or doing procedures. And they rate each of them on a scale of 1 to 9. And then the aggregate score is all put together. And for median scores of 7 to 9, this is determined to be appropriate. So for instance, when we're talking about testing, it would be an appropriate test for the specific indication. And that means that the test is generally acceptable and is a reasonable approach for that indication. A median score between 4 and 6 is deemed maybe appropriate. And this means that in this case, the test for a specific indication may be generally acceptable, may be a reasonable approach, and also may be appropriate as a designation, implies that more research and or patient information is needed to classify the indication better. Median scores of 1 to 3 are deemed rarely appropriate. So for instance, in regards to a test for a specific indication, this would be not generally acceptable and not a reasonable approach for the indication, or at least it is unlikely to be. Now, why is it that appropriate use criteria are so important? Well, they were originally constructed out of concerns for the rising cost of testing, particularly cardiac testing in the cases that we're discussing right now. But subsequently, they were taken up by the Centers for Medicare and Medicaid Services in something they called their appropriate use criteria program. CMS, Centers for Medicaid and Medicare Services, is actually the main funding agency from the United States government. So it has a lot of power to determine what is going to be paid for in terms of medical tests and treatments. The appropriate use criteria program has been delayed in rolling out. You can see here that it's actually going to be even delayed a little bit farther out while they're trying to figure out how to do this. But it essentially it consists of a process by which certain important testing procedures, which basically are elucidated here below: computed tomography, positron emission tomography, nuclear medicine, and magnetic resonance imaging. You'll note that ultrasound imaging is not included on that, is part of this program that will require clinicians, before they order it, to have decision support tools. And these basically are tools that are based on appropriate use criteria, and they will more or less counsel a physician or a nurse practitioner or some other clinician doing the ordering what is an appropriate indication for ordering tests. Now, what are appropriate use criteria not? Well, they are not guidelines. Guidelines have been defined as what should be done, a series of things that experts come together looking at their literature and the evidence that's available and come up with a list of things that should be done in clinical medicine. They are also not practice performance measures. Now, practice performance measures are essentially things that have to be done. In order to have quality practice, you must perform these measures. Appropriate use criteria are not those things. Again, going back to our definition, they are basically about what is reasonable and what is generally acceptable as a therapeutic or diagnostic intervention. Now, this is taken directly from the appropriate use criteria we'll be discussing today. The goal of this document is the determination of the range of modalities that may or may not be reasonable for specific indications, rather than determination of a single best test for each indication or a rank order of those tests. Essentially what this means is that these documents are not trying to tell you which modality, a CT versus cardiac ultrasound, for instance, is better than the other. It's basically talking to you about reasonable alternatives for specific indications. Furthermore, it makes the point that if more than one modality falls into the same appropriate use category, then it's good. You can use both of them. And it comes down to physician or clinician judgment and available local expertise that should decide between the two tests. So in essence, appropriate use criteria at this point are not necessarily helping you decide which of two equivalent tests you should use for a particular indication. This is a diagram that shows the cardiac imaging process, and you'll see that it goes from patients all the way to improved patient outcomes, and there are a number of steps along the way. Well, we're basically going to be talking about patient selection when we talk about appropriate use criteria. But let's not forget that there are these other elements: study performance, interpretation, and reporting. And in fact, the appropriate use criteria assume that all of these others are being done at a high quality, which of course is not necessarily the case, but we're just focusing on the patient selection aspect. Now, there are many different indications that are mentioned in appropriate use criteria. This is one of the earlier appropriate use criteria, the 2007 document covering transthoracic and transesophageal echocardiography. But there are many others. And in general, the ones that deal with diagnostic imaging will talk about a series of different indications. Indication of making an initial diagnosis, indication of evaluating a change in clinical status or cardiac exam, or for guiding therapy or management, even if there are no symptoms. And then there are the categories of early and late follow-up without changes in clinical status, but detecting things that might be important to find changes in earlier rather than later. So that might include aortic sizes. If the aorta is growing at a fast rate or reaches a certain size, then it may need to be replaced depending on the patient's genetic aortopathy. And the same is true for valvular lesions. If we find that even without symptoms, there has been change in ventricular size or function and worsening of valvular lesions, it may be time to intervene. So I like to think about the appropriate use designations as being like a stoplight. Appropriate is green for go. That means that this is accepted and generally should be done. Yellow is maybe appropriate, as we mentioned, and this sort of is like proceeding slowly with caution. It's not as ringing an endorsement as appropriate, certainly. And as mentioned, it needs more data. And red, of course, is rarely appropriate. And these are the ones in which you want to stop and rethink what you're doing. Now, of course, like all stoplights, occasionally things get a little confusing, and that's also true for the appropriate use criteria. You can see that this stoplight is showing both red and green at the same time. Not very helpful. And so again, just sort of looking at this at a very wide out view or huge 30,000 foot view, as we like to say, from very far up, the appropriateness is determined by whether there's a new symptom or a change in symptoms or something is increasing or getting worse, like sizes. For things that may be appropriate, a lot of times these fall into the categories of being within a certain time frame. So 1 year between imaging studies is kind of the baseline minimum in many cases, deeming appropriateness, and then something over a year, it may be appropriate. And for the rarely appropriate indications, they would include things like surveillance without a change in signs and symptoms. Routine is a word that might signify rare appropriateness. If it won't change management, and then of course, if it's done for screening purposes, because most of the testing that we're talking about is rather expensive, and we discourage the idea that it could be used for screening. Now, this doesn't cover other situations in which you might have people going to a remote area, for instance, with a small portable ultrasound machine to do cardiac ultrasound screening. That is a different story and may be actually appropriate, but is not covered in the appropriate use criteria. These are the two appropriate use criteria that are most modern in dealing with the topic of heart failure. In 2013, there was a specific document talking about use of cardiovascular imaging in heart failure. And then the more recent 2019 appropriate use criteria for multimodality imaging in the assessment of cardiac structure and function in non-valvular heart disease has quite a few sections that deal with imaging of heart failure. And these are the modalities that first 2013 document mentions. Cardiac MRI up on the upper left, PET scanning, nuclear scanning, coronary CT and coronary artery calcium scoring, echocardiography, and invasive coronary angiography. And I would like to just go through that 2013 guideline, because even though it is older and in some ways has been supplanted by the 2019 document, I think it actually organizes the appropriate use criteria for heart failure in a very interesting way and a very easy way to sort of conceive of what we should be doing. So in table 1, they describe the first clinical scenario, and that is initial evaluation of cardiac structure and function for patients with newly suspected or potential heart failure. And you can see there's some specific indications here on the left side of the screen in the column under indication, all under this newly suspected or potential heart failure heading. And they include things like symptoms, and then if a patient's going to have cardiotoxic chemotherapy, or if they have reason to suspect that they have a familiar or genetic cardiomyopathy, they have congenital heart disease, or if they've had an acute myocardial infarction during initial hospitalization. And if we look at the appropriateness and color code them, we see that echo is appropriate really for all of these indications. Radionuclide ventriculography can be appropriate for some of them, and cardiac magnetic resonance imaging, CMR, is appropriate for all of them as well. The things that are not so appropriate are actually the things dealing with ischemia or coronary artery disease, because these would not necessarily be the first test, the initial evaluation for new suspected potential heart failure. And so while we have a few things here that may be appropriate, most of the imaging modalities that look at stress testing or coronary artery disease are actually deemed to be rarely appropriate. And that includes, of course, coronary angiography, except for the fifth indication here, acute myocardial infarction, and the evaluation of LV function. That received an appropriate designation, and what it means here is not coronary angiography, but rather left ventriculography during a catheterization procedure. Moving on to the second clinical scenario listed in Table 2, and that's evaluation for ischemic etiology. You see it's quite a bit shorter here and covers only angina or ischemic equivalent syndrome, and then imaging without angina and ischemic equivalent syndrome. And you can see here, it's exactly the opposite, that ischemia and coronary artery disease detection receive the appropriate designations, including for invasive coronary angiography done during catheterization, whereas rest only are either maybe appropriate or rarely appropriate. On clinical scenario 3 in Table 3 is viability assessment. This assumes that the ischemic etiology of heart failure has already been diagnosed, and we're trying to figure out whether revascularization should be done. And this is with or without clinical angina. And divided up here into the different levels of ejection fraction, severely, moderately, or mildly dysfunctional. And you can see here that we again have a bit of a different situation in which we have things like SPECT, rest, and redistribution, looking specifically at viability, is considered appropriate for those with severe reduced ejection fraction. PET has been expanded a little bit more into the moderately reduced function category. And CMR is appropriate across the board. Rest and stress echo, or particularly dobutamine stress echo for viability, is considered appropriate, as is SPECT, and PET and CMR for certain of the indications. We see that baseline echo, or echo that is done only at rest, along with some of these other specific applications of nuclear scanning, and then all of cardiac CT is considered maybe appropriate. And then radionuclide ventriculography, which doesn't give any information about viability, and catheterization, which also does not, are considered rarely appropriate. And then here is a much more complicated table that deals with ICDs and cardiac resynchronization therapy. And I'm going to try to break this down a little bit more succinctly without going into a lot of the details. Basically, echocardiography, and for most of these specific indications related to ICDs and CRT devices, is considered appropriate, as is to some extent radionuclide ventriculography looking at ejection fraction, and of course CMR for a number of different reasons, and CCT, or cardiac CT. We have a number of maybe appropriate indications across the board on different modalities, but you'll see that the vast majority of this table is actually in red, and that means it is rarely appropriate. Of course, that makes sense when you're talking about ischemia evaluation and coronary angiography, but there are other things that we should avoid doing as well, because they will not be helpful in this particular setting. And then finally, the clinical scenario number 5 is repeat evaluation of heart failure. This is one of the most interesting, in my opinion, because it tends to be that repeat studies end up costing a lot of money, and they may be the ones that are least likely to be appropriate. And so we do need guidance on what is appropriate to order a repeat imaging study for in relation to heart failure. And you'll see here again that the appropriate studies generally fall into the echo category and also particularly for new or increasing heart failure symptoms, which might be due to coronary disease, looking at some of these stress modalities and even catheterization. At the time, there was less evidence for PET and CMR stress testing. And we can see that there's a lot of different, maybe appropriate designations here for new angina or ischemic equivalents or new increasing heart failure symptoms. And then the vast majority of the lower part of the table covering the last two indications in which there are no new symptoms is all red. And that is, again, because the appropriate use criteria consider that patients who do not have symptoms probably don't need testing for the most part. And the one difference here is a maybe appropriate designation for echo, transthoracic echo, when there are no new symptoms and no other clinical status changes, but it's been a year at least since the last image. So let's move on then to the 2019 appropriate use criterion. I'll just give you a warning here that it's considerably more complicated. It covers many more things than just heart failure, but I have pulled out the aspects of it in the tables that are dealing just with heart failure. Nonetheless, it is considerably more complex. It covers all the same modalities that we talked about earlier and that were covered in 2013 document, but it also adds a number of other important modalities. That includes three-dimensional echo, Speckles tracking strain echocardiography, particularly global longitudinal peak systolic strain. Transesophageal echocardiography is brought out. It also covers pyrophosphate scanning or PYP scanning, and also it deals with some of the more advanced nuclear techniques such as FDG-18 PET scanning. It also is broken down into different tables with different indications, as were the other guidelines. And in table 2, it lists the initial the indications under the initial evaluation of patients with clinical signs of heart disease. Now, there are many other types of heart disease that are covered, but here are the ones that are related to heart failure and cardiomyopathy. First is the initial evaluation, very similar to what was covered in the 2013 appropriate use criteria. Second is suspected inherited or acquired cardiomyopathy, also similar to that which mentioned dilated cardiomyopathies of a genetic flavor. And then finally, evaluation of LV function in patients who are scheduled to receive chemotherapy, also quite similar to the 2013 document. And you can see it's very much the same, we should say, that transthoracic echocardiography with or without 3D and with contrast as needed is considered appropriate pretty much across the board. And then you have a smattering of other appropriate designations here for stress echo and SPECT or PET or CMR, looking at the initial evaluation. The rest of them are basically considered maybe appropriate, and it depends on the clinical scenario. And that includes strain and strain rate imaging. In terms of suspected inherited or acquired cardiomyopathies, we now see the introduction of some maybe appropriate categories, again, covering strain and strain imaging, but also now F18, FDG PET, and also technetium-99 pyrophosphate scanning, trying to get at the etiology of the inherited or acquired cardiomyopathy. CT can also be helpful in that respect. But it is considered that TE, stress echo angiography, not needed in this case because we already think it's non-ischemic. For the evaluation of LV function in patients who receive chemotherapy, pretty much it's just things like radionuclide ventriculography and echocardiography. Everything else is not necessary and won't particularly be helpful. And then, of course, CMR, it's rather expensive to be doing evaluations on patients receiving chemotherapy multiple times when that can just be done by other means. So to put this all together for initial evaluation, we're really looking at structure and ischemia, so stress testing, echo and CMR. For cardiomyopathy, transthoracic, echo and CMR, and for chemo, it's the agents that look quite well at the ejection fraction and can be repeated. In terms of devices, you remember this was a big table in the 2013 appropriate use criteria, And essentially, to break this down, it's all about transthoracic echo, and pretty much everything else, with the exception of CMR and radionuclide ventriculography for the evaluation of the appropriate time interval following revascularization or optimal medical therapy to determine candidacy for these implanted devices and the device choice. Everything else is either red or yellow. And there needs to be more data in looking at some of these aspects, but for the most part, it's all about echo. For cardiac transplantation, monitoring for rejection and cardiac structure and function evaluation of potential heart donor, again, this is pretty much all about echo. There's a smattering of other things, including the use of strain and the myocardial perfusion imaging, CMR, and angiography as needed, but really echo is the first line for monitoring cardiac transplants. In terms of the indication of sequential or follow-up testing to clarify initial diagnostic testing, this table assumes the transthoracic has already been done, and that's why it is crossed out in the first column. Otherwise, this is a very multicolored table, and in essentially looking at the different modalities, it depends on what you're actually needing to assess. So the indications here range from left ventricular systolic function, pulmonary hypertension, CAD, heart failure symptoms, evaluation of an undefined cardiomyopathy, sarcoidosis, amyloidosis, hypertrophic cardiomyopathy, and then this category they threw at the end, which no imaging test besides echo is appropriate for, and that is characterization of a known or suspected incidentally noted small cardiovascular implanted electronic device thrombus. But you'll see the rest of them, there's an awful lot of red in here. And essentially the greens are in the cases that would make the most sense. So if you're looking at left ventricular systolic function, you need a better assessment of the systolic function after echo. You might consider exercise stress echo, myocardial perfusion imaging, MR, CT, or angiography. In terms of pulmonary disease, it's really CMR and CT. CAD are the indications related to stress testing or detection of coronary artery disease. And then there is not much else besides some strain rate applications and exercise echo for hypertrophic cardiomyopathy, but then the use of cardiac magnetic resonance imaging as that follow-up or next test. Of course, PYP and FDG PET scanning can be important for the specific indications of sarcoid and amyloid along with CMR. In terms of sequential or follow-up testing, when patients who are asymptomatic or have stable symptoms, there's even more red on this table. So in terms of less than 1 year evaluation for stage A patients, those at risk but don't actually have symptoms or prior signs of dysfunction, that's pretty much across the board considered rarely appropriate to do an imaging test. In a reevaluation of a patient previously or currently undergoing therapy with cardiotoxic agents, this is the only time when reevaluation in less than 1 year is considered appropriate. And not surprisingly, it's with transthoracic echo and strain imaging and also radionuclide ventriculography. In terms of sequential or follow-up testing when patients actually do have symptoms or need to have therapy guided, again, most of these indications are all well served with transthoracic echocardiography, and then only is periodic reevaluation of patient undergoing cardiotoxic therapy, once again, considered appropriate for strain imaging and radionuclide ventriculography. But for the most part, this is all about transthoracic echocardiography. EEE has been recognized to be important when in evaluation or reevaluation of ventricular assist device complications, particularly when an infection is suspected, looking for endocarditis. So here then is from particularly the 2013 guidelines, kind of a summary of the appropriate use criteria for multimodality imaging in heart failure. It's good for the initial evaluation. It's good for determining ischemic etiology, and once that's been established, whether there is viability. Very helpful in determining devices and repeats. These are all the categories that we're talking about. Imaging is important for all these indications, but particularly echo is important in all of these different things. And the other modalities come to play depending on their particular strengths at answering the clinical question. Now, in terms of determining appropriateness in these particular clinical questions, it's important to remember that we're looking for diagnosis, making an initial diagnosis. We're trying to mostly image patients who have symptoms, who have particularly new symptoms and changes in symptoms. And of course, what we really want are actionable findings. Now, actionable findings could include finding that there's nothing wrong. That in itself might be actionable, because a non-action is essentially a pretty good action when you think about it. If you know you don't have to cath this patient because there is no evidence for ischemia, that's actually a pretty actionable finding, even if it was technically a negative study. In terms of the modalities, basically we can think about transthoracic echo being good for just about everything, and that is essentially what they say in the discussion section of the 2019 appropriate use criteria. Other than that, if we're looking for structure and function, we're going to be thinking about transthoracic echo, cardiac magnetic resonance imaging, and sometimes radionuclide ventriculography. If our question is whether ischemic or coronary artery disease evaluation is indicated, well, then all of the stress modalities, obviously. Also, coronary angiography by computed tomography, and of course, cath with invasive coronary angiography. If we're actually trying to investigate the myocardium and investigate it further, that's when we use our super specialized testing, FDG PET, CMR, strain, and of course, pyrophosphate scanning. Now, I want to emphasize in closing here that although we talk about the patient and patient choice and appropriate indications, and that really is the focus today, there are these other aspects, which, as we mentioned, are extremely important. Excellence in scanning, accuracy in interpretation, and assessment and feedback for quality improvement, quality assurance. We need to make sure that we pay attention to these while we are focusing on the appropriate use criteria in heart failure imaging. Because remember, quality is not an act, but a habit, at least according to Aristotle. Thank you so much. I really appreciate the opportunity to spend some time and discuss this with you today. My very best wishes to everyone for an excellent Congress.
Thank you so much, Professor Jim Kirkpatrick, for the wonderful and profound presentation. And I think that we will need more seminars and conferences in Vietnam to learn and discuss about appropriate use criteria, which you shared today among clinical practitioners. And also we need to discuss with the people in medical insurance for helping the patient to receive this examination. Thank you so much for the wonderful presentation.
Thank you so much for the opportunity. Well, next up, we have a very, very interesting topic, and we're so glad to have Nina Ricchetti joining us today. Nina is the EchoLab director at Northwest Hospital. She has been to all the best places for cardiac imaging training. She spent time at the Mayo Clinic, University of Chicago, Columbia University, but I'm most proud to say that she's a graduate of our fellowship program at the University of Washington. She brings a wealth of experience, and we're so glad to have her speak to us today on one of the most important topics in echocardiography. Nina.
Are you all able to see my screen?
Yes.
Yes.
Perfect.
And we can hear you.
Great. So hi, everyone. Thank you so much for having me present at this wonderful conference. It's a true honor to be part of this conference. I was asked to speak about diastolic dysfunction, why, when, and how we would go about measuring diastolic dysfunction. So what is diastolic function? And we know that left ventricular diastolic function refers broadly to abnormalities in myocardial relaxation, compliance, and filling. And echocardiography plays a central role in evaluation of left ventricular diastolic function. The assessment of diastolic function should be an integral part of examination of patients presenting with dyspnea or heart failure. Now, we know that about half of patients who present with no new diagnosis of heart failure have normal or near normal global ejection fractions. And therefore, this puts a huge emphasis on being able to evaluate diastolic function as an alternative possible diagnosis for patients' new symptoms. So my objectives today are to review the concepts of diastolic function assessment using echocardiography, discuss simple approach to assessing presence or absence of diastolic function, and then finally focus on grading of diastolic function. There are 4 basic elements that we use in echocardiography in measurement of diastolic function. We focus mainly on left atrial volume index, mitral inflow Doppler, mitral annular tissue Doppler velocity, and right ventricular systolic function and pulmonary pressures. The first one that I wanted to talk to you about is mitral inflow, and namely the E to A ratio, which is used mainly to identify filling patterns. As you can see, we use pulse Doppler at the tip of the mitral valve tips, and we were able to get this ratio, which is called E to A ratio. And the E and the 2 patterns are mainly of early rapid filling, which is E, followed by the atrial contraction, which we measure as A. Now, we mainly get 4 main patterns when we are looking at this E to A ratio. As you can see on the right, the normal pattern, which we see mostly in normal, healthy individuals, is the E to A, which is more than 1. The second pattern that we see commonly in patients who are above the age of 60 are the impaired relaxation, which basically it takes longer for the early filling to occur. And we get this pattern that we see with impaired relaxation where E to A ratio is less than 0.8. Now, the third pattern that we commonly see with moderate dysfunction or pseudo-normal is basically similar to the E to A ratio with the normal pattern, except that with this one, with Valsalva maneuver, we're able to get reversal of E to A ratio. I will go into this in more details in my later slides. And then the last pattern is the restrictive pattern or the severe dysfunction, where there is a significant increase in the filling patterns of the left ventricular function, and we see an E to A ratio, which is more than 2. The second component, which I had outlined initially, was left atrial size, which is a main component in our evaluation of diastolic function or diastolic dysfunction using echocardiography. We measure the atrial volumes using the biplane, 2-chamber and 4-chamber, and we want to make sure that we don't include the left atrial appendage. We know that if the volumes of the left atrium are more than 34, then this increases the probability of diastolic dysfunction. The third component, the third out of the 4th component, is tissue Doppler. We use tissue Doppler at the medial annulus of the mitral valve, and we are able to use pulse wave tissue Doppler and get some measurements. Now, this gives us an E prime pattern, which if it is increased by more than 7, we know that likely diastolic function is normal. And if this E prime is less than 7, likely diastolic function is abnormal. This has become an integral part of measurement of diastolic dysfunction in the early recognition of it using echocardiography. Now, we can get significant errors using this for the measurement of diastolic function. In the A square, we see that this is the correct way of measurement of this tissue Doppler. B shows that there is the sample is being put on the ventricular septum, and this will give us incorrect measurement. In C, we have basically higher gains, and D is giving us an inaccurate measurement as well. The fourth and the last component that has gone into the assessment of diastolic function is TR velocity. We know that if the TR velocity is more than 2.8 meters per second, that this increases our probability of diastolic dysfunction. Now, we know that there are other components that can help us with assessing diastolic dysfunction, but these 4 components are the main components that go into assessment of diastolic dysfunction using echocardiography. And lastly, one of the things that we usually report on echocardiography is what we call E to E prime ratio. And basically, this is using the mitral inflow E pattern and using that ratio to the E prime using the medial annulus of the mitral valve. And this is reflective of filling pressures. These numbers are usually normal in patients with normal diastolic function and impaired relaxation. So this is normal in patients who have normal diastolic function and grade 1 diastolic dysfunction. And the filling pressures increase progressively with progressive diastolic dysfunction. We know that if the E to E prime is more than 14, the increased filling pressure, these are increased filling pressures, and you certainly have diastolic dysfunction. But in general, measurement of diastolic function is a probability game using echocardiography. All these variables increase probability of diastolic dysfunction. And the more of these variables that you have, the more likely that you will have diastolic dysfunction. Now, I briefly wanted to go over the American Society of Echocardiography guidelines, and they have 2 key algorithms. One algorithm basically focuses on if the left ventricle appears normal, then all you have to decide is if the diastolic function is normal versus abnormal. But the other one is if there is low ejection fraction or if there is myocardial disease, such as left ventricular hypertrophy, dilated left ventricle, marked strain abnormality, then you can surely assume that there is diastolic dysfunction, and then you go ahead and grade this. So just to put this in context, we know that diastolic function is likely normal if you have normal left atrial size, normal E prime, normal filling pressure, and normal TR velocity. And likely it's abnormal if you have a large left atrial volume index, low E prime, high filling pressures, and high TR velocity. So this is the algorithm that American Society of Echocardiography is using for diagnosis of diastolic dysfunctions with patients with normal EF. And basically has really simplified it using these main 4 categories of E to E prime, septal E prime velocity, TR velocity, and left atrial volume index. If you have 0 or 1 variables that are positive, then likely you have normal diastolic function. If you have 2 out of 4 positive, then this is likely indeterminate, or you may want to use other variables such as pulmonary veins to help you determine the diastolic function. But if you have 3 or 4 positive, then you likely have diastolic dysfunction. Again, I use the word likely because this is all a probability game. And the more variables that you have, the higher likelihood of having diastolic dysfunction. I wanted to go over a case with you. And this is basically a case of a 31-year-old male who was referred for a murmur. What we see is that on the left, you have a still shot of peristernal lung axis showing normal thickness of the left ventricle. In the middle, you have an E2A that resembles the normal pattern, E2A more than 1. And then on the very right one, we see an E prime that's significantly, it's nice and more than our measurement of 7. We know that based on other measurement, our left atrial volume index is 29, which is below the threshold of 34 by the ASE. Our TR jet velocity is 2.4. Again, this is lower than our cutoff of 2.8. And we have an ejection fraction of 65% with normal blood pressure and normal heart rate. So if we go through the ASE algorithm, we see that this is likely a normal diastolic function because all the variables that we measure in this using this echocardiography points us towards normal diastolic function. Now, the second algorithm that ASE has given us is basically gets a little bit more complicated, but really focuses on the main 4 variables. But this is for patients who have depressed ejection fraction, or they have normal ejection fraction, but they have myocardial disease. And basically, this focuses on the same variables, and based on the number of variables that the echocardiography meets, it will give us a category for the diastolic function. I wanted to go over a second case, and this is a case of a 63-year-old male with recurrent dyspnea on daily activity and ankle swelling. He has diabetes, he's on insulin, and has had hypertension for more than 10 years with CKD with serum creatinine of 2.5. He has an elevated blood pressure of 160/85 with heart rate of 64 beats per minute. Still shot of apical 4-chamber and apical 2-chamber views of his echocardiography show that he has some LV wall thickness and his atria look pretty large. This is a still shot of mitral regurgitation using color Doppler showing that there is not much MR that would explain his enlarged atrium. And then looking at his mitral inflow pattern, we see a normal mitral inflow pattern. E to A ratio is more than 1. But when we look at his septal E prime, we see that it's lower than the cutoff of 7. And then his lateral E prime, which I didn't mention, is also low, below the cutoff of 10. Also, his clinical findings are significant for somebody who likely has diastolic dysfunction, including elevated blood pressures, hypertension that he's had for more than 10 years, and significant symptoms. His TR jet by Doppler shows a velocity of 3.6 meters per second. This is also above the cutoff of 2.8. So already we have a patient with clinical data consistent with cardiac disease. We have an E to A ratio that resembles the normal pattern. It's between the 0.8 but less than 2. But then the other variables point us towards pseudonormalization, which is basically a pattern that resembles normal in the E to A ratio, but then every other variable points towards significant diastolic dysfunction, including E to E prime ratio of 20, which signifies increased filling pressures, an enlarged left atrial volume index, and elevated TR velocity. So going back to the American Society of Echocardiography algorithm, looking at a patient who has normal EF but likely has myocardial disease, he goes right in the middle where the E to A ratio is between the 0.8 and 2, but he does meet all the 3 criteria, and this signifies elevated left atrial pressure and grade 2 diastolic dysfunction. In conclusion, diastolic function is a probability game, and all these variables that we use in echocardiography only increase the probability of diastolic dysfunction. And the more variables that you have, the more likely you will have significant diastolic dysfunction. Thank you.
Thank you so much, Dr. Ricchetti. That was truly a wonderful review of a very challenging and difficult topic that could have been a much longer talk, but I'm so impressed with how you were able to distill it into a very short period of time that was extremely practical. Well, next we'd like to bring back Dr. Gary Wang. The reason that we're doing this is Dr. Selma Carlson unfortunately couldn't make it. She had a joyous family event. I'll leave it at that, but she's doing very well, and we're so grateful for Gary for being able to step in and address this topic of valvular heart disease. Just as a reminder again, Gary is the Echo Lab Director at Harborview Medical Center in Seattle. And I do want to let everybody know that something new about Gary that I hadn't mentioned before, his research interests vary widely, but he has been interested in particular on the application of small portable ultrasound devices by cardiologists. And he has done research in that area along with many other very interesting things. I would highly suggest that you look for his name in the medical literature because you will definitely see it with some very new and innovative explorations in the field of cardiac imaging. Gary, thank you again so much. We really appreciate you stepping in and providing this lecture for us.
Thank you so much, Jim. And I'm happy to be here. Thanks so much for having me speak here. And let me just share my screen. All right, can you guys see this? Sounds like
yes.
Yes, great. All right, so my next topic that I'll be talking about is valvular heart disease. And I have no disclosures. And so the reason why valvular heart disease is so important of a topic is because, as you can see in this image from a study in 2016, looking at the number of deaths from valvular heart disease, it's gone up linearly since 1979. And the most common cause of death, of valvular heart disease causing death is from aortic valve disease. So that's why it definitely needs to be addressed. And the two most common valvular heart diseases that I'll be discussing today are aortic stenosis and mitral regurgitation. They're the most common and the most prevalent. And the first I'll talk about is aortic stenosis. So there is a variety of etiologies of aortic stenosis. And this is a patient with a normal aortic valve. So you have a patient with a non-coronary cusp here, the right coronary cusp with the ostium of the right coronary artery, and the left coronary cusp with the left coronary artery ostium here. And as you can see during systole, it opens well. A very uncommon etiology of aortic stenosis in the United States, but I'm sure much more common in Vietnam, is rheumatic valve disease. And you can see here, you have significant thickening of the aortic valve, and it causes the opening to be restricted during systole. In patients with calcific aortic stenosis, this is more common with age. And you can see the severe calcification of the valve. And again, it's restricting the opening of the valve. And then in patients with bicuspid aortic valve, this patient has fusion of the left and right cusps, and these patients develop aortic stenosis at a much earlier age. And in patients with age-related calcific aortic stenosis, it's the most common etiology in adults in the United States. About 30% of adults greater than 65 years of age have aortic sclerosis, which is basically just thickening or calcification of the aortic valve. And about 10% of adults over the age of 80 years have aortic stenosis, which means blockage of the valve. You can see here an example of severe aortic stenosis from age-related calcific aortic valve. You can see severe calcium on the valve in short axis view, and it's not opening well. And similarly here in a 3D image, you can also see heavy calcification and restricted opening of the valve as well. In patients with calcific bicuspid aortic valves, so 1% of the population has a bicuspid aortic valve, but it accounts for 50% of aortic valve repair. It's a very important pathology. And you can see in this top video, you have fusion of the right and left coronary cusps of the aortic valve, and it opens well with not much calcium yet. This patient is still young. And in this older patient, again, they have a bicuspid aortic valve with some mild calcification. So they have not developed severe aortic stenosis yet at this point. And again, rheumatic aortic valve disease, it's a problem outside of industrialized nations, and it's almost always associated with mitral valve involvement. So patients with rheumatic aortic valve stenosis usually have mitral valve stenosis as well. You can see, as opposed to in patients with calcific aortic stenosis, these patients have valve thickening as opposed to calcium. You can see it's not as echo-dense. And you can see in the long axis view, similarly, it's restricting the opening, but the leaflets are more thickened than calcified. So the concept of aortic stenosis can be illustrated in this image of a water hose. So similarly to a water hose, if you put a smaller and smaller nozzle on the end of the hose, you're going to cause an increase in pressure gradient behind the nozzle, and you're going to have an increase in velocity across the nozzle as well. Similarly, with aortic stenosis, the smaller the opening of the valve, you have a faster velocity of the flow of blood across the valve, and you have increase in pressure gradient as well. Patients with aortic stenosis oftentimes present asymptomatically. These patients are oftentimes incidentally discovered. If they get a physical examination, the physician may hear a murmur, and it would alert us for severe AS. Also, if the patient ends up getting an echocardiogram for other reasons, but you can find AS with this as well. And if patients do develop symptoms, they're oftentimes asymptomatic. For example, decreased exercise tolerance, dyspnea on exertion, dizziness. Patients can also have angina, syncope, and heart failure, which I'll discuss in a second. And the murmur that you hear in patients with aortic stenosis are you have a loud mid to late peaking systolic murmur in the right second intercostal space. And oftentimes this murmur radiates through the carotid arteries. You also have diminished and delayed carotid pulse, so pulsus parvus et tardus. And if it's severe enough, you can actually have a single second heart sound, and the S2 may become paradoxically split when the stenosis is severe. So this is just an image showing that. So patients with mild AS, the peaking is a little earlier. With more severe aortic stenosis, you have mid peaking, and then you have late peaking murmur here. And you have a paradoxical splitting of S2 in which you have P2 occurring before A2. And that's what that's referring to in a setting of severe aortic stenosis. Some imaging modalities we use to diagnose AS are, we use echocardiography primarily. We can also use cardiac MRI or cardiac CT angiography. And in this patient who has had an echo for AS, so you have the AS jet, basically very fast velocity across the valve of 5.4 meters per second, and a high mean gradient of 77 millimeters of mercury, which are both very high and indicate severe AS. You can also use the continuity equation, which is a math equation, to calculate the valve area as well. And so these are some numbers we put to patients with severe AS. So peak velocity is greater than or equal to 4 meters per second, mean gradient of greater than or equal to 40 millimeters of mercury, and aortic valve area of less than 1 centimeter squared. You can also just calculate the valve area by short axis and trace it out. And this patient has an aortic valve area of 1.32 centimeters squared, so it's moderate AS. The patient has severe AS, 0.55 centimeters squared. So again, transthoracic echocardiography is recommended in the initial evaluation of patients with known or suspected valve heart disease, or in this case, AS. And it's also recommended in patients with any change in symptoms or physical examination findings concerning for worsening valve disease, and for periodic monitoring of patients with asymptomatic valvular heart disease as well. So this study was done in 1968 before valve procedures were started to be performed. And on x-axis, you have age, y-axis, you have percent survival. So you can see you have a very long latent period in patients with aortic stenosis that's severe. But if you have symptoms, then their survival drops significantly and quickly. And so the symptoms that you should watch out for in patients with severe AS are angina, syncope, and heart failure. Because in patients who develop angina in severe AS, they only have a 5-year, 50% survival, syncope, 50% survival of 3 years, and heart failure, 2-year, 50% survival. So definitely, if they develop symptoms, you should be concerned and perhaps should undergo a procedure. And this study was done in 2010, and it followed patients with severe aortic stenosis. And it showed basically that over time, and this is a 6-year period, that all of these patients ended up either dying or end up getting a AVR, aortic valve replacement. And so most of these patients need either surgery again or they end up dying. And in the same study, it shows that the higher the velocity across the aortic valve, the worse the outcome. So in these patients with the velocity of greater than or equal to 5.5 meters per second, the event-free survival goes down significantly. And also in patients with moderate or severe calcification, the survival goes down as well compared to just mild or no calcification. And so in terms of what we do for these patients, so in patients with severe aortic stenosis, the velocity greater than or equal to 4 meters per second, or the mean gradient greater than or equal to 40 millimeters of mercury, and they're symptomatic, then they should undergo aortic valve replacement. If they're asymptomatic, but they have low EF of less than 50%, and they're undergoing another cardiac surgery, for example, a cardiac bypass graft surgery, then they should also undergo aortic valve replacement. All right, and then the next valve disease I'll talk about is mitral regurgitation, which is also very common. And the mitral valve apparatus is very complicated with many structures involved. So you have the anterior leaflet of the mitral valve, posterior leaflet. You have the annulus around the valve, and you have the posterior lateral and anterior medial commissures. Also have the chordae tendineae attached to the valve, and then the lateral papillary muscle and medial papillary muscle. Any disruption in any of these structures can lead to significant mitral valve disease. The most common etiologies for mitral regurgitation, you can split between primary or degenerative MR, or secondary or functional mitral regurgitation. And in terms of primary MR, most common is mitral valve prolapse, followed by leaflet thickening. So for example, infection or inflammation. You can also have rupture of the cord or the papillary muscle. Secondary MR is usually from ischemia or infarction, in which you dilate the left ventricle, leading to functional MR. So again, mitral valve prolapse ranges from fibroelastic deficiency all the way to Barlow's disease, in which you have prolapse of the mitral valve into the left atrium during systole. So this image shows that during systole, you have prolapse in this case of the posterior papillary of the posterior leaflet, and you have significant mitral regurgitation through that opening during systole. Mitral valve prolapse affects 0.6 to 2.4% of the population, and it's the most common cause of chronic mitral regurgitation. Moderate to severe MR is present in 16% of patients with mitral valve prolapse as well. This echo shows a patient with significant mitral regurgitation from significant mitral valve prolapse. So you can see a significant prolapse of the posterior mitral leaflet here into the left atrium during systole. You can see the regurgitation jet going anteriorly into the left atrium. And so again, mitral regurgitation caused from mitral valve prolapse. Symptoms, oftentimes these patients don't have any symptoms, but they can have a mitral valve prolapse syndrome, which includes atypical chest pain, palpitations, dyspnea, exercise intolerance, dizziness, and anxiety disorders. And these patients over time, because you have increased pressure in the left atrium, can develop atrial fibrillation as well. In terms of the murmur you hear for mitral valve prolapse, it's characterized by a mitral valve prolapse click, followed by a mitral regurgitation murmur. Typically have a mid-systolic click, but the timing varies depending on certain maneuvers that change left ventricular volume. So for example, if you're standing and you reduce preload, the click actually occurs earlier. And if you squat and increase afterload, then the click occurs later. And the murmur can radiate either anteriorly to the precordium or posteriorly towards the apex. And another cause of mitral regurgitation, as I mentioned before, is secondary or functional MR. And in this scenario, patients oftentimes have myocardial infarctions, in which it dilates the left ventricle and it pulls the papillary muscle out, for example, in turn pulling the chordae, and it keeps the mitral valve open during systole, causing significant mitral regurgitation. And the murmur you hear from mitral regurgitation generally is a high-pitched, blowing holosystolic murmur, loudest at the apex and radiates to the axilla. The intensity increases with hand grip or squatting, and the intensity does not increase with inspiration, like you would hear with right-sided murmurs. And the heart sounds in chronic MR are you have a diminished S1, accentuated P2 from pulmonary hypertension, S3 gallop, and displaced apical impulse from heart failure, perhaps. And again, very similar to aortic stenosis, echocardiography is recommended in the initial evaluation. Also, if there's any change in symptoms or physical exam findings, or if you're just following them up, you should obtain serial echocardiograms as well. And echo in the assessment of MR is to assess the presence and severity of MR, the mechanism and etiology of MR, the sequelae, in which you have a dilated left ventricle or systolic dysfunction. Again, you may have new onset atrial fibrillation or pulmonary hypertension, and feasibility of repair as well. And then lastly, in terms of management of these patients, patients with primary MR determined, which is severe, determined by echo usually, and they're symptomatic, and their EF is greater than 30%, then they should undergo mitral valve surgery. If they're asymptomatic, their EF is between 30 to 60%, or their LV is dilated, so their LV end systolic diameter is greater than 40 millimeters, then they should also undergo mitral valve surgery. If they have new onset AFib or pulmonary hypertension, then they could have mitral valve repair possibly as well. All right, and lastly, some take-home points. The clinical presentation can be variable for each type of valvular heart disease, and each type of valvular heart disease has a characteristic murmur. Echocardiography is typically the first-line diagnostic imaging modality, and surgery is largely dependent on if the patient develops symptoms. That's it. Thank you very much. Again, my name is Gary Huang. Here's my email and Twitter. Feel free to email me if you like. Thank you.
Great. Thank you so much, Gary. And again, I so appreciate you stepping in there sort of at the last minute and being able to help us out. That really was phenomenal for heart valves. Next, we'd like to open things up for Q&A. And we would love to have all of the speakers go ahead and turn on your cameras. And we actually in echocardiography, how do you get the parameter as soon as the patient reaches the peak during a treadmill test? That is a very great question, and one of those things that we have some issues going forward. Gary, would you like to take that one?
I'm trying to understand the parameter. You mean how to obtain the image as soon as the patient reaches peak?
I think that they're referring to imaging, or if even if you're measuring diastolic functions or anything like that. How can you do your best to get it at peak stress?
Yeah, it's typically very difficult to do that, and especially in the setting. I'm trying to turn on my video. It's not really working, unfortunately. You know, if we're trying to rush the patient from the treadmill, for example, onto the bed, it's usually very difficult. But to have perhaps the bed closer to the treadmill and to have the staff adequately trained. But yeah, it's usually very difficult. I'm not sure, Jim, if you have anything else to add.
No, I think that's a great point. It's decreasing the time that's going there. And I think the other thing that that we do routinely so much we forget about is that just try to get the patient to go as long as they possibly can on the treadmill. The faster the heart rate when they hit the bed, the better. If you stop them when they're not quite at their peak, then obviously the heart rate will go down faster and you may not catch it. So, but really great points. The next question for Dr. Lanspa, absolutely, and that is, can lung ultrasonography distinguish the main pathogenesis when a patient has both pneumonia and acute pulmonary edema?
That answer is yes, sometimes. In fact, in that, it's called the Blue Protocol. If you want to Google this, you can just type in Blue Protocol ultrasound and you can see this. But one of the criteria is pneumonia is typically heterogeneous. So as you image both sides of the chest, you'll see areas of consolidation and edema, and you'll see areas that may be aerated, areas that may have just edema without consolidation. And so yes, if a patient has pneumonia or ARDS, acute respiratory distress syndrome with pneumonia, you can actually use lung ultrasound to help differentiate that between pneumonia and pure pulmonary edema, where someone may have, let's say, cardiogenic pulmonary edema, where there will be B lines, they will be symmetric, they will be more prominent in the dependent areas and less prominent in the supine or the less gravity dependent areas. But yes, it ends up being a Bayesian analysis in the sense that if you have a high pretest probability for cardiogenic edema and you see symmetric B lines on both sides, it can be very accurate. And I believe
that's fabulous. So we're gonna stay with Dr. Lanspa for the next one here. Is the cutoff point for EDE prime different for weaning mechanical ventilation or weaning ECMO, or is it the same?
Yeah, so there are two studies that were done by this. One is by Allyn, A-L-L-Y-N, and I'll put this in the chat in 2013. The other one was by Papanicolaou in 2011. And these were fairly small studies, and they had different criteria. One was looking for successful weaning, and the other was looking for problems with diuresis. And it was essentially an EDE prime of about 8 or higher, had higher likelihood of failing weaning or failing liberation from mechanical ventilation. EDE prime less than 7 was more likely to fail diuresis. Now, that doesn't mean that we need to shoot for an EDE prime exactly between 7 and 8. These are small studies. There's a gray area. It's point that the higher your EDE prime is, the more likely you are to have cardiogenic pulmonary edema, and the more likely you are to still have benefit from additional diuresis. And the lower your EDE prime, the more dangerous diuresis is. As far as ECMO, that's a completely different situation. And at least to my knowledge, I don't know of using EDE prime to liberate someone from ECMO because of all of the challenges that occur from the altered filling pressures that occur when someone is on extracorporeal membrane oxygenation. And I'll put those citations in the chat.
Great, thank you so much. Let's move on to the next question here, and I'm going to pose this one to Nina. How about strain imaging by speckle tracking in acute heart failure? What are the advantages and disadvantages? Nina, I think you're still muted. Nina may have stepped away. I think this is a phenomenal question. So in the setting of acute heart failure, it actually can be very helpful to know what the speckle tracking strain looks like. Particularly, we think about global longitudinal strain. There's really two things here. One is basically the pattern of strain, and there is some evidence that the pattern of strain can be helpful in determining what is the etiology of the heart failure. Now, we tend to think of this more in terms of heart failure with preserved ejection fraction, looking for amyloid infiltration, sometimes sarcoid infiltration, sometimes hypertrophic cardiomyopathy. And that, of course, can be somewhat helpful in the acute setting to try to figure out what's going on. Other than that, sort of the other sort of global longitudinal strain measurements, worse is worse, basically. And we do know that even in patients with systolic heart failure or HFrEF, that a lower strain value actually portends a worse prognosis over time. I'm not aware that this is different in an acute heart failure situation compared to a chronic heart failure situation. And of course, we do run into some difficulties because sometimes you have something like a stress-induced cardiomyopathy, which actually improves over time. And just like ejection fraction, your strain may not be reflective of what's going to happen. That said, Gary, I'd love you to be able to jump in on this question too, in particular, perhaps in relation to HFpEF.
Great question. In a setting of HFpEF, I'm actually doing a study looking at patients with recovered EF, and these patients oftentimes have abnormal strains despite having recovery of EF. So it actually adds a layer of sensitivity to LV systolic function before EF.
Absolutely. This is a great area of research and further clinical care as well. I think this next question would be for Dr. Lee, who I don't believe is with us. What morphologic features in echo and CT of the left atrial appendage are not suitable for the Watchman device? Gary, would you want to take that one, or feel free, Nina, to jump in as well?
Yeah, I'm not quite sure actually on that.
Yeah, this I do think is an interesting topic. I think we did do a study led by one of our fellows who's now at the University of Colorado, looking at not necessarily completely being unfavorable, but trying to correlate potential complications with a certain morphology of the left atrial appendage. And it turned out that there actually were very few complications, and it was a bit questionable in terms of how we would apply that to saying, well, you wouldn't really do a Watchman device. But there did tend to be some more in regards to some morphologies that were not sort of the typical ones that we see with the chicken wing. So other ones like cauliflower, broccoli, things that Dr. Lee was mentioning, do sometimes have that angulation that he spoke of that can make it a bit complicated. I don't think you would not do the device because of that, but certainly you might anticipate that there may be something coming out, but a lot more work I think needs to be done in regards to that. Dr. Nguyen just put in an excellent, Dr. Y just put in an excellent question for Dr. Lanspa here. Do you have any comments on high output heart failure in decompensated state in the ICU? We know, Dr. Lanspa, you're an expert in sepsis, but also obesity, pregnancy, anemia. Apart from cardiac output, are there other echo parameters that we need to pay attention to?
Yes, as I had mentioned in the talk, one of the key issues with hemodynamics and changes that occur with a patient, one of the things that we're often looking at is the E to E prime in diastolic assessments. And it's not a true measure of diastolic function, but more of a surrogate for left ventricular filling pressure. An example that I can say that we've seen in septic patients who are hypovolemic and hyperdynamic, you'll have a high ejection fraction, typically a low cardiac output. And despite having fairly low filling pressures, you may actually have a fairly high E to E prime in some of these patients. There's evolving literature about left atrial strain in these patients and some of the changes that can occur with the filling that can occur with high output cardiac failure. And there's also growing applications of longitudinal strain in this. Although both of these last two are not typically done at bedside, it's currently an evolving area of research. But what we will look at mainly is changes with filling pressures for fluid responsiveness, as well as fluid tolerance. And our E to E prime is probably the crude measure that we use most commonly in those patients.
Excellent point. Our next question, we're going to pose this one to Dr. Huang again. I think he's still on. If not, then I'm happy to take it. Hypertrophic cardiomyopathy and mitral regurgitation. Is the mitral regurgitation primary or is it secondary?
I'm still here. Excellent.
Excellent question. All right.
Yeah, excellent question. Agreed. I think it's more secondary mitral regurgitation because you have thickening of the left ventricle that's perhaps pulling the chordae, and therefore it's preventing the leaflets from coapting during systole. It's not a primary issue with the valves themselves, from my understanding.
Yeah, that is, I think, the main mechanism that we would be invoking. There are sometimes some problems with the anterior leaflet in particular, which can be elongated. This can create some controversy in terms of whether what we're seeing is chordal systolic anterior motion of the mitral valve, or it's actually that elongated leaflet. Nonetheless, the leaflet itself, without the sort of secondary effects, is probably not going to be causing MR. So I would agree. I think that this is mostly a secondary problem, even though there are abnormalities of the mitral apparatus itself. But really great questions. All of them are phenomenal. Should cardiac MRI be performed in all patients diagnosed with hypertrophic cardiomyopathy? I think this is an interesting one as well. Nina or Gary, any thoughts on it?
From my understanding, I don't typically get cardiac MRI unless the echo images are suboptimal. Certainly, you have a low threshold to obtain it, but if you have, everything you need with echo, assessment of the valves, and LV wall thickness, then it doesn't necessarily mean you need a cardiac MRI, at least for me.
I agree with Gary as well. That I think a lot of our patients that we get echocardiography, it's sufficient to get the data that we need. But sometimes cardiac MRI is important to get an accurate assessment of the wall thickness and myocardial mass. But really, nowadays we get cardiac MRI a lot of times because of its capability to measure late gadolinium enhancement. And, we do know that if there's a lot of LGE, more than 10%, there's a much increased risk of sudden cardiac death. And that goes into assessment as far as placement of ICD for subgroup of patients with HCM. So, I don't think it's made it up in the guidelines yet, but it is certainly something plausible to do for patients with HCM if you have capabilities to do cardiac MRI.
That's an excellent point. Let me actually bring in Dr. Y here and answer that question or begin to address it. how do you do imaging of hypertrophic cardiomyopathy at Bach Mai Hospital?
In Bach Mai Hospital, we do echocardiography as the first choice for screening and for assessing the NV morphology and function, and we also do a CMR for the hypertrophic cardiomyopathy.
Excellent. Let me also ask you, Dr. Huai, on the same topic of hypertrophic cardiomyopathy, do you use stress testing at all in this patient population? And if so, what are you looking for?
Yes, we do stress echo for hypertrophic cardiomyopathy for patient who has who do not have who is asymptomatic but has a height gradient, or who has who is symptomatic but the gradient is not high enough, and we look for the response of the blood pressure, of the BP, of the heart rate, and the heart rate recovery, and also the gradient, NVOT gradient, and the pulmonary artery pressure.
Yeah, excellent. Yeah, we do a very similar thing, and you know, that burden of arrhythmias that are generated also in stress ends up being a very good prognostic sign for patients, and helps also determine, in some cases, what we're going to be doing with ICDs and such. We have another question for Dr. Lanspa here. You showed a case in which PEEP increased to 14, the RV was more dilated, and its function was significantly diminished. And in that case, what would be your threshold for PEEP that you would find acceptable?
So if we were to take the best level of evidence right now for acute respiratory distress syndrome, which is what that patient had, it would depend on how much oxygenation they needed. And as the fraction of inspired oxygen increases, we go up on the PEEP as well. The literature suggests higher PEEP is probably better than lower PEEP, although that is not a randomized controlled trial. That's what has been used in most of the highest quality literature. As far as what threshold, I start to get uncomfortable when the PEEP is in the 15 to 20 range. I have rarely gone over 22. The reason I show that is not so much to recognize a PEEP at which I should stop up titration, but rather those are patients in whom a rapid up titration of PEEP is, to me, much more dangerous. And the reason that came about is we were participating in a randomized controlled trial where we had to get people rapidly onto a higher PEEP protocol, and we recognized that it caused hypotension in a substantial number of patients. So what I will do if I need to increase the PEEP due to hypoxemia is I will slowly ramp up if I see that the right ventricle is expanding or dilated, or if its function decreases. If the RV is clinically looking okay, I have more confidence with it, but all of this is me basing this off a physiologic principle. There is not high quality data to justify this, and so that's why I wouldn't advocate a PEEP threshold.
Excellent answer. Dr. Huang, when we assess cardiac chamber volume, should we correct it to heart rate and blood pressure? Specifically in mitral regurgitation and aortic regurgitation?
Interesting, great question. I typically don't do that. Although, you know, I can imagine if the patient has high blood pressure in a setting of significant mitral regurgitation, the volume would be higher. And similarly with heart rate, I would assume the volumes of the cardiac chambers would increase as well. But I don't know if there's any data to suggest that, but I personally don't correct it myself.
Nina, what would you say? Dr. Ricchetti may have stepped out. This is another phenomenal question. I absolutely agree. I don't know of any data that suggests that we should be doing that, especially in making decisions using our usual cutoffs of chamber volume size that are mentioned in the guidelines. However, I do think this is a great idea. And to be honest, when I'm doing a transesophageal echo, looking at mitral regurgitation, we always document the blood pressure on the screen, because a lot of times patients, at least in the United States, are fairly significantly sedated. They're not as hardy as Vietnamese patients. They require a lot more sedation to undergo transesophageal echo, and that will drop the blood pressure and affect the mitral regurgitation, making it potentially look a lot better than it really is on transthoracic imaging. But if we don't know what the blood pressure is, we can't sort of correct that in our minds and make that adjustment when we consider it. Sometimes, particularly in the operating room or the procedure lab, the anesthesiologist might actually give a pressor agent in order to raise the blood pressure and see what happens to the valvular lesions in those cases. So really a very insightful question. I think we need more research to be able to try to figure out what the outcomes are in different chamber volume sizes according to blood pressure, especially when we're thinking about mitral regurgitation. All righty. Are there any other comments that any of our panelists would like to make? All right. Well, I am going to turn it over to Dr. Huai for some concluding and summary remarks, but just thank everybody for a phenomenal session.
Thank you so much. Thank you so much, Professor James Kirkpatrick, and thank you all the excellent speakers for the wonderful session, which gave us so many beautiful, brilliant presentations and lectures, and we learned so much from you and from the presentation and from the interesting Q&A parts. We look forward to more wonderful conference. Thank you so much. Jim, could you please give some wrap up?
I would be very happy to. And thanks to everybody for being here and participating. Again, just phenomenal questions, as we've already said. Well, today we learned quite a bit. We learned quite a bit about a variety of different important imaging topics. They ranged across a very broad spectrum. We're so thankful for all of our speakers, for Dr. Huang for telling us a lot about stress testing and the multimodality nature. We may not all have access to all these modalities, but understanding the strengths and weaknesses of each one of them is vitally important as we make good choices about stress testing modalities and understanding how to interpret the results. We're so grateful for Dr. Lanspa being able to give us an amazing talk about this emerging field of critical care echo. He educated all of us tremendously about particularly the use of some parameters that cardiologists don't know as much about, but we need to know more about them, particularly lung scanning, the use of hemodynamics for guiding ventilator management and other management in the ICU. We're so grateful for Dr. Lanspa and his really pioneering work in both research and in education in this. With many thanks to Dr. James Lee and his innovative talk on left atrial appendage occluder devices. He is an expert in the field. He gave us some very practical tips, showed us many of the ways that they do it at Henry Ford, which is really a leader of interventional echo, and we're grateful that he was able to tell us that. And thanks so much to Dr. Raschetti. She did a phenomenal job going over diastolic dysfunction, a very difficult topic, but she did it in a short period of time and in a very practical way that gave us a lot of excellent tips on how to address this. And I want to thank Dr. Huang once again for pitch hitting, for coming in, giving us an excellent overview of aortic stenosis and mitral regurgitation, two extremely important valvular lesions. And I really appreciated the fact he took us back to the physical exam as something that as imagers we tend to forget, but we shouldn't forget it. We need to continue to develop our skills. It's really a complement to imaging, not something that imaging is necessarily going to replace. I gave a few remarks about appropriateness. The only thing I would say about that is that I would just encourage all practitioners of multimodality imaging in Vietnam to think about what are the best ways to utilize imaging in your context. Certainly the appropriate use criteria can give some guidance, but ultimately this is in many ways dependent on local expertise, where people are at, what is available, and also sort of the disease processes that are encountered frequently. So I think Vietnamese appropriate use criteria would be very appropriate to consider and in guidance of imaging modalities. Well, I hope I didn't leave anyone out with that, but I did want to thank Dr. Huai for an amazing job putting this session together, organizing it along with the other members who have participated in putting this together. Thank you to the audiovisual people and the secretaries in this great Congress. We really appreciate it. And on behalf of the American Society of Echo, I wish you all a tremendous Congress.
Thank you so much, Jim. Thank you, everybody.
Take care.
Thank you
so much.
Giá như tôi được chẩn đoán bệnh tăng huyết áp sớm hơn và giá như tôi tuân thủ sự điều trị của bác sĩ tốt hơn thì tôi sẽ không bị biến chứng như vậy.
Hearts struggling to keep pace, gaining momentum at all cost, pushing boundaries, further and beyond. We are in overdrive. Time to take control.
Recording in progress.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
At Viatris, we aim to empower people worldwide to live healthier at every stage of life. We're dedicated to delivering increased access to the medicines patients need, regardless of geography or circumstance. Because at Viatris, we believe in healthcare, not as it is, but as it should be.
Rồi chào Thắng ơi. Chưa bật mic Thắng ơi.
Dạ em chào thầy ạ. Thầy khỏe không thầy?
Thầy khỏe, cảm ơn Thắng. Bên Thắng ổn định chưa?
Dạ tạm tạm rồi thầy.
Giờ vẫn là phân đôi nhiệm vụ hả Thắng? Vừa Covid một bên là không Covid đúng không?
Dạ
là dạng
Covid còn khoảng 100 bệnh nhân ạ.
Dữ dằn ha.
Dạ. Nó còn giảm bớt bỏ bớt khoảng 5 khoa rồi. Tôi chưa 8 khoa Covid rồi.
Ồ dữ dằn ha.
Dạ.
Cái thứ tự báo cáo là Huy báo cáo trước rồi Thắng báo cáo sau hả Thắng?
Dạ.
Cái PGS của Thắng hình như là Thắng chưa có chiêu đãi nha. Chưa chiêu đãi là coi như chưa biết nha.
Bây giờ là đúng giờ rồi, không biết mình bắt đầu chưa hay là chờ ha? Huy chưa thấy vô ha?
Huy như có gửi bài thôi thầy, em nghe nói gửi bài chứ không có bài.
Xin kính chào quý đồng nghiệp. Chúng ta đều biết là statin là một trong những cái liệu pháp cực kỳ quan trọng giúp kéo dài tuổi thọ cho bệnh nhân. Và có thầy thuốc tim mạch đã nói là statin là cái biện pháp duy nhất mà một người thầy thuốc nội khoa có thể sử dụng để kéo dài tuổi thọ cho bệnh nhân cũng như là giảm các biến cố tim mạch. Và kể từ khi xuất hiện, liệu pháp statin đã trải qua nhiều giai đoạn, trong đó có những lúc bị nghi ngờ là làm tăng cái nguy cơ ung thư hay là tăng cái nguy cơ Alzheimer, vân vân. Và cái câu hỏi đặt ra là đối với những bệnh nhân đã quá cao tuổi hay là những bệnh nhân đã có biến cố tim mạch do xơ vữa thì cái giá trị của statin có còn hay không? Thì thông qua cái buổi hội thảo ngày hôm nay, chúng ta sẽ cập nhật những cái thông tin mới trong cái điều trị dự phòng nguyên phát, tức là khi chưa có biến cố tim mạch, lẫn dự phòng thứ phát, tức là khi bệnh nhân đã có biến cố tim mạch. Và để bắt đầu chương trình, chúng tôi xin kính mời tiến sĩ Đinh Đức Huy báo cáo cái chủ đề đầu tiên. Xin kính mời.
Kính thưa quý đồng nghiệp, bài báo cáo của chúng tôi liên quan đến hiệu quả và an toàn của statin trong phòng ngừa biến cố tim mạch tiên phát. Đây là chúng ta thấy là 10 cái thông điệp mà Hội Tim Hoa Kỳ năm 2019 đã đưa ra đối với phòng ngừa biến cố tiên phát, các cái biến cố tim mạch. Thì trong đó có 2 mục có liên quan đến điều trị statin. Ở mục số 3 thì chúng ta thấy là các cái bệnh nhân mà từ 40 đến 75 tuổi thì nên được đánh giá nguy cơ bệnh tim mạch do xơ vữa 10 năm. Và trước khi bắt đầu điều trị, ví dụ như điều trị tăng huyết áp, điều trị aspirin hoặc điều trị statin, thì ACC khuyến cáo là bệnh nhân và thầy thuốc nên có một cái trao đổi rõ ràng với nhau để biết được các cái lợi ích cũng như các cái nguy cơ. Điều số 8 trong cái bản hướng dẫn này chúng ta thấy là statin là điều trị đầu tay để phòng ngừa tiên phát các cái biến cố tim mạch do xơ vữa ở bệnh nhân tăng cholesterol máu với LDL-C trên 190 mg/trăm, các bệnh nhân đái tháo đường, các bệnh nhân từ 40 đến 75 tuổi sau khi đã được trao đổi về nguy cơ lợi ích với thầy thuốc. Vậy thì làm thế nào mà chúng ta có thể tính toán cái nguy cơ tim mạch 10 năm? Thì chúng ta thấy là chúng ta có rất là nhiều cái công cụ. Ở đây là một cái công cụ từ cái trang web MD Calculate. Chúng ta thấy là chúng ta chỉ việc điền vào một số những thông tin, ví dụ như tuổi, bệnh nhân có đái tháo đường hay không, giới tính của bệnh nhân, chủng tộc, tình trạng thuốc lá và lượng cholesterol toàn phần và cái con số huyết áp, thì lập tức chúng ta sẽ có cái nguy cơ. Ví dụ chúng ta có bệnh nhân nam 75 tuổi, đái tháo đường, bệnh nhân chủng tộc da vàng, bệnh nhân không có hút thuốc lá và cholesterol toàn phần là 5,6 mmol trên lít. Chúng ta thấy là tính ra cái nguy cơ của bệnh nhân là 56,1%, nguy cơ rất là cao. Và trong trường hợp này thì statin cường độ cao được khuyến cáo cho bệnh nhân để giảm biến cố tim mạch tiên phát. Và bảng này cũng cho ta biết là nếu mà chúng ta tính điều trị tích cực cho bệnh nhân, giảm cái yếu tố nguy cơ, thì chúng ta giảm từ 5,6,1% xuống 18,6%. Ngược lại, chúng ta thấy là nếu mà chúng ta gặp một bệnh nhân nữ 45 tuổi, da vàng, không hút thuốc lá, chỉ tăng cholesterol toàn phần là 5,2 mmol trên lít, huyết áp tâm thu là 140 mm thủy ngân, thì chúng ta thấy là cái nguy cơ rất là thấp, chỉ có 2%. Và nếu mà chúng ta có điều trị tối đa thì chúng ta giảm xuống 0,5%. Và trong trường hợp mà chỉ có 2,5% như vậy, tức là bệnh nhân thuộc nhóm nguy cơ thấp, thì khuyến cáo đề ra là bệnh nhân chưa cần thiết phải điều trị bằng statin, và chúng ta nên khuyến khích bệnh nhân thay đổi lối sống, hoặc là nếu mà bệnh nhân chưa có chế độ tập thể dục thể thao thường xuyên thì bệnh nhân nên bắt đầu một cái chế độ tập luyện cho nó phù hợp trước khi mà chúng ta bắt đầu điều trị statin cho bệnh nhân. Đây là guideline chung tổng thể, thì chúng ta thấy là có một cái nhóm, tức là nhóm có LDL-C rất là cao trên 190 mg/trăm, thì guideline khuyến cáo là chúng ta điều trị statin cường độ mạnh ngay từ đầu. Class 1, bệnh nhân đái tháo đường từ 40 đến 75 tuổi thì có thể bắt đầu bằng cái statin cường độ trung bình, cũng là khuyến cáo Class 1. Đối với bệnh nhân tiểu đường 40 đến 75 tuổi, chúng ta đánh giá nguy cơ và sau đó chúng ta có thể sử dụng cái statin cường độ cao Class 2A. Còn phần lớn các bệnh nhân còn lại thì chúng ta thấy là chúng ta sẽ dựa vào cái thang điểm ASCVD 10 năm để phân tầng nguy cơ. Dưới 5% là bệnh nhân nguy cơ thấp, và trên 20% là bệnh nhân nguy cơ rất cao, trung bình là từ 7,5 cho đến 20%. Nếu bệnh nhân ở nguy cơ rất cao thì chúng ta thấy là statin được chỉ định ngay từ đầu với mục tiêu ban đầu là giảm được LDL-C trên 50%. Tô màu xanh lá cây tức là Class 1. Bệnh nhân nguy cơ thấp thì chúng ta chỉ cần khuyến khích bệnh nhân là thay đổi lối sống, cải thiện các yếu tố nguy cơ. Nếu bệnh nhân ở cái nhóm mà từ 7,5 cho đến dưới 20% thì chúng ta thấy là thảo luận với bệnh nhân, nếu mà bệnh nhân đồng ý điều trị statin thì chúng ta có thể bắt đầu một cái statin cường độ trung bình với cái mục tiêu để giảm LDL-C xuống 30 đến 49%. Sau khi chúng ta đã bắt đầu điều trị statin rồi, chúng ta có thể xem xét thêm một số cái yếu tố khác, ví dụ điểm canxi hóa trên cái hình chụp mạch vành của bệnh nhân, để chúng ta có thể quyết định coi là bệnh nhân có cần phải một cái statin điều trị cường độ mạnh hơn hay không. Một câu hỏi hay đặt ra trong điều trị phòng ngừa tiên phát là bệnh nhân lớn tuổi trên 70 tuổi thì điều trị statin có đem lại lợi ích thực sự hay không. Nghiên cứu thực hiện ở Mỹ, chúng ta thấy là với cái tiêu chí đánh giá chính là tử vong do mọi nguyên nhân và tử vong tim mạch ở nhóm bệnh nhân trên 75 tuổi và không hề có biến cố tim mạch sơ vữa trước đó, theo dõi trong vòng gần 7 năm. Phần lớn bệnh nhân trong nghiên cứu này là nam, và chúng ta thấy là người ta ghi nhận được 326.000 bệnh nhân mà có hơn 206.000 tử vong và hơn 53.000 tử vong tim mạch. Thì rõ ràng nếu mà chúng ta so sánh ở nhóm mà điều trị statin so với không điều trị statin đó, thì P ở đây chúng ta thấy là đều dưới, nhỏ hơn 0,001 ở cả các biến cố tử vong do mọi nguyên nhân và tử vong tim mạch. Thành ra các nhà nghiên cứu này đã kết luận là sử dụng statin để phòng ngừa tiên phát cho bệnh nhân trên 75 tuổi thì giúp giảm cái biến cố tim mạch do mọi nguyên nhân và tử vong do nguyên nhân tim mạch. Đối với điều trị tiên phát thì chúng ta thấy là từ rất lâu là chúng ta đã biết là LDL-C càng thấp thì kết quả của bệnh nhân càng thuận lợi. Đây là cái biến cố đột quỵ. Chúng ta thấy là nếu mà chúng ta giảm được 1 mmol LDL-C cholesterol thì chúng ta có thể giảm được cái nguy cơ đến 21%. Và nếu mà chỉ tính riêng là cái nguy cơ mà đối với các nghiên cứu mà phòng ngừa tiên phát thì thậm chí chúng ta còn giảm được nhiều hơn đến 36%. Đây là bảng cho chúng ta biết là các cường độ, các độ mạnh của statin. Ví dụ nếu mà chúng ta sử dụng atorvastatin 40 cho đến 40 mg hoặc là rosuvastatin 20 mg thì chúng ta sử dụng với cái mức độ là cường độ mạnh và chúng ta hy vọng là giảm được trên 50% LDL-C. Trung bình thì chúng ta thấy là có atorvastatin từ 10 đến 20 mg và rosuvastatin khoảng 5 đến 10 mg. Còn nếu mà chúng ta chỉ điều trị simvastatin 10 mg thì cường độ của điều trị statin của chúng ta là yếu. theo các cái guideline hiện tại thì chúng ta biết là với cái statin mà cường độ mạnh á, thì chúng ta điều trị khoảng 20 bệnh nhân thì chúng ta sẽ giảm được với một cái biến cố tim mạch. Còn đối với statin mà cường độ trung bình thì chúng ta cần điều trị khoảng 30 bệnh nhân để chúng ta giảm một cái biến cố tim mạch do xơ vữa. 2021 thì ESC cũng có guideline mới về phòng ngừa biến cố tim mạch, và các yếu tố nguy cơ trong ESC 2021 cũng được nhấn mạnh lại, trong đó cholesterol máu được gọi là được xếp vào cái nhóm yếu tố nguy cơ tim mạch số 1. Thì chúng ta thấy là năm nay ESC đưa ra khái niệm là non-HDL cholesterol để tính điểm score 2 hoặc là score 2 OP, chính là hiệu số giữa cholesterol toàn phần và HDL cholesterol. Năm nay ESC thì chia bệnh nhân ra, ví dụ bệnh nhân mà chúng ta bệnh nhân người khỏe không có yếu tố bệnh lý tim mạch trước đó thì tùy theo độ tuổi từ 50 đến 69 hoặc trên 70 thì bệnh nhân sẽ được xếp vào cái nhóm nguy cơ tim mạch từ thấp tới cao hoặc là từ thấp tới rất cao. Tuy nhiên nếu bệnh nhân bệnh thận mạng thì chúng ta thấy là chỉ có 2 ô thôi, ô nguy cơ cao và yếu tố ô nguy cơ rất cao. Bệnh nhân đái tháo đường thì cũng được xếp ở cái nhóm ít nhất là cái nhóm mà nguy cơ trung bình, tức là các bệnh nhân đái tháo đường dưới 10 năm. Còn bệnh nhân còn lại thì là nguy cơ cao, bệnh nhân đã có biến cố tim mạch thì nguy cơ rất cao. Và đối với người khỏe thì sau khi chúng ta đánh giá cái nguy cơ tim mạch 10 năm của bệnh nhân bằng sang điểm score 2 đối với bệnh nhân trẻ dưới 69 tuổi và score 2 OP đối với bệnh nhân trên 70 tuổi thì chúng ta sẽ đưa ra các cái mục tiêu điều trị. Huyết áp phải dưới 140 mm thủy ngân và LDL-C phải dưới 2,6 mmol trên lít. Cho dù là người dưới 70 tuổi hay là người trên 70 tuổi. Ở bước tiếp theo thì đối với nhóm bệnh nhân dưới 70 tuổi thì sau khi đã lượng định thêm các cái bệnh lý kèm theo thì chúng ta thấy là chúng ta phải kiểm soát huyết áp chặt chẽ, đồng thời với đưa LDL-C cholesterol xuống ở mức 1,8 mmol trên lít đối với bệnh nhân nguy cơ cao, và bệnh nhân nguy cơ rất cao là 1,4 mmol trên lít. Đối với bệnh nhân cao tuổi thì các cái mục tiêu nó không có chặt chẽ như là nhóm bệnh nhân trẻ tuổi. Vậy thì nếu chúng ta đưa cái LDL-C xuống rất thấp thì nó có an toàn hay không? Thì chúng ta thấy là từ cái trường nghiên cứu Odyssey phân tích dữ liệu từ 14 thử nghiệm lâm sàng, trong cái nhóm này thì người ta sử dụng cái PCSK9 với thời gian theo dõi là 104 tuần, thì thấy là ngay cả đưa cái nhóm mà bệnh nhân có LDL-C xuống dưới 25 mg% so với cái nhóm mà trên 25 mg% thì các cái biến cố về nhận thức nó không có khác nhau, nghĩa là LDL-C rất thấp vẫn an toàn cho bệnh nhân. Mức độ an toàn đối với người cao tuổi như thế nào? Đây là cái nghiên cứu của statin công bố gần đây trong năm 2021 về vấn đề suy giảm nhận thức cũng như là các cái suy giảm trí nhớ ở nhóm bệnh nhân trên 65 tuổi theo dõi khoảng 5 năm. Đây cũng là phòng ngừa tiên phát, chúng thấy bệnh nhân không có biến cố tim mạch trước, không có cái biến cố về thần kinh trước, không có cái biến cố về vận động, về suy giảm vận động trước đó. Chúng ta thấy là kết luận cho dù là cái suy giảm trí nhớ do mọi nguyên nhân có liên quan đến bệnh Alzheimer hay không thì chúng ta thấy là statin, điều trị statin nó không làm ảnh hưởng người bệnh. Các cái biến cố bất lợi của statin chúng ta đều biết là bệnh nhân có thể có đau cơ, nặng nề nhất là cái hủy cơ thì cái biến cố nó rất là thấp. Biến cố hay được nói tới là cái khởi phát của đái tháo đường thì chúng ta thấy là chỉ có ở một số nhóm bệnh nhân mà ví dụ như béo phì hoặc là đã có cái tình trạng đường huyết lúc đó tăng cao trước đó thôi, thì cái nhóm này nguy cơ hơn những nhóm còn lại. Còn cái nhóm còn lại ví dụ như tăng men gan hoặc là bệnh lý gan thì là rất hiếm hoặc là rất thấp. So sánh atorvastatin ở người châu Á so với các cái chủng tộc còn lại thì chúng ta thấy nghiên cứu năm 2016 của tác giả Chan và cộng sự, người ta thống kê lại hơn 100 cái thử nghiệm lâm sàng với atorvastatin từ năm 92 cho đến 2012, và người ta so sánh ở nhóm bệnh nhân châu Á so với nhóm bệnh nhân khác. Tổng số bệnh nhân trong cái nghiên cứu này là gần 78.000 bệnh nhân, trong đó cái nhóm chủng tộc châu Á là chiếm hơn 3.000 bệnh nhân, và lượng định cái yếu tố an toàn. Thì kết quả cho thấy là các cái tác dụng phụ hoặc là các biến cố bất lợi hoặc là cái việc mà chúng ta phải chấm dứt điều trị statin thì ở bệnh nhân châu Á thì nó cũng tương đồng với các cái nhóm chủng tộc khác. Và chúng ta thấy người ta đi qua rất là nhiều liều khác nhau, từ liều atorvastatin thấp 10 mg, atorvastatin trung bình 20 mg cho tới atorvastatin liều cao là 80 mg, thì chúng ta thấy là các cái liều, cho dù chúng ta tăng liều sử dụng cao thì cái biến cố bất lợi đối với bệnh nhân châu Á hoặc là các chủng tộc khác thì rất ít. Để kết luận bài nói thì chúng tôi xin có vài ý. Thứ nhất là để trong cái phòng ngừa tiên phát thì việc đánh giá nguy cơ tim mạch 10 năm bằng cái thang điểm ESCVD là một cái công cụ rất quan trọng để chúng ta phân tầng nguy cơ của bệnh nhân. Năm nay ESC 2021 thì đưa ra hai cái thang điểm là score 2 và score 2 OP để lượng giá nguy cơ tim mạch của bệnh nhân, và để từ đó chúng ta có một cái chiến lược tiếp cận phù hợp. Cho đến bây giờ thì mọi người đều đồng thuận là nếu chúng ta giữ được cái LDL-C càng thấp thì tiên lượng bệnh nhân sẽ càng tốt hơn, và ngay cả khi chúng ta kéo LDL-C xuống rất thấp thì cũng không hề làm gây ra các biến cố bất lợi về thần kinh cho bệnh nhân. Mục tiêu LDL-C cholesterol của điều trị statin của chúng ta trong phòng ngừa tiên phát thì chủ yếu sẽ được quyết định dựa trên cái phân tầng nguy cơ của bệnh nhân. Bệnh nhân nguy cơ rất cao thì chúng ta cần cái lượng LDL-C đưa xuống rất thấp. Ví dụ mục tiêu hiện tại mọi người đồng thuận là chúng ta có thể kéo tới khoảng 1,4 mmol trên lít. Và ngay cả đối với người cao tuổi thì chúng ta thấy là điều trị phòng ngừa tiên phát với statin cũng rất là hiệu quả và an toàn. Chúng tôi xin cảm ơn sự chú ý lắng nghe của quý đồng nghiệp.
Xin cảm ơn tiến sĩ Đinh Đức Huy. Và một cái phân nhóm bệnh nhân được nghiên cứu, đó là những cái bệnh nhân đã bị biến cố tim mạch nặng, tức là đã bị tai biến mạch máu não. Thì đối với cái dân số này, chúng tôi xin mời Phó Giáo sư tiến sĩ Nguyễn Huy Thắng báo cáo về cái vấn đề điều trị giảm cholesterol máu sau khi bệnh nhân đã bị đột quỵ. Điều trị như thế nào, lúc nào, giảm xuống bao nhiêu và thời gian điều trị là bao lâu. Xin kính mời Phó Giáo sư tiến sĩ Nguyễn Huy Thắng.
Kính thưa thầy, giáo sư và thành nhân, kính thưa các anh chị đồng nghiệp. Hôm nay tôi xin được trình bày một cái đề tài về cái vai trò của statin. Như ta biết rằng statin hiện nay có một cái vai trò cũng rất quan, không chỉ ở tim mạch mà cũng rất quan trọng đối với các cái bệnh lý đột quỵ, đặc biệt là các cái bệnh nhân mà đột quỵ liên quan đến các yếu tố xơ vữa. Tuy nhiên một cái vấn đề đặt ra cho một cái bệnh nhân sau khi đột quỵ xơ vữa, chúng ta có nên sử dụng statin hay không, khi nào chúng ta nên sử dụng, và sử dụng bao lâu và chúng ta kéo dài bao lâu, là một cái câu hỏi mà chúng ta thường gặp trên các cái bệnh nhân mà chúng ta phải đối diện ở lâm sàng hàng ngày. Để bắt đầu thì tôi xin được trình bày một cái trường hợp bệnh nhân của tôi. Đó là một cái bệnh nhân 67 tuổi. Bệnh nhân này nhập viện vì hôn mê. NIST ban đầu là 34 điểm, tức là bệnh nhân này là một cái đột quỵ rất nặng, gần như bệnh nhân này liệt tứ chi và hôn mê. Bệnh nhân nhập viện lúc 12 giờ trưa, và thời điểm mà bệnh nhân còn bình thường lúc là 1 giờ sáng là thời điểm bệnh nhân đi ngủ. Thì trên cái CT scan đầu tiên tôi chụp đó, thì các đồng nghiệp có thể thấy rằng bệnh nhân này đã có một cái tổn thương nhỏ thôi ở ngay cái vùng cạnh giữa cầu não bên phải. Tuy nhiên nếu chúng ta nhìn vào động mạch thân nền của bệnh nhân này bị đứt, bị tắc hoàn toàn cái đoạn gốc của động mạch thân nền. Cho biết rằng đối với trong đột quỵ, tắc động mạch thân nền là một cái nguyên nhân mà nặng, được xem là nặng nhất trong tất cả các cái mạch máu, bởi vì nó cung cấp máu cho cái vùng cầu não, được xem là những cái trung tâm thần kinh, những cái trung tâm tim mạch, những trung tâm hô hấp đều nằm ở khu này. Và những cái bệnh nhân theo y văn, những cái bệnh nhân mà tắc động mạch thân nền mà nếu như chúng ta không tái thông được đó, thì cái khả năng tàn phế cũng như tử vong lên đến 90%. Và hiện nay chúng ta biết rằng cái cái cửa sổ chúng ta điều trị TB đường tĩnh mạch hiện nay cho phép là 4 giờ rưỡi. Tuy nhiên đối với tắc động mạch thân nền thì hầu như tất cả các chuyên gia đều đồng thuận rằng chúng ta có thể mở rộng cửa sổ thời gian tiêu hủy đường tĩnh mạch cho các bệnh nhân tắc động mạch thân nền, bởi vì cái hậu quả của nó quá nặng nề. Và ngoài ra, một trong những cái điều mà chúng ta có thể an tâm đó là đối với những cái tế bào não ở vùng thân não đó, thì cái sức chịu đựng của nó cũng như khả năng chuyển dạng xuất huyết mà liên quan đến thuốc TPA nó sẽ thấp hơn rất nhiều so với những nhu mô não ở tuần hoàn trước. Bệnh nhân này rất may mắn, bởi vì sau khi chúng tôi sử dụng cái TPA đường tĩnh mạch đó, thì các anh chị có thể thấy rằng cái động mạch đây là cái thời điểm mà bệnh nhân này đã có cái hiện rõ rệt, và các thang điểm NIST bệnh nhân lúc xuất viện chỉ còn có 8 điểm, và bệnh nhân này cái Modified Ranking 3 điểm là sau 3 tháng. Modified 3 điểm tức là bệnh nhân có thể đi lại được nhưng với sự trợ giúp. Và các anh chị thấy rằng sau 24 giờ khi chúng tôi chụp lại CT scan thì với cái liều TPA nó đã làm tái thông cái động mạch thân nền. Và trên cái MRI chụp sau đó các anh chị thấy rằng bệnh nhân này chỉ có nhồi máu giống như cái ban đầu, tức là nhồi máu ở vùng cạnh giữa cầu não bên phải. Tuy nhiên các anh chị thấy rằng mặc dù chúng ta tái thông mạch thân nền nhưng mà chúng ta thấy rằng cái bệnh nền của bệnh nhân này rất rõ là một cái xơ vữa rất nặng ở các động mạch cột sống, đặc biệt cột sống bên phải và các động mạch thân nền. Dù chúng ta tái thông được nhưng mà cái tổn thương xơ vữa hẹp trên 70% vẫn còn ở động mạch thân nền. Vấn đề đặt ra khi ta nhìn lại tiền căn của bệnh nhân này, bệnh nhân này hoàn toàn không có tiền căn đột quỵ trước đó. Bệnh nhân này cũng chỉ có tiền căn cao huyết áp, tuy nhiên bệnh nhân này không điều trị thường xuyên. Các cái dung mạo lipid tôi thấy rằng cái LDL của bệnh nhân này là 120 mg dl, cái triglyceride của bệnh nhân này là 125, và cái đường huyết của bệnh nhân này cũng trong ở giới hạn bình thường, tức là khoảng 110 mg/%, HbA1c là 6%. Như vậy vấn đề đặt ra cho các bệnh nhân này chúng ta sẽ bắt đầu bằng cái cách nào để chúng ta làm giảm cái LDL cũng như là làm giảm cái quá trình xơ vữa của bệnh nhân này. Nếu như chúng ta nhìn đây là một cái phân tích gộp bao gồm khá nhiều các thử nghiệm mà bản thân chúng ta vẫn thường khuyên các bệnh nhân sử dụng để kiểm soát cái dung mạo lipid, ví dụ như chế độ ăn, ví dụ như fibrat, ví dụ như cái resin hoặc là cái omega 3. Thì tất cả những các biện pháp này bao gồm tất cả khoảng hơn 30 thử nghiệm lâm sàng, và người ta xem tất cả các phương pháp này có tác động gì đến làm giảm các biến cố đột quỵ hay không. Thì chúng ta thấy rằng tất cả các phương pháp này đều không làm thay đổi, làm giảm bớt được cái nguy cơ đột quỵ. Chúng ta có thể làm thay đổi cái dung mạo lipid nhưng chúng ta không thể làm giảm được các biến đột quỵ qua hơn 30 cái thử nghiệm lâm sàng này. Và đối với khi mà chúng ta phải dùng thuốc thì hiện nay chúng ta có thể dùng statin. Tuy nhiên chúng ta thấy rằng đối với hiện nay các nghiên cứu mà trên các cái bệnh nhân mà đột quỵ đó gần như rất ít. Gần như tất cả các cái nghiên cứu lâm sàng đều tập trung cho các cái bệnh lý tim mạch, các bệnh lý mạch vành hoặc là bệnh nhân chưa có mạch vành, như là phòng ngừa các bệnh nhân yếu tim mạch. Và đối với đột quỵ gần như chỉ có duy nhất là một cái nghiên cứu rưỡi. Tại vì sao nói một nghiên cứu rưỡi? Bởi vì duy nhất là nghiên cứu Sparkle được lấy bệnh là những cái bệnh nhân chuyển bệnh là những cái bệnh nhân mà có tiền căn đột quỵ hoặc là cơn thiếu não. Và nghiên cứu thứ hai được xem là phân nửa, bởi vì cái SPS là một nghiên cứu mà nó có một cái tỷ lệ khá đáng kể các bệnh nhân đã bị đột quỵ rồi. Đầu tiên chúng ta sẽ xem đến cái nghiên cứu mà SPS là Heart Protection Study. Trong nghiên cứu này thì người ta chỉ bao gồm những cái bệnh nhân mà có bệnh lý mạch vành, có tiền căn mạch vành hoặc bệnh lý mạch vành, những đặc biệt là ngoài ra không chỉ mạch vành mà người ta còn có một cái tỷ lệ các bệnh nhân đột quỵ, và tỷ lệ đột quỵ chiếm tỷ lệ khoảng 3.280 bệnh nhân, tức là chia trên tổng số 20.000 bệnh nhân thì nó chiếm một tỷ lệ cũng khá khiêm tốn, tức là nó chiếm tỷ lệ khoảng tầm 15% trong tổng số các bệnh nhân thôi. Và nghiên cứu này được chia làm 2x2, một thử nghiệm giữa cái simvastatin, trong một đó có một cái nhánh người ta sử dụng cái simvastatin 40 mg và so với giả dược. Và trong nghiên cứu này thì các anh chị thấy rằng nếu như chúng ta xét chung về tất cả các biến cố bao gồm đột quỵ cũng như các biến cố tim mạch thì simvastatin làm giảm khoảng 24% các biến cố về tim mạch cũng như đột quỵ. Tuy nhiên chúng ta thấy rằng riêng trên cái nhóm các bệnh nhân đột quỵ đó thì có sự khác biệt rất lớn giữa các bệnh nhân đã bị đột quỵ rồi và những bệnh nhân chưa bị đột quỵ. Người ta thấy rằng cái lợi ích của simvastatin chủ yếu đến là nhờ vào trên các cái phân nhóm bệnh nhân chưa bị đột quỵ. Còn trên bệnh nhân đã bị đột quỵ rồi đó thì cái lợi ích của statin và placebo là không khác biệt rõ rệt. Và điều này chúng ta cũng thấy rằng đó là đối với các cái biến cố mà tim mạch chính quan trọng thì cái simvastatin làm giảm rõ rệt. Tuy nhiên đối với các biến cố về đột quỵ thì không có sự khác biệt giữa simvastatin và placebo. Nguyên nhân tại sao? Vấn đề thứ nhất đó là đây là một cái phân tích dưới nhóm và chúng ta không có gì đưa trước trong cái thiết kế nghiên cứu này. Thứ hai là cái tỷ lệ các bệnh nhân đột quỵ trong nghiên cứu này cũng còn rất là nhỏ, chỉ có 15% thôi. Và quan trọng hơn là cái nghiên cứu này nó bao gồm những bệnh nhân đột quỵ và cái thời điểm trung bình mà người ta đưa vào nghiên cứu này là 4.3 năm sau khi các cái biến cố đột quỵ xảy ra. Và chúng ta biết rằng cái nguy cơ một cái đột quỵ tái phát nó nằm chủ yếu nằm trong vài tháng đầu, vài tuần đầu, hoặc tối đa là khoảng chừng 1 năm đến 2 năm đầu thôi. Và khi chúng ta đưa vào tuyển bệnh một cái nhóm bệnh nhân mà gần như ổn định suốt hơn 4 năm trời, thì cái khả năng các biến cố đột quỵ tái phát nó sẽ rất thấp và rất khó để chúng ta thấy được cái lợi ích của statin. Và nguyên nhân cuối cùng có lẽ đây là cái statin này nó không đủ mạnh chăng, tuy nhiên điều đó chúng ta không thể kết luận được. Đó là lý do tại sao mà năm 2006 người ta phải làm lại một cái nghiên cứu mà đặc biệt cho các bệnh nhân đột quỵ. Trong nghiên cứu này nó quan trọng hơn cái nghiên cứu SPS bởi vì nó không bao gồm các bệnh nhân tim mạch. Điều này rất quan trọng bởi vì nếu như chúng ta bao gồm những bệnh nhân có bệnh tim mạch đó, thì chúng ta đã biết chắc rằng cái statin đã được chứng minh được làm giảm các biến cố, mang lại lợi ích cho các bệnh nhân tim mạch. Và như vậy điều đó nếu chúng ta đưa vào sử dụng so sánh giả dược, điều đó nó hoàn toàn vi phạm y đức. Do đó cái nghiên cứu này nó chỉ bao gồm các bệnh nhân đột quỵ hoặc là cơn thiếu não, và quan trọng hơn là nó chỉ bao gồm từ 1 đến 6 tháng, chứ không phải một thời gian rất dài giống như 4 năm gần 4 năm rưỡi như trong cái nghiên cứu SPS. Và cái LDL ban đầu nó ở dưới khoảng từ 100 đến 190 mg/dl, và nghiên cứu này thu thập là 4.731 bệnh nhân và đưa vào hai nhóm, một nhóm sử dụng atorvastatin liều 80 mg và so với giả dược. Và chúng ta thấy rằng cái nghiên cứu này cái kết cục endpoint đó là các bệnh đột quỵ tử vong hoặc là không gây tử vong. Và chúng ta thấy rằng sau một thời gian khoảng 5 năm thì cái so với cái LDL ban đầu là 133 ở nhóm chúng ta sử dụng atorvastatin thì cái LDL trung bình là còn giảm xuống còn 73 so với 129 ở nhóm chúng ta sử dụng giả dược. Và quan trọng hơn về mặt endpoint, tức là các đột quỵ, các cái đột quỵ tử vong không tử vong, thì với việc chúng ta sử dụng atorvastatin 80 mg thì chúng ta làm giảm được 16% các biến cố đột quỵ tử vong và không gây tử vong. Và chúng ta thấy rằng nếu như chúng ta nhìn vào các phân nhóm, ví dụ như giới, ví dụ như tuổi, ví dụ trên các bệnh nhân có hẹp về mạch cảnh và hoặc là các bệnh nhân loạn chuyển hóa, ví dụ như tiểu đường, thì cái atorvastatin đều có lợi hơn so với giả dược. Và tất cả các biến cố ví dụ như TA đều có lợi đối với statin, bệnh lý động mạch lớn, bệnh lý mạch máu nhỏ hoặc là các nguyên nhân khác. Tuy nhiên chúng ta thấy rằng đối với những bệnh nhân mà xuất huyết não thì cái tỷ lệ placebo nó có lợi hơn so với giả dược. Đó là lý do tại sao mà đối với các bệnh nhân mà xuất huyết não chúng ta không nên sử dụng statin lâu dài. Chúng ta có thể sử dụng như là để đạt cái mục tiêu chúng ta cần đạt, và sau đó chúng ta phải ngừng lại statin bởi vì statin không hề có lợi đối với các bệnh nhân bị xuất huyết não. Và khi mà chúng ta phân tích gộp đối với tất cả các bệnh nhân đột quỵ trong tất cả các nghiên cứu đó, thì người ta thấy rằng statin làm giảm được khoảng 12% các biến cố đột quỵ tái phát so với giả dược. Như vậy cái guideline hiện nay của Hoa Kỳ, người ta khuyên rằng đối với statin, đối với các bệnh nhân mà đột quỵ mà liên quan tới xơ vữa đó, thì việc chúng ta bắt đầu statin thì được xem là khuyến cáo mang lại lợi ích cho các cái bệnh nhân trong việc làm giảm các biến cố đột quỵ cũng như các biến cố về tim mạch trên các bệnh nhân đột quỵ hoặc là TA. Như vậy khi nào như vậy chúng ta đã xác định được khi nào một bệnh nhân đột quỵ chúng ta nên sử dụng statin, nhưng khi nào chúng ta bắt đầu. Ta biết rằng nhìn lại cái Heart Protection Study, khi chúng ta sử dụng quá trễ 4.3 năm trong Heart Protection Study, chúng ta không thể ghi nhận được cái lợi ích của simvastatin. Tuy nhiên trong Sparkle, nếu chúng ta sử dụng sớm hơn từ 1 đến 6 tháng thì chúng ta có thể thấy được lợi ích của statin. Tuy nhiên trên thực tế thì không ai chờ 1 đến 6 tháng chúng ta mới bắt đầu statin cả, bởi vì nếu chúng ta bắt đầu càng sớm, cái sự tuân thủ điều trị của bệnh nhân nó sẽ tốt hơn, đặc biệt khi chúng ta sử dụng trong quá trình làm việc. Chúng ta sẽ giảm LDL ở mức độ nào? Chúng ta thấy rằng thật ra nó có một cái mối lo ngại rằng đối với tại vì qua các cái nghiên cứu mà trên cộng đồng đó, thì người ta thấy rằng nếu như cái mức LDL đó, mà nó càng tăng, mức LDL càng tăng thì các biến cố đột quỵ, nhồi máu nó sẽ tăng. Ngược lại trong cái dân số cộng đồng những người lành mạnh bình thường đó, thì cái LDL nó càng thấp thì lại làm tăng các biến cố về xuất huyết. Như vậy cái mối lo ngại ở đây là khi trên cộng đồng những người lành mạnh, cái LDL thấp nó có thể liên quan đến các biến cố về xuất huyết. Như vậy trên cộng đồng những bệnh nhân đã bị đột quỵ rồi hoặc những bệnh nhân có nguy cơ rồi, việc chúng ta sử dụng statin để chúng ta làm giảm LDL có gây ra các biến cố xuất huyết giống như trong cộng đồng hay không? Đó là một câu hỏi mà chúng ta cần phải giải đáp. Nếu chúng ta nhìn lại nghiên cứu Sparkle, thật ra nếu chúng ta xét trên các biến cố đột quỵ thiếu máu đơn thuần đó, thì cái atorvastatin 80mg nó giảm được 21% các biến cố đột quỵ thiếu máu. Tuy nhiên cái lợi ích 21% này nó đã bị trung hòa bởi vì các biến cố xuất huyết tăng lên ở nhóm atorvastatin 80mg, nó làm tăng khoảng 68% so với các biến cố so với giả dược. Tuy nhiên câu hỏi đặt ra là liệu rằng cái việc mà xuất huyết này nó có liên quan đến việc chúng ta sử dụng atorvastatin hay không? Thì ta nhìn lại trong cái phân nhóm mà đưa vào trong cái nghiên cứu này, mặc dù trong nghiên cứu này cái tiêu chuẩn chọn bệnh là các biến cố nhồi máu hoặc là TEA, tuy nhiên vì một lý do nào đó có khoảng 50 các cái bệnh nhân, có khoảng gần 100 bệnh nhân được đưa vào trong nghiên cứu này là những bệnh nhân xuất huyết não, và chúng ta thấy rằng xuất huyết não như ta biết rằng hoàn toàn không có lợi với statin. Và khi mà câu hỏi đặt ra giống như tôi nói trình bày, tức là nguy cơ xuất huyết não đối với các bệnh nhân xuất huyết não, chúng ta dùng statin có tăng lên hay không, và cái khi chúng ta giảm quá mức LDL nó có làm tăng các biến cố xuất huyết nào hay không. Ngoài ra những yếu tố nguy cơ nào khác có thể làm tăng các biến cố xuất huyết khi chúng ta sử dụng statin. Thì qua cái phân tích mà hồi quy thì người ta thấy rằng có 4 cái yếu tố mà liên quan đến các biến cố xuất huyết. Đặc biệt hàng đầu đó là biến cố xuất huyết. Nếu như một cái bệnh nhân mà xuất huyết não và chúng ta sử dụng atorvastatin 80mg và kéo dài trong vòng 5 năm thì chúng ta sẽ làm tăng khoảng gấp 8 lần cái nguy cơ xuất huyết so với giả dược. Nếu như các bệnh nhân ở nam giới thì cái nguy cơ xuất huyết sẽ tăng gấp 2 lần so với cái nữ giới. Tuổi cứ tăng 10 tuổi sẽ tăng khoảng 40%. Và cái điều quan trọng nhất là cái mà chúng ta lo lắng rằng việc chúng ta làm giảm LDL quá mức có làm tăng các nguy cơ xuất huyết không, thì qua phân tích thì người ta thấy rằng không có mối liên hệ giữa cái mức LDL thấp và mức LDL hoặc là cao so với cái nguy cơ gây ra xuất huyết trong nghiên cứu Sparkle. Ngoài ra cái yếu tố huyết áp được xem là yếu tố rất quan trọng, có thể làm tăng biến cố xuất huyết. Nếu như một cái bệnh nhân mà mức huyết áp càng cao, ví dụ như giai đoạn 2 thì cái nguy cơ xuất huyết có tăng gấp 6 lần so với giai đoạn 1, tăng gấp 3 lần, hơn gấp 3 lần rưỡi, hoặc là những huyết áp ở tiền giai đoạn cao huyết áp nó cũng hay làm tăng cái nguy cơ xuất huyết não. Và khi người ta phân tích nếu như chúng ta xem nếu như ở những cái bệnh nhân mà chúng ta không giảm LDL nào, cái mức LDL chúng ta sau khi thời gian sử dụng statin mà nó không giảm đó, thì chúng ta thấy rằng cái lợi ích gần như nó rất thấp. Trong khi đó nếu chúng ta giảm được 50% cái mức LDL ban đầu đó, thì cái lợi ích chúng ta mới thấy được cái lợi ích của statin. Và đặc biệt nếu chúng ta giảm trên 50% đó thì cái lợi ích nó càng rõ hơn. Và cái các biến cố về nhồi máu nó cũng tỷ lệ đối với cái mức giảm LDL. Nếu chúng ta không giảm được LDL, gần như chúng ta không thể tác động được gì các cái biến cố giảm về thiếu máu. Ngược lại chúng ta giảm mà dưới 50% cái mức ban đầu, cái lợi ích nó cũng rất nhỏ. Ngược lại chúng ta làm giảm trên 50% cái mức LDL ban đầu đó, thì cái lợi ích giảm các biến cố thiếu máu nó sẽ cao hơn rất rõ. Ngược lại trong các biến cố xuất huyết thì chúng ta lại thấy rằng câu chuyện nó không tỷ lệ như vậy. Tức là khi chúng ta thấy rằng chúng ta giảm rất nhiều, trên 50% so với ban đầu, thì các biến cố xuất huyết nó lại có khuynh hướng tốt hơn so với giảm dưới 50. Thì đây có nghĩa là gì? Cái mức giảm LDL nó không có liên quan đến các biến cố xuất huyết giống như các cái nghiên cứu mà trong các cộng đồng dân số bình thường. Và người ta thấy rằng nếu như chúng ta làm giảm LDL cứ mỗi 1 mmol LDL, chúng ta sẽ làm giảm được khoảng 21% các biến cố đột quỵ tái phát. Và như vậy cái guideline hiện nay người ta khuyên chúng ta rằng nếu như chúng ta chọn một cái mục tiêu cho mình thì at least tối thiểu chúng ta nên phải chọn khoảng giảm dưới 50% cái mức LDL ban đầu, hoặc là cái mức LDL chúng ta nên chọn dưới 70 mg/dl để chúng ta đạt được cái hiệu quả tối ưu của statin. Một cái nghiên cứu khá là quan trọng cũng cùng của tác giả Amarenko được công bố gần đây năm 2019 trên tạp chí là New England Journal of Medicine. Trong nghiên cứu này người ta đưa ra một cái concept hết sức là quan trọng. Như trong cái guideline hiện nay người ta cũng khuyến cáo chúng ta nên đưa mức LDL dưới 100 mg/dl. Và trong nghiên cứu này nó bao gồm khoảng gần 3.000 bệnh nhân. Và đây là những bệnh nhân mà vừa mới bị đột quỵ rất là sớm, chỉ trong vòng 3 tháng hoặc là 15 ngày đối với cơn thoát máu não. và người ta chọn lựa hai cái mục tiêu. Một nhóm chúng ta sẽ đưa cái LDL xuống dưới cái 70 mg dl, và một nhóm chúng ta đưa cái LDL theo giống như guideline, tức là đưa cái LDL dưới 100 mg dl theo guideline. Và cái endpoint đó là các biến cố tim mạch cũng như đột quỵ. Và trong nghiên cứu này thì chúng ta thấy rằng so với cái nhóm mà chúng ta làm theo guideline là cái mức LDL chúng ta giữ dưới 100, tức là khoảng 96 mg, trung bình là 96 mg%. Tất cả hai nhóm đều sử dụng statin, và người ta cho phép chúng ta ngoài statin chúng ta có thể sử dụng thêm cái ezetimibe để chúng ta làm giảm tối đa cái mức LDL để chúng ta đạt được cái mục tiêu của mình. Mà so với cái nhóm mà điều trị theo guideline thì cái mức mà ở cái nhóm mà chúng ta aggressive giảm LDL thì mức LDL nó giảm xuống còn 65 mg/dl. Và quan trọng là với việc chúng ta làm giảm nhiều như vậy thì so với cái nhóm mà chúng ta điều trị guideline thì việc chúng ta hạ thấp cái mức LDL dưới 70 chúng ta sẽ làm giảm thêm được khoảng 22% các biến cố tim mạch cũng như đột quỵ. Đây là một cái thông tin rất là quan trọng, bởi vì nó là một cái RCT đầu tiên đối với chuyên ngành đột quỵ đã chứng minh được rằng việc chúng ta càng giảm LDL càng nhiều thì có lợi ích làm giảm các biến cố tim mạch cũng như đột quỵ càng lớn trên các bệnh nhân có tiền căn đột quỵ hoặc là cơn thoái thiếu não. Khi chúng ta điều trị cho mình thì như vậy, đây là những cái guideline, đây là những cái mục tiêu mà chúng ta mong muốn đạt được, như là LDL, cholesterol, LDL, triglyceride, HDL và cái đặc biệt là huyết áp. Thì nếu chúng ta giữ LDL mà dưới 70, triglyceride dưới 150, HDL trên 50 và cái huyết áp chúng ta giữ 100 dưới 120/80, thì đây là những mục tiêu mà thông thường tất cả các bác sĩ đột quỵ đều hướng tới để phòng ngừa các biến cố đột quỵ thứ phát trên các bệnh nhân nhồi máu. Và chúng ta thử xem nếu như chúng ta không đạt được cái mục tiêu nào và chúng ta đạt được một mục tiêu, chúng ta thấy rằng nếu như chúng ta đạt được một cái mục tiêu trong 4 mục tiêu trên đó, thì chúng ta chỉ làm giảm được khoảng 2% các biến cố đột quỵ phát, gần như là không có thay đổi. Nếu chúng ta đạt được cả hai mục tiêu trong số 4 mục tiêu trên thì chúng ta làm giảm được khoảng 22% các biến cố đột quỵ tái phát. Nếu chúng ta giảm được 3 mục tiêu, chúng ta làm giảm được 38%, và đặc biệt nếu như chúng ta làm giảm được 4 mục tiêu, tức là chúng ta đạt được cả 4 mục tiêu trên, thì cái lợi ích mang lại sẽ cực lớn, bởi vì lúc đó chúng ta sẽ làm giảm được khoảng 65% các biến cố đột quỵ. Thì như vậy khi chúng ta kiểm soát các cái yếu tố nguy cơ của bệnh nhân, cách tốt nhất chúng ta nên đặt ra cái mục tiêu cho mình, và nếu chúng ta đạt càng nhiều mục tiêu thì cái lợi ích của bệnh nhân chắc chắn sẽ càng lớn. Và như vậy chúng ta sẽ sử dụng bao lâu? Chúng ta nhìn lại SPS, cái lợi ích của statin, chúng ta thấy rằng gần như trong năm đầu cái lợi ích của statin cũng như giả dược gần như là ngang bằng nhau, và cái lợi ích nó chỉ tách ra, cái đường copper-Mayer lợi ích nó chỉ tách ra sau khoảng 2 năm. Và trong cái nghiên cứu Sparkle cũng vậy, thường cái statin nó chỉ có hiệu quả tách ra rõ rệt sau 2 năm. Như vậy chúng ta sử dụng statin thì ít nhất bắt buộc chúng ta phải sử dụng lâu dài, bởi vì cái statin nó chỉ có được sau khi chúng ta sử dụng một cái thời gian ít nhất là sau 2 năm. Và trong nghiên cứu Treat to Target Trial cũng vậy, tất cả các cái lợi ích mà tách ra từ việc chúng ta hạ thấp cái LDL nhiều hơn nó cũng rõ rệt chỉ sau thời gian ít nhất là 2 năm. Trở lại cái ca lâm sàng của tôi, một cái bệnh nhân mà đột quỵ mà liên quan đến yếu tố xơ vữa, đặc biệt là xơ vữa rất nặng, hẹp trên 70% đồng mạch thân nền. Như vậy chúng ta sẽ điều trị cái gì? Trong nghiên cứu, trong cái điều trị bệnh nhân này, chúng tôi chọn lựa sử dụng aspirin cộng với carbidopa trong vòng 1 tháng và sử dụng atorvastatin 80 mg. Như vậy câu hỏi đặt ra là khá nhiều đồng nghiệp nghĩ rằng đây có phải là một cái trường hợp mà chúng ta nên đặt stent hay không? Bởi vì liệu rằng những cái điều trị nội khoa thông thường như thế này có đủ để giúp cho bệnh nhân phòng ngừa được hay không? Thì đây là cái nghiên cứu, một cái thử nghiệm lâm sàng được xem là kinh điển dành cho các bệnh nhân hẹp động mạch nội sọ, đó là nghiên cứu SUNBRIDGE. Thì trong nghiên cứu SUNBRIDGE này đó, người ta bao gồm những bệnh nhân mà có hẹp các động mạch nội sọ, ví dụ như động mạch thân nền, động mạch não giữa, và với cái mức độ hẹp từ 70 đến 99%. Và nghiên cứu này được thực hiện khoảng 50 trung tâm ở đột quỵ Hoa Kỳ, và người ta lựa chọn 2 cái phương pháp. Một phương pháp là điều trị nội khoa giống như chúng tôi, đó là aspirin cộng với carbidopa và cộng với liều cao statin, và trong nghiên cứu này người ta sử dụng cái rosuvastatin là 20 mg. Và so với một cái nhóm chúng ta đặt stent và sau đó cộng với điều trị nội khoa cũng giống như cái điều trị nội khoa thông thường, tức là aspirin cộng với Cobrel và statin. Điều trị nội khoa thì giống nhau, chỉ khác biệt là đặt thêm cái stent. Và cái kết quả chính của nghiên cứu này là tỷ lệ các biến cố đột quỵ và tử vong trong vòng 30 ngày. Chúng ta thấy rằng trong nghiên cứu này đó, các bệnh nhân đã được kiểm soát rất tốt. Ở nhóm điều trị nội khoa, cái huyết áp ban đầu của bệnh nhân là 140, gần 150, và sau khoảng 4 tháng huyết áp bệnh nhân này đã giảm xuống khoảng còn 130. Ở nhóm chúng đặt stent nó cũng tương tự như vậy, khoảng 130 ở sau khoảng 4 tháng. LDL ban đầu ở cả hai nhóm nó khoảng gần 100, và sau thời điểm 4 tháng nó đã giảm xuống còn khoảng 72 đến 75 mg dl. Cái đường huyết cũng được kiểm soát tương đối tốt, là 8 chấm ban đầu, thì sau thời gian 4 tháng nó kiểm soát còn 7,5 hoặc là 7,8 ở nhóm chúng đặt stent. Và cái outcome của nghiên cứu này, nếu như chúng ta xét vào thời điểm 1 tháng đó, 30 ngày đó, thì chúng ta thấy rằng ở cái nhóm chúng ta điều trị nội khoa đơn thuần, các biến cố đột quỵ tái phát là 5,8%, và so với cái nhóm stent là 15,7%, tức là các biến cố đột quỵ liên quan đến nhóm đặt stent nó tăng gần gấp 3 lần ở nhóm chúng ta đặt stent. Và đó là lý do tại sao nghiên cứu này phải dừng sớm, bởi vì cái sự khác biệt nó quá lớn đến các biến cố ở nhóm điều trị nội khoa so với đặt stent. Và nhiều đồng nghiệp nói rằng nếu như chúng ta xét đến thời điểm trong 30 ngày đó, trong 30 ngày đầu tiên sẽ bao gồm khi chúng ta đặt cái stent vào, chắc chắn nó sẽ có những cái biến chứng rủi ro sau khi thủ thuật. Như vậy chúng ta sẽ xem đối với các biến cố đột quỵ mà sau khi bệnh nhân sau 30 ngày, tức là chúng ta đã loại bỏ đến các cái tỷ lệ mà bệnh nhân có thể có những cái biến cố bất lợi khi mà chúng ta liên quan đến thủ thuật đặt stent, thì một lần nữa chúng ta cũng khá là thất vọng, bởi vì ở cái nhóm mà điều trị nội khoa đó tỷ lệ là 5,7%, mà so với cái nhóm chúng ta đặt stent là 5,8%. Điều đó có nghĩa là gì? Điều đó có nghĩa là dù cho chúng ta đặt stent thành công chăng nữa thì cái stent đó cũng không có giá trị trong việc phòng ngừa các biến cố đột quỵ và thứ phát trên các bệnh nhân hẹp nội sọ. Và kết luận của Sampris là so với điều trị nội khoa đơn thuần thì việc chúng ta dùng cái Wingspan stent thì nó không hiệu quả bằng, và nó nguyên nhân là do cái lợi ích của cái nhóm điều trị nội khoa nó đã thấp hơn nhiều so với dự định. Đó là lý do thất bại của nghiên cứu Sampris. Người ta đi đến hai cái kết luận của thất bại Sampris. Thứ nhất là các biến cố mà liên quan đến kỹ thuật đặt stent cao hơn ước tính. Trong các cái thử nghiệm mà nhỏ, những cái thử nghiệm case series thì cái kỹ thuật này nó thành công nhiều hơn. Trong khi đó trong nghiên cứu Sampris, một kiểu RCT thì nó lại cao hơn khá nhiều. Ngoài ra các biến cố đột quỵ tái phát ở cái nhóm điều trị nội khoa đã thấp hơn một cách rõ rệt so với nghiên cứu trước. Các nghiên cứu trước trong nghiên cứu WASHIT tỷ lệ tái phát là 19%, trong đó Sampris nó làm giảm cho còn có 12% thôi. Mà cái lợi ích cho biết rằng trong nghiên cứu WASHIT thì không có vai trò của statin trong Sampris, chúng ta đã có thêm cái việc chúng ta sử dụng statin, và như vậy vô tình cái việc chúng ta sử dụng statin chúng ta đã tác động làm giảm rất rõ rệt các biến cố đột quỵ bằng cái điều trị nội khoa đơn thuần mà chưa cần đến cái can thiệp. Do đó cái guideline hiện nay đối với các bệnh nhân đột quỵ mà liên quan đến hẹp nội sọ thì việc điều trị nội khoa, tức là kiểm soát huyết áp, kiểm soát cholesterol được xem là mức khuyến cáo 2B, so với cái việc mà chúng ta đặt stent thì được xem là không rõ nguyên nhân, không rõ lợi ích và nên được kiểm định bằng các cái thử nghiệm lâm sàng khác. Như vậy để tóm tắt bài này, đối với các bệnh nhân đột quỵ mà liên quan sơ vữa, chúng ta sẽ bắt đầu cái gì để chúng ta kiểm soát LDL? Thì tôi thấy rằng cái simvastatin nó làm giảm biến cố tim mạch máu chính nhưng làm không giảm các biến cố đột quỵ. Trong Sparkle cái atawasertib làm giảm các biến cố chính, đặc biệt là nguy cơ đột quỵ. Như vậy so với cái simvastatin thì atawasertib được xem là lựa chọn tốt hơn. Khi nào chúng ta bắt đầu trong Sparkle từ 1 đến 6 tháng, và theo guideline hiện nay chúng ta nên bắt đầu statin càng sớm càng tốt sau cái biến cố đột quỵ. Và chúng ta giảm nước nào? Tôi thấy rằng hiệu quả của giảm nguy cơ đột quỵ nó sẽ tỷ lệ thuận với mức giảm LDL. Như vậy LDL càng thấp, cái hiệu quả chúng ta mang lại càng tốt, và lâu dài, cái bao lâu thì cái statin nó chứng tỏ rằng qua các thử nghiệm lâm sàng với thời gian dài nó đã chứng minh hiệu quả cũng như độ an toàn. Như vậy thông thường chúng ta sẽ sử dụng lâu dài cái statin. Và một cái mà tôi muốn chuyển đến các đồng nghiệp đó là khi một cái bệnh nhân, chúng ta có một cái bệnh nhân đột quỵ và liên quan xơ vữa, chúng ta đừng nhìn vào cái LDL để ban đầu để chúng ta quyết định có hay không xài statin. Bởi vì cái statin hiện nay nó giống như một viên aspirin, giống như một viên Corbiloprel. Khi chúng ta uống vào, chúng ta biết chắc rằng nó sẽ làm giảm các biến cố đột quỵ tái phát liên quan đến xơ vữa. Và LDL càng thấp thì cái lết càng tốt, và cái dung nạp lipid chỉ là cái để chúng ta giúp chúng ta theo dõi để điều chỉnh cái điều trị thuốc trong quá trình điều trị của bệnh nhân hay không. Xin cảm ơn sự lắng nghe của quý đồng nghiệp.
Xin cảm ơn Phó Giáo sư Nguyễn Huy Thắng. Và để tiếp tục chương trình thì chúng ta sang phần hỏi đáp. Chúng tôi xin mời quý đồng nghiệp có câu hỏi thì có thể gửi vào chat box hay là bật mic để có thể hỏi trực tiếp. Xin cảm ơn. Chúng tôi nhận được một câu hỏi, đó là có một tỷ lệ nhất định bệnh nhân sử dụng statin bị tăng biến cố xuất huyết não. Xin Phó Giáo sư cho ý kiến về vấn đề này. Xin kính mời Phó Giáo sư Nguyễn Huy Thắng.
Dạ, tôi xin trả lời. Đó, trong cái bài của tôi đã trình bày. Thứ nhất là xuất huyết não. Bản thân nếu bệnh nhân đã xuất huyết não thì chúng ta sẽ không nên sử dụng statin. Bởi vì statin nó sẽ làm tăng các biến cố về xuất huyết não, tăng gấp 8 lần các biến cố về xuất huyết não. Nhưng mà các anh chị nên nhớ rằng trong cái bối cảnh mà statin làm tăng các biến cố não là trong bối cảnh của Sparkle, tức là với cái liều mà chúng ta sử dụng atorvastatin là liều rất cao, tức là 80 mg và chúng ta kéo dài suốt 5 năm. Như vậy vấn đề đặt ra, nếu như bệnh nhân xuất não chúng ta có thể sử dụng statin hay không? Chúng ta có thể, nhưng mà cái cách tiếp cận chúng ta sẽ khác với nhồi máu. Nếu như đối với những bệnh nhân nhồi máu não, chúng ta sử dụng statin liều cao và lâu dài. Ngược lại, đối với các bệnh nhân xuất huyết não, nếu như chúng ta thấy rằng bệnh nhân này chúng ta cần thay đổi dung nạp lipid thì chúng ta có thể sử dụng statin, nhưng khi chúng ta đạt được cái target của mình rồi đó thì cách tốt nhất là chuyển sang một cái loại thuốc khác hoặc là một cái chế độ ăn uống để chúng ta kiểm soát cái dung nạp lipid, thay vì chúng ta vẫn tiếp tục sử dụng statin giống như các bệnh nhân thiếu máu. Còn đối với các bệnh nhân thiếu máu thì hiện nay cái lợi ích của statin đã quá rõ, và người ta thấy rằng cái việc đối với chế nhân thiếu máu thì việc chúng ta sử dụng statin nó không làm tăng các biến cố về xuất huyết giống như chúng ta suy nghĩ, giống như trong cái bối cảnh của các cái cộng đồng các bệnh nhân bình thường.
Dạ, tôi đang bận với anh, tôi xin lỗi anh, tôi đang bận với anh, gửi tin nhắn cho mình. Xin cảm ơn câu trả lời của Phó Giáo sư Nguyễn Huy Thắng. Và chúng tôi cũng xin sang cái câu hỏi thứ hai cho Phó Giáo sư Thắng, là trên thực hành lâm sàng rất hiếm khi sử dụng statin liều cao, ví dụ atorvastatin 80 mg trong nghiên cứu Sparkle. Vậy việc dùng liều 10 hay 20 mg atorvastatin có hiệu quả phòng ngừa đột quỵ tái phát hay không? Xin kính mời Phó Giáo sư Nguyễn Huy Thắng.
Dạ, em cũng xin mượn lời của thầy giáo sư Võ Thành Nhân. Trong những cái bài thầy cũng đã nói, nếu chúng ta muốn một cái lợi ích của một cái thuốc thì chúng ta phải tuân thủ đúng cái liều của cái thuốc đó, đúng không ạ? Chúng ta không thể người ta sử dụng 80 và chúng ta sử dụng 10 để chúng ta đạt được cái hiệu quả được. Tuy nhiên trên thực tế thì đúng là trên thực tế thì chúng ta ở Việt Nam thì bản thân tôi cũng ít khi nào tôi sử dụng 80. Nguyên nhân là hiện nay chúng ta không có liều cái dose 80 trên thị trường ở Việt Nam, và nếu như chúng ta sử dụng 2 viên 40 thì nó là cái giá nó quá là cao, khó cái bệnh nhân nào mà có thể tuân thủ được. Như vậy thông thường đó, các bệnh nhân đột quỵ chúng tôi thường sử dụng atorvastatin liều 40 mg, còn đối với rosuvastatin chúng tôi sử dụng 20 mg. Còn nếu như quý đồng nghiệp có bệnh nhân có những cái tác dụng phụ mà liên quan đến thuốc, ví dụ như đau cơ, ví dụ như tăng men gan, thì lúc đó tôi nghĩ rằng việc chúng ta sử dụng liều thấp có thể là một cái giải pháp tốt hơn. Tuy nhiên nếu như chúng ta sử dụng ngay từ đầu, chúng ta không nên sử dụng cái liều quá thấp.
Chúng tôi cũng xin tham gia bổ sung trong cái câu trả lời của Phó Giáo sư Nguyễn Huy Thắng, đó là nếu như chúng ta theo cái khuyến cáo cách đây cũng mấy năm rồi của anh, đó là cái khuyến cáo NICE, thì khi điều trị dự phòng nguyên phát chúng ta có thể sử dụng liều atorvastatin 20 mg, nhưng khi mà điều trị dự phòng thứ phát thì người ta khuyến cáo là 80 mg. và đặc biệt là trong cái chuyên ngành tim mạch đó, đặc biệt là tim mạch can thiệp, thì đối với những bệnh nhân mà đã có hội chứng mạch vành cấp đã được đặt stent thì chúng tôi đều sử dụng cái liều theo khuyến cáo là 80 mg. Và cái liều 80 mg này là thì thật sự là do cái thói quen, mà chúng ta biết là giữa cái thực hành, giữa cái thói quen, cái thực tế đời thường và cái học thuật thì bao giờ nó cũng có khoảng cách. Và chúng ta đi ở ngoài đường, chúng ta thấy đèn vàng ở trên cái phương diện gọi là cái học thuật, tức là phương diện mà lái xe thì người ta khuyên là chúng ta phải rà thắng ngừng lại, nhưng mà trên thực tế đời thường thì thấy đèn vàng người ta càng tăng tốc. Như vậy thì quý đồng nghiệp khi phân vân giữa cái liều thấp và cái liều cao, mình có thể đặt mình vào cái tình huống thấy đèn vàng thì là mình tăng tốc hay là mình chậm lại theo đúng cái luật giao thông. Chúng tôi xin sang cái câu hỏi kế tiếp là theo ASA năm 2021 thì khuyến cáo bệnh nhân sử dụng atorvastatin 80 mg một ngày trên bệnh nhân đột quỵ do thiếu máu cục bộ và LDL cholesterol trên 100 mg để dự phòng đột quỵ tái phát. Việc sử dụng statin cường độ cao như vậy có an toàn, đặc biệt là trên cơ và gan? Chúng tôi xin kính mời Phó Giáo sư Nguyễn Huy Thắng.
Một cái khi chúng tôi sử dụng đó thì một cái đồng nghiệp có muốn biết an toàn hay không đó, thì các đồng nghiệp có thể vào tham khảo cái nghiên cứu Sparkle. Trong cái nghiên cứu Sparkle á, thì chúng ta thấy rằng đối với, hoặc là trong nghiên cứu mình sử dụng liều cao, Sparkle là sử dụng atorvastatin 80 mg mà trong vòng 5 năm, hoặc các nghiên cứu khác, ví dụ trong nghiên cứu về sử dụng Rosuvax 20 chẳng hạn, thì thậm chí 40 mg. Các anh chị thấy rằng trong các thử nghiệm đó người ta so sánh với giả dược và tất cả những người đánh giá đều là mù, tức là để người ta làm giảm hoàn toàn cái độ bias, tức là chúng ta thiên lệch ở cái nhóm mà chúng ta sử dụng placebo, giả dược hoặc là cái statin, thì người ta thấy rằng cái tỷ lệ mà các bệnh nhân đau cơ này, các bệnh nhân mà tăng men gan ở cái nhóm mà chúng ta sử dụng statin gần như nó khác biệt rất là thấp, đặc biệt là đau cơ. Tại vì cái đau cơ nó có rất là nhiều yếu tố chủ quan, bởi vì nhiều bệnh nhân người ta đọc cái trang thông tin về thuốc và người ta đau cơ, người ta rất là dễ lầm lẫn. Và trong cái nhóm giả dược người ta thấy rằng ở cái nhóm đó thì tỷ lệ đau cơ cũng rất là cao, không có khác gì so với là dùng statin cả. Như vậy và trong tất cả các thử nghiệm này người ta đều sử dụng cái liều rất là cao, và đặc biệt sử dụng toàn là từ 5 năm trở lên. Và đó tôi nghĩ rằng đó là những cái thử nghiệm lâm sàng đã cho thấy, chúng ta thấy rằng cái hiệu quả và đặc biệt là cái sự an toàn của các cái statin trên các cái bệnh nhân đột quỵ.
Chúng tôi cũng xin phép bổ sung một cái số ý kiến cá nhân về cái vấn đề này. Thì cái vấn đề mà bệnh nhân theo thói quen, một số bệnh nhân, đặc biệt là những bệnh nhân trẻ, khi mà được thầy thuốc kê toa thì thường hay lên mạng tra cái tác dụng phụ của thuốc, và người ta không nhìn cái ích lợi mà người ta chỉ thấy những cái tác dụng phụ, và những cái tác dụng phụ này nhiều khi cả triệu người mới có một người bị. Và như vậy thì người ta bị ám ảnh bởi cái tác dụng phụ và người ta ngại dùng thuốc, và cái tác dụng này người ta gọi là cái nocebo effect. Nó giống như tác dụng của giả dược, tác dụng tâm lý ta gọi là placebo, còn cái tác dụng này là tác dụng tâm lý mà ngược lại, ta uống thuốc cứ sợ tác dụng phụ thì người ta gọi là nocebo effect. Thì nếu bây giờ mình suy nghĩ lại, nếu mà thuốc không có tác dụng phụ thì làm sao có tác dụng chính? Mình ăn cơm hay là mình ăn tinh bột thì nó làm tăng nguy cơ tiểu đường, mình ăn chất béo thì nó làm tăng nguy cơ xơ vữa động mạch, mình ăn nhiều chất đạm thì nó làm tăng nguy cơ ung thư. Đối với những người có bệnh thận thì nó làm tăng cái tình trạng suy giảm chức năng thận. Đối với những người bị bệnh gút thì nó làm tăng nguy cơ có những cái cơn gút cấp. Như vậy thì những cái người đó, nếu mà người ta chỉ nhìn vào tác dụng phụ, người ta có bỏ cơm được không? Có bỏ ăn thịt được không? Có bỏ ăn chất béo được hay không? Và khi mà một cái thuốc được đưa ra thị trường hay là được nghiên cứu thì bao giờ cái ích lợi của nó cũng vượt trội so với lại những tác dụng phụ. Có thể là chúng ta đừng vì những cái tác dụng phụ mà nó tương đối nó hiếm gặp mà chúng ta bỏ đi cái lợi ích rõ ràng trước mắt là cải thiện các biến cố tim mạch, cải thiện tỷ lệ tử vong tim mạch, và đặc biệt là cải thiện tỷ lệ tử vong do mọi nguyên nhân, tức là kéo dài tuổi thọ. Mình có cái biện pháp, giải pháp nào để kéo dài tuổi thọ của mình không? Statin là một trong những giải pháp đó. Thành ra chúng tôi nghĩ là mình chỉ nhìn cái khía cạnh tiêu cực thì cái góc nhìn nó có vẻ là hơi bị lệch lạc. Thì đó chỉ là cái quan điểm cá nhân thôi, thì quý đồng nghiệp cứ tự mình suy nghĩ. Một cái câu hỏi khác đó là giữa các statin, atorvastatin, simvastatin, rosuvastatin có gì khác nhau về hiệu quả dự phòng, tính an toàn, hay là khác nhau giữa các nhóm bệnh nhân hay không? Xin mời Phó Giáo sư Nguyễn Huy Thắng.
Chúng ta biết rằng hiện nay mặt chứng cứ trên các cái đột quỵ thì chúng tôi chỉ có SPARKLE là nghiên cứu về atorvastatin, và một cái nghiên cứu SUNBRIDGE khi tôi trình bày đối với các bệnh nhân mà có hẹp động mạch nội sọ đột quỵ thì người ta sử dụng cái rosuvastatin. Trong khi đó cái nghiên cứu SBS sử dụng simvastatin thì lại là một nghiên cứu thất bại. Cho dù chúng ta có thể biện hộ lý do gì thì đó là một cái nghiên cứu mà mặt thất bại mặt hiệu quả. Do vậy mặt lâm sàng đó hiện nay thông thường các cái bác sĩ về đột quỵ thường sẽ sử dụng cái atorvastatin hoặc là rosuvastatin trong việc phòng ngừa các biến cố đột quỵ thứ phát hơn là sử dụng simvastatin. Và tôi nghĩ rằng chắc là các cái đồng nghiệp tim mạch cũng là như vậy, ông thầy Nhân ạ.
Chúng tôi cũng thống nhất với ý kiến của Phó Giáo sư Thắng. Và chúng ta biết là những cái statin mà thế hệ càng về sau này thì cái tính an toàn cũng như là cái hoạt lực của nó, tính an toàn nó cao hơn những statin thế hệ cũ, và cái hoạt lực của nó thì mạnh hơn những statin thế hệ cũ. Và một cái điểm dễ nhận thấy đó là nếu như chúng ta sử dụng những statin thế hệ cũ thì cái hoạt lực nó yếu, thời gian tác dụng nó ngắn, thành ra chúng ta hay cho bệnh nhân uống vào ban đêm, vào buổi chiều hay là tối, tại vì ban đêm là cái lúc mà gan nó tổng hợp cholesterol. Nhưng mà đối với những cái statin mà thế hệ mới, ví dụ như là atorvastatin, rosuvastatin, thì thời gian tác dụng của nó là 24 giờ. Nó thành ra chúng ta không có phải cho bệnh nhân sử dụng vào buổi chiều hay là buổi tối. Và cái hoạt lực nó càng mạnh thì đương nhiên là cái hiệu quả dự phòng nó càng cao. Và chúng ta thấy là hiện nay các cái khuyến cáo trong năm 2021, đặc biệt là trên cái phương diện bệnh lý mạch vành, thì nếu mà nguy cơ rất cao là người ta đề xuất là phải giảm xuống dưới 40 mg trên decilit, hay là nguy cơ cao là dưới 55 mg trên decilit. Và mình hỏi là cái tính an toàn nó có an toàn hay không, thì thông qua cái bài báo cáo của tiến sĩ Huy cũng như là Phó Giáo sư Thắng, chúng ta biết là khi mà bệnh nhân sử dụng các thuốc ức chế PCSK9 thì LDL cholesterol nó giảm xuống dưới 25 mg trong vòng 2 năm mà bệnh nhân hoàn toàn không có một cái biến cố hay là một cái sự cố gì về tim mạch, thì cho thấy rằng cái tính an toàn nó rất cao. Nếu chỉ sử dụng statin thì không mong gì chúng ta có thể giảm xuống dưới 40, nó đừng nói gì là giảm xuống dưới 25. Nó thành ra đừng lo lắng về cái chuyện là cái hiệu quả nó quá mức, mà chúng ta nên lo lắng là nó không đủ hiệu quả để đạt được cái mục tiêu điều trị, đặc biệt là ở những bệnh nhân có phân tầng nguy cơ rất cao, là những bệnh nhân vừa mới bị đột quỵ, vừa mới bị nhồi máu cơ tim cấp. Chúng tôi xin sang một cái câu hỏi khác là sau khi LDL cholesterol đã đạt đích điều trị, việc sử dụng tiếp tục statin như thế nào? Nên tiếp tục duy trì liều đang dùng hay cân nhắc giảm liều? Chúng tôi xin mời Phó Giáo sư Nguyễn Huy Thắng.
Thật ra thì trong cái trước đây đó, trước khi có nghiên cứu Treat to Target thì bản thân tôi cũng cố gắng giảm LDL càng thấp càng tốt. Và thông thường cái xu hướng chúng ta sẽ giảm LDL nó dưới 70 mg/dl. Sau đó nhiều đồng nghiệp nghĩ rằng chúng ta sẽ có thể giảm đều. Tuy nhiên từ lúc mà nó công bố nghiên cứu Treat to Target, chúng ta thấy rằng trong nghiên cứu Treat to Target thì cái việc chúng ta làm giảm thêm cái LDL càng thấp thì cái lợi ích nó càng nhiều. Do vậy thông thường hiện nay thì gần như chúng tôi không giảm liều statin khi chúng tôi đã đạt được cái target, trừ khi chúng tôi chỉ giảm liều khi mà bệnh nhân có những cái tác dụng phụ và tôi nghĩ rằng có thể liên quan đến thuốc thì chúng tôi mới giảm liều thôi. Chứ còn bản thân thì chúng tôi sẽ sử dụng liều cao ít nhất là trong vòng một vài năm đầu, là những cái thời gian mà nguy cơ cao nhất của bệnh nhân.
Chúng tôi cũng xin có ý kiến cá nhân. Thì bản thân chúng tôi nghĩ là thuốc mình sử dụng mỗi ngày mỗi uống là tại vì thuốc nó tác dụng chỉ có 24 tiếng. Do đó thì sau 24 tiếng chúng ta phải uống. Như vậy thì chúng ta uống để đạt được cái mục tiêu điều trị với một cái liều nhất định, thì khi chúng ta giảm liều thì chắc chắn là cái mục tiêu đề ra nó sẽ không đạt. Và chúng ta cũng đừng quên là statin không phải là mình tăng liều gấp đôi là hiệu quả nó lên gấp đôi đâu nha. Đối với statin thì nó theo cái quy luật số 6, tức là chúng ta tăng liều gấp đôi thì hiệu quả của nó chỉ tăng thêm lên có 6%. Do đó thì ở cái liều chúng tôi đang lấy ví dụ như bệnh nhân bị hội chứng bằng cấp, trong giai đoạn mà hội chứng bằng cấp và ngay sau đó thì chúng tôi sử dụng liều 80, thì nhiều khi nó còn chưa đạt được liều điều trị, hay là nếu may mắn nó đạt được liều điều trị mà chúng ta giảm xuống 40 thì sợ là nó sẽ không còn đạt được cái mục tiêu điều trị, và như vậy thì nó sẽ không còn có lợi nữa. Do đó trên cái quan điểm cá nhân thì đối với statin là chúng tôi không bao giờ giảm liều, không bao giờ có cái chế độ xuống thang. Chúng ta đừng lẫn lộn với chế độ xuống thang của statin với chế độ xuống thang khi chúng ta sử dụng những cái liệu pháp khác, ví dụ như liệu pháp kháng sinh hay là liệu pháp sử dụng thuốc kháng cái tật thực phẩm. Chúng tôi xin sang một cái câu hỏi khác là kinh nghiệm sử dụng statin trên đối tượng bệnh nhân bệnh thận mạng. Xin mời Phó Giáo sư Thắng.
Đối với bệnh nhân thận mạng thì hiện nay thì vì ngay cái lựa chọn mà hiện nay cái tốt nhất là vẫn là tôi nghĩ là atorvastatin vẫn là cái lựa chọn tốt hơn so với rosuvastatin. Không biết ý kiến thầy Nhân thế nào, bởi vì cái rosuvastatin người ta cũng có khuyến cáo trên các bệnh nhân mà suy thận nặng.
Chúng tôi cũng thống nhất với lại nhận định của Phó Giáo sư Thắng thôi. Thì trước hết khi mà nói bệnh thận mạng thì thật ra nó là một cái giải rất là rộng. Tại vì khi mà độ lọc quãng cầu ước lượng mà dưới 60 thì mình đã coi như, dưới 90 thì mình đã coi như là có bệnh thận mạng giai đoạn 2 rồi. Dưới 60 từ 30 tới 60 thì thành 3A, 3B. Nó thành ra mình nói chung chung bệnh thận mạng thì cũng khó. Nếu mà bệnh nhân bị bệnh thận mạng trong giai đoạn 3 đổ lên thì nó không có chống chỉ định sử dụng statin nha. Và chúng tôi cũng thống nhất với lại Phó Giáo sư Thắng là atorvastatin nó chứng minh cái hiệu quả nó an toàn và nó có trì hoãn cái sự suy giảm chức năng ở bệnh nhân bị bệnh thận mạng. Chúng ta biết là bệnh thận mạng là một cái bệnh lý mãn tính tiến triển, tức là cái tình trạng suy thận nó sẽ càng ngày càng tăng. Thì những bệnh nhân sử dụng statin thì người ta thấy là cái việc suy giảm chức năng thận theo thời gian nó có chậm hơn là những bệnh nhân không được sử dụng statin. Khi người ta bị bệnh thận mạng tới cái giai đoạn 5, tức là khi độ lọc quãng cầu nó dưới 15 ml và bắt đầu phải nghĩ tới cái biện pháp là phải chạy thận định kỳ cho bệnh nhân, thì lúc này nó đặt ra hai tình huống. Một cái tình huống là bệnh nhân chưa dùng statin thì người ta khuyên là lúc này ở cái giai đoạn này rồi thì khoan hãy dùng. Còn khi mà bệnh nhân đã chạy thận định kỳ rồi thì lúc đó chúng ta có thể sử dụng. Còn nếu như bệnh nhân đã suy thận, sắp sửa phải chạy thận định kỳ nhưng mà bệnh nhân đã sử dụng statin rồi thì các cái chuyên gia cũng khuyến cáo là không nên ngưng. Đang xài thì không ngưng, chưa xài thì khoan xài. Và khi đã chạy thận định kỳ rồi thì mình có thể sử dụng an toàn, không có gì phải lo lắng. Thì chúng tôi xin hỏi bộ phận kỹ thuật là có còn câu hỏi nào nữa không ạ? Nếu không còn câu hỏi nào từ quý đồng nghiệp thì chúng tôi xin tổng kết. Thì thông qua hai bài báo cáo của tiến sĩ Đinh Đức Huy và Phó Giáo sư Nguyễn Huy Thắng, chúng ta thấy là cái vai trò của statin là cực kỳ quan trọng trong bệnh lý tim mạch. Tim mạch ở đây là tim, tức là giường mạch vành, và mạch ở đây là mạch não cho những cái bệnh nhân bị đột quỵ. Và theo các cái khuyến cáo hiện nay thì để điều trị dự phòng nguyên phát cho bệnh nhân nguy cơ cao hay là điều trị dự phòng thứ phát thì chúng ta cũng nên sử dụng statin thế hệ mới, tức là atorvastatin hay rosuvastatin mới ở trong ngoặc kép, và phải sử dụng liều cao thì mới đạt được cái mục tiêu điều trị cũng như mới đạt được những ích lợi mà những cái công trình nghiên cứu cho thấy. Chứ nếu chúng ta sử dụng cái liều không đủ thì chắc là cái ích lợi của cái việc sử dụng statin nó sẽ không cao như là chúng ta kỳ vọng. Chúng tôi xin phép là có một câu hỏi, cái này gọi là câu hỏi chót trước khi chúng ta chấm dứt chương trình. Đó là khi khởi trị statin thì sử dụng liều tăng dần đến khi đạt liều khuyến cáo hay có thể khởi đầu với liều cao statin luôn? Thì cái này thì mình có thể ước lượng dựa trên cái chỉ số LDL cholesterol ban đầu của bệnh nhân. Nếu ví dụ như ban đầu mình thấy nó đã ngấp ngưỡng gần đạt mục tiêu thì mình có thể nhấp thử cái liều 20. Tuy nhiên nếu mình điều trị dự phòng thứ phát, tức là bệnh nhân đã có biến cố rồi, hoặc là cái chỉ số LDL cholesterol ban đầu nó quá cao, thì theo ý quan điểm cá nhân là chúng tôi sử dụng liền cái liều là 80 mg hay là 40 mg nếu mình ngại. Chúng tôi xin ý kiến của Phó Giáo sư Thắng về cái câu hỏi này.
Dạ, đối với các bác sĩ đột quỵ con em thì đối với bệnh nhân đã bị đột quỵ rồi thì chắc chắn mình sẽ dùng liều cao và ngay từ đầu.
Dạ, xin cảm ơn Phó Giáo sư Nguyễn Huy Thắng và xin cảm ơn quý đồng nghiệp đã tham dự chương trình cũng như là đặt những cái câu hỏi có tính chất thực tế, thực hành trong cái công việc hàng ngày của mình. Xin cảm ơn quý đồng nghiệp và xin tuyên bố là chấm dứt cái phiên hội thảo ngày hôm nay.
Dạ, em xin chào thầy ạ.
Thầy chào Thắng.
Dạ.
Xin cảm ơn bộ phận IT và bộ phận thư ký.
At Viatris, we aim to empower people worldwide to live healthier at every stage of life. We're dedicated to delivering increased access to the medicines patients need, regardless of geography or circumstance. Because at Viatris, we believe in healthcare, not as it is, but as it should be.
Recording in progress.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Chào mừng các quý vị và các bạn đồng nghiệp đến với phiên chuyên đề. Trong cái phiên chuyên đề ngày hôm nay chúng ta sẽ trao đổi với nhau bằng tiếng Anh cùng với các speaker nước ngoài. Các bạn có thể lựa chọn cái đường dịch bằng tiếng Việt trên kênh của Zoom. Và bây giờ chúng ta sẽ bắt đầu vào cái phiên này. Tôi sẽ xin được chuyển sang nói tiếng Anh cùng với các bạn. Welcome every people to the sections. Today we have a very specific symposium on update on diagnostics of cardiomyopathies. I'm Associate Professor Nguyễn Ngọc Quang from Vietnam National Heart Institute, the chairperson of this section. The co-person chair with me is Professor Olivier from Toulouse Ranguet University Hospital of Toulouse. He's already worked with our association for a long time, and we have already very good success sections on emerging modality for coronary syndrome last year. And this year he came back for a very specific symposium on cardiomyopathy. We have two other special speakers, Professor Ewan Donan from Hospital Pontcharloux de Rennes, Français, and also Professor Philippe Charon, the Hospital Pitié-Salpêtrière Paris Français. On the panelists, we have another associate professor, Leung Kung Thức and Lê Minh Khôi from two big hospitals in Hanoi and Ho Chi Minh City. And now we start with the symposium. The first speaker, Professor Olivier, will present what the underlying pathology of heart failure with the preserved LV function. I think it is a great talk. Will provide us a very briefly overview background of the underlying pathology for the heart failure with preserved ejection fraction. Professor Olivier, please.
Thank you for the introduction. I'm going to try to talk about the pathophysiology of heart failure with preserved ejection fraction. I have 20 minutes. I'm going to try to do that in 20 minutes. So here, can you see my screen? I guess it's okay.
Yes.
Good. Thank you for the introduction, and it's a really it's a pleasure to do this presentation to this Congress. And I'm going to try to do this presentation on the pathophysiology of heart failure with preserved ejection fraction. And to start, maybe the first question, it's probably that ejection fraction is not the really best tool to assess heart failure. And we know that ejection fraction is a really good tool because we are dealing with ejection fraction every day, and we are giving the treatment and the therapeutic of heart failure according to ejection fraction. But the issue is that we know that there is a wide spectrum of heart failure according to the ejection fraction. And the main issue is that it's pretty easy to do the diagnosis of heart failure according to the low ejection fraction, but the preserved ejection fraction is probably hard to explore. And we know that we need symptoms, we need preserved ejection fraction, we need probably elevation of natriuretic peptide, and we need functional and structural abnormality of the myocardium and of the left atrium. And there is some limitation of the ejection fraction, and I like to show this slide showing in the middle the normal myocardium with end diastolic volume of 100 milliliters and the systolic volume of 40 milliliters, stroke volume of 60 milliliters, and left ventricular ejection fraction of 60%. And if you look on the left, you see an enlargement of the left ventricle with an end diastolic volume of 200 milliliters, and you can see a stroke volume of 120 millimeters, and ejection fraction. This is not right. I made a mistake here, but increased ejection fraction. And if you look on the right, and this will be the topic of this presentation, this is kind of left ventricular remodeling with left ventricular hypertrophy, and you can see there is a decrease of the end diastolic volume, and this is automatically an increase of the left ventricular ejection fraction. And if you consider these three left ventricular function, you will see that the most performant left ventricle is on the left, and you see this is the less efficient ventricle is on the right, and this is the most increased ejection fraction. And this is the issue with the ejection fraction, that the ejection fraction is not the best tool to assess the left ventricle. And this is this is an issue because left ventricular ejection fraction is not considering the myocardial remodeling. And the myocardial remodeling is probably more complex. And if you look here, you can see that you can have an increase of the left ventricular mass, and this is typically dilated cardiomyopathy. And we know that there is eccentric hypertrophy with the increase of the mass and decrease of the left ventricular ejection fraction. But we know that we can get patients with left ventricular hypertrophy and concentric hypertrophy with the increase of the mass of the left ventricle and the increase of the left ventricular thickness, and patient without increase of the left ventricular mass, but increase of the left ventricular thickness, and a decrease of the left ventricular performance, diastolic dysfunction without decrease of the left ventricular ejection fraction. And we know now this is a big issue. And among the comorbidity, chronic condition linked to the left ventricular dysfunction, we know that hypertension is it's one of the most powerful chronic condition. And there is a kind of confusion between the transition with patients with left ventricular hypertrophy, concentric remodeling, and symptomatic heart failure with normal ejection fraction, and patients with decrease of the ejection fraction. And among the chronic condition allowing this transition, there is probably myocardial infarction, diabetes, and a lot of conditions leading to the transition between preserved ejection fraction and decreased ejection fraction. And are we dealing and are we talking about the same pathology? This is hard to say. And this is here factors influencing the left ventricular geometry and remodeling among patients with hypertension, which is one of the most chronic conditions linked to the preserved ejection fraction. And we can see that there is a lot of conditions leading to the decrease of the left ventricular ejection fraction. And the main issue is that if we consider the guidelines of heart failure, there is the mention that we need preserved ejection fraction and structural abnormality of the left ventricle and left atrium. And here we can see that in patients with preserved ejection fraction heart failure and preserved ejection fraction, there is not always left ventricular hypertrophy, and we can see that in more than 40% of patients, there is no left ventricular hypertrophy. In more than 1/3 of patients, it's almost 1/3 of patients, there is normal diastolic function, I mean in normal condition. And we know that the diastolic function, it's pretty hard to assess, and there is a variation of the diastolic function according to the age and varying during the time. And if we are looking at the left atrial size, we will see that in almost 1/3 of patients, we will have normal atrial size. So assess heart failure and preserved ejection fraction can be really tricky, and that's why it's probably a complex pathophysiology, and it's probably a hard condition to explore. And I think there is 3 main pathophysiological way leading to heart failure and preserved ejection fraction. There is a decrease of vascular function with endothelial dysfunction leading to impaired ventricular arterial coupling. There is an increase of myocardial stiffness leading to diastolic dysfunction. There is the atrial dysfunction with impaired diastolic reserve leading to pulmonary vascular remodeling. And there is an impaired, at the end, peripheral muscle abnormalities. So first, it's the first cause of heart failures with preserved ejection fraction is probably the vascular dysfunction. We know that the arterial compliance is probably the first step of the dysfunction. And we know that the aging people are leading to decrease of vascular dysfunction, leading to, for example, arterial hypertension. And here is the illustration of the issue of the compliance. You can see there is a kind of pulsatile function without compliance. And you can see here the same with compliance, and the pressure is low and the flow is continue. I'm gonna show you again. This is a pulsatile flow with increased pressure and without compliance. This is the same with continued flow with compliance and without increase of pressure. And this is the main issue in heart failure with preserved ejection fraction. We know that there is endothelial dysfunction with decrease of reactive hyperemia index in patients, and that's why patients with heart failure and preserved ejection fraction have endothelial dysfunction. This is really well described. And this is gonna lead to the ventricular arterial coupling impairment. I mean that there is a dissociation between the ventricular function, left ventricular function, and arterial performance. And we know that there is impaired ventricular arterial coupling. And this is gonna lead to the decrease of the performance of the ventricle. That's why it's hard to dissociate the ventricular performance to the arterial compliance. The next step will be the myocardial parietal stiffness. And as I already showed for the arterial performance, this is the same for the myocardial performance. We know that we are going to have kind of fibrosis within the myocardium, leading to the increase of the stiffness of the myocardium, and this is gonna lead to the decrease of the compliance of the myocardium. And if we consider the composition of the myocardium, we will see that we are going to increase the collagen composition of the myocardium and decrease of the titin composition, which is kind of elastic protein within the myocardium. And if you consider studies with cardiac MRI, we know that there is an increase of the extracellular volume, and there is an increase of the fibrosis within the myocardium, and that can explain the decrease of the compliance of the myocardium. Here, there is the relation between the left ventricular pressure and the time. And we know that in patients with left ventricular, with heart failure and preserved ejection fraction, there is a decrease of the relaxation of the myocardium, leading to the delay of the relaxation. But we know that there is a decrease of the compliance of the myocardium, leading to the increase of the pressure all the time we increase the volume. I mean that in normal person, theoretically, you should be able to increase the volume without increasing the pressure. But in patients with heart failure and preserved ejection fraction, the increase of the volume is gonna lead to the increase of the pressure. And this is particularly true if you are doing exercise. That's why patients has a lot of symptoms when they are working and when they are doing exercise. And this is the main issue of the compliance of the left ventricle. Finally, all that is going to lead to atrial dysfunction. And atrial dysfunction is probably one of the most well-known point of heart failure with preserved ejection fraction. And we know that in patients with heart failure and preserved ejection fraction, there is an enlargement of the left atrium, and there is a decrease of the left atrial function. And in this patient, if they are doing exercise, and you can see here regarding the A wave of the mitral valve, there is a decrease of the A wave during exercise, and patients are not able to feel the left ventricle because of the decrease of the compliance of the left ventricle. And this is going to lead symptoms, but also this is going to lead to chronotropic impaired response to exercise. I mean that patients are not able to increase the heart rate when they are doing exercise, and this is gonna lead to the decrease of the cardiac output during exercise. All that is going to give hypertension because of the increase of the left ventricular filling pressure. And we know, this is well known, that there is there is pulmonary hypertension in patients with heart failure and preserved ejection fraction, because when there is left atrial enlargement and increase of the left atrial pressure, there is an increase of the pulmonary arterial wedge pressure, and this is going to lead to the decrease of the pulmonary arterial compliance, and this is going to lead to the decrease of the right ventricular function. So there is a link, a really thick link between the left ventricular function and the right ventricular function, and we cannot dissociate the heart failure with preserved ejection fraction to the pulmonary arterial compliance and to the right ventricular function. And that's why that's well known. There is a right ventricular dysfunction in patients with preserved ejection fraction, heart failure and preserved ejection fraction. And this is gonna lead to the decrease of the prognosis of the patient. And at the end, we will see the systemic involvement of the disease with a decrease of the muscle function and a decrease of the modification of the composition of the muscles in the peripheral impact of heart failure with preserved ejection fraction, with the decrease of the performance of the muscles, leading to the decrease of the performance of the patient and leading to the symptoms of the patient. That's why, and this is the case for all patients with heart failure. This is not only the case with patients with preserved ejection fraction, but it's really important to remember that heart failure is not an issue of the heart. It's an issue of the heart and the vascular system, leading to an issue of the systems with decrease of the performance of the muscles, and decrease of the performance of the kidney, decrease of the performance of all the organs. And there is a link between organs and the muscles, and cardiac remodeling should not be considered by itself, but including in the whole system. And in many ways, we know that heart failure with preserved ejection fraction has probably the same link with the aging condition. And that's why we cannot split aging to the chronic condition leading to heart failure with preserved ejection fraction. And this is the case for hypertension, but we know that obesity can link to heart failure to preserved ejection fraction. We know that there is a lot of chronic condition leading to this condition, and all are linked to the aging. And that's why this is a really complex physiopathology. Thank you for your attention.
Thank you, Professor Olivier, for the great talk, and we can see a very complex pathology of the heart failure with the preserved ejection fraction. Actually, you didn't mention about the abdominal compartment, or which component is quite big enough in the last in the few last slide, and maybe we can discuss something about that when we prepare for the Professor Ewan Donald. So Professor Olivier, can you give some comment about the abdominal compartment contribution to the
Actually, for the abdominal compartment, there is a main issue of the abdominal compartment when you consider when there is a kind of third volume expansion with the hepatic issue. But in practice, the systemic involvement of the abdominal compartment, it's an issue when there is an increase of the volume. and we can consider the abdominal comportment if we consider that there is a link between the probably endocrine involvement of the abdominal compartment and cardiac remodeling. But this is not the main, I think from my point of view, this is not the main issue of the heart failure.
Okay.
But I mean, in practice, obesity it's probably one of the main chronic conditions leading to heart failure with preserved ejection fraction. So there is probably a link, but this link is not really well described.
Yeah, I think this is a great comment for the pathology for that one. So basically, back to the basic in the clinical practice, usually we have a question and how we can what we can do to for the heart failure. When do you need to think about the cardiomyopathy on screening a symptomatic healthy or athletic person by echocardiography? Because sometimes it's very difficult to differentiate. So for this talk, we would like to invite Professor Ewan Tunan to give this talk about this very specific topic.
Dear colleagues, dear friends, it's a real pleasure to be with you today to discuss about the role of echocardiography in the diagnosis of cardiomyopathies in athletes, persons, or healthy ones. First of all, I would like to start with an illustrative case. It's a patient that I saw a few weeks ago with semi-professional soccer guy, 25 years old. And you see that this guy who is asymptomatic has a complete abnormal EKG. You see this LVH with this T wave that are completely abnormal. Then we did an echocardiography. And as you can see, this guy who is playing football every day, more than 2 hours a day, has an interventricular septum of 13 millimeter and a LV and diastolic diameter of 49 millimeter. You see that the valves are normal, the aorta is normal, the LV function is normal. Then we checked for the apical views and the LV ejection fraction is totally normal. As you can see, the size of the LV, the size of the RV, the size of the LA are completely normal, and the global longitudinal strain is a little bit low, minus 18% at rest. When you look at the pulse DTI, you observe that at the septum, at the lateral wall, as well as the right ventricular free wall, you have a S prime wave greater than 9 centimeters per second, as well as the E prime wave, which means that the LV systolic and early diastolic function is normal. The LV systolic function is normal, as well as the relaxation. When you have to assess an athlete, when you think about a cardiomyopathy, if you look back at the EKG, you might think about a hypertrophic cardiomyopathy. But then when you look at the echo, the septum is 13. Look at the stroke volume and the output. You see that the LVOT VTI is supranormal. The diastolic function is normal. So we really probably have a patient who has an abnormal EKG, but without any cardiovascular disease. But let's move on. And then we have to look at the LV, of course. We will discuss furthermore about the LA, but we shouldn't forget about the right ventricle. And you see that in the present case, the right ventricle is normal in size, normal in function. And when you look at the strain of the RV, you see that the function is normal and the peaks are well synchronized, which means that the RV is really completely normal. And then if you are still in doubt, you have the EKG which is completely abnormal in this patient with soccer guy, and he practice a lot, and then you want to make sure that there is no cardiomyopathy. So you can do only the echo, but it could be nice sometimes to do also the CMR to check for the presence of left gadolinium enhancement and to check for the size of the cavities. As you can see on that movie, the cavities are completely normal, the LV, the RV, as well as the atria. And there is no left gadolinium enhancement, there is no fibrosis, nothing is abnormal in this patient. So it's really important to keep in mind that the term athlete's heart refers to the clinical picture characterized by a slow heart rate, an enlargement of the heart most of the time. You start with the clinical examination, you do the EKG, and then you move on to the echocardiography. You will check for the thickness of the left ventricle, you will check for the size of the cavity, and you can expect an increase in size if the patient is an athlete. You check for the size, you check also for the function. Most of the time, the LV ejection fraction is a little bit low, as well as the global longitudinal strain. But if you look at the global longitudinal strain, the peaks should be synchronized. There shouldn't be any dysynchrony between the systolic peak of each of the LV segments. You check for the LV output, and this LV output should be normal or supranormal. And of course, in an athlete, you shouldn't find any abnormality of the diastolic function, as well as any abnormality of the RV systolic function, looking at the TAPSE, S prime, regurgitant surface area, change during systole and diastole, as well as RV strain, as I showed you on the previous slide. Here you have a nice overview of the normal and higher value you can expect in terms of size, as well as in terms of systolic and diastolic function in athletes. You have these nice review papers that has been published by Maurizio Galdaresi, thanks to the EACVI. And you see that most of the time, the LV and diastolic diameter should be about 55 millimeter, but could reach 70 millimeter. You see that the S prime should always be higher than 9 centimeters per second. And you see that you can find some degree of LA enlargement, but this LA enlargement should be associated with a normal systolic function, which means that the reservoir function of the left atrium should be normal. And you can use the strain, the longitudinal strain, to assess this LA longitudinal function. If you are in doubt, if you think that the athlete might have an idiopathic dilated cardiomyopathy or an hypertrophic an hypertrophic cardiomyopathy, then you do the EKG, which is most of the time abnormal, and then you discuss with the patient, you try to understand how much he practice sport, which kind of sport does it practice, and then you look at the echo. If you have a thickness of the left ventricle below 12 millimeter with a normal diastolic function, then you probably have an athlete without any cardiomyopathy. If the thickness of the left ventricle is greater than 12 millimeter with some degree of diastolic dysfunction, then you have to do a CMR and perhaps also an exercise stress echocardiography to confirm the diagnosis of hypertrophic cardiomyopathy. If you think about a dilated cardiomyopathy, you look at the end diastolic diameter. If the end diastolic diameter is below 60 millimeter with a normal LV ejection fraction, it's probably an athlete. If there is a reduced in LV ejection fraction with an end diastolic diameter greater than 60 millimeter, then you can stress the patient to make sure that he normalizes the function during the exercise, and you can do a CMR to check for the lead gadolinium enhancement, which means that you check for the fibrosis. And then if there is some degree of LV fibrosis, then probably the patient has some degree of dilated cardiomyopathy. You can think about hypertrophic cardiomyopathy. You can think about dilated cardiomyopathy. You have also to avoid the patients who might have a coronary artery disease, and for that purpose, the exercise stress echocardiography is fundamental to make sure that there is no ischemia when the patient is doing some exercise. Of course, you can do a CT scan to check for the coronary arteries, but first of all, you have to check for the function, and then you do an exercise stress echo to reproduce the exercises that the patient is doing in his real life. And if it's normal, you are comfortable. There is one disease that you should think about, is the right ventricular cardiomyopathy. And this arrhythmic right ventricular cardiomyopathy is sometimes difficult to diagnose, but it's something that you should diagnose. So you have to look at the EKG. You have to look at the RV function using the TAPSE, S prime, but you should look at the RV strain, the morphology, and the size of the right ventricle. If the RV size and function are completely normal, you are comfortable, there is no doubt that the patient might have or something wrong with the right ventricle. If you are in doubt, if the RV is enlarged, or if the function is not strictly normal, then you have to perform a CMR. You have to check for the presence or not of an arrhythmic right ventricular cardiomyopathy. So check for the right ventricle, it's very important. And as I told you before, you also have to check for the left atrium. It's very important because most of the time in athletes, you have an increase in size of the left atrium. But if you have an increase in size of the left atrium, it shouldn't be associated with a risk of arrhythmia. And then you have also to check the function. And if the LA function is completely normal, and it's very easy to check that with the LA strain, if you have a reservoir function greater than 40% during the LV systole, then you are confident the patient has an enlargement of the left atrium that is related to the sport practice and not to a disease. So check for the LV, check for the LA, check for the RV. It's very important. And if you are still in doubt, you have to perform a cardiac magnetic resonance imaging, and you have to perform an exercise stress echocardiography to see how the patient is behaving during the exercise. It's very important to check the patient when he's exercising because it's his real life. So this is my last slide actually, and you have to keep in mind that if you are an athlete, you have an adaptation of the left ventricle, you have an adaptation of the left atrium as well as the right ventricle. And then you have to take that into consideration. You have to take into consideration the heart rate, the normal increase in size of the cavities, and you have to integrate the clinic, the parameters that the patient told to you. You have to look at the EKG, you have to look at the rest echocardiography, but sometimes, quite frequently actually, you have to stress the patient and do an exercise stress echocardiography, and sometimes also a CMR to check for the presence or not of a lead gadolinium enhancement. Thank you very much for your kind attention, and I hope to see you soon.
Thank you very much, Professor Ekwon-Donan, for the great talk. And we have a very few index to identify the cardiomyopathy when you screening a healthy and asymptomatic patient. So I just got a few questions from the local audience. And first of all, I would like to ask Professor Ekwon-Donan. So you mentioned about the RV function. So which one is the best index for the RV function? Because we have a list of a lot of things. So which one you prefer for the RV function?
Thank you for the question. I think that the most sensitive parameter is to look at the RV strain for sure, because it's a way to assess not only the global function, but also the regional function. And usually when you have a right ventricular, the arrhythmic right ventricular cardiomyopathy, then you might have some segmental abnormalities. And then it's a better way to check for the RV function than just looking at the TAPSE or the S prime, because TAPSE and S prime are easy to perform for sure, but not sensitive enough to demonstrate that there is something wrong with the RV. And of course, you shouldn't forget about the size and the geometry of the right ventricle, because most of the time when you have an arrhythmic right ventricular cardiomyopathy, there are some abnormalities in the geometry of the right ventricle, especially in the outflow.
Yeah, thank you. We have another question for Professor Olivier. How the left atrial and ventricular strain in the heart failure preserve EF and the role for the prognostic of the ECG?
Yeah, that's I guess a really I think a really good question, because strain is probably the most not powerful, but I think it's a really good tool to assess the prognosis and to make the difference between normal ejection fraction and decrease, I mean, heart failure with preserved ejection fraction. Regarding the left ventricle, we know that the strain is better than the ejection fraction to assess the prognosis. I will do a talk of that later during this congress, and this is probably the best tool to assess the prognosis. We know that that's better than left ventricular ejection fraction. And for the left atrial strain, it's a really good tool, and Ekwon-Donan is there and will be better than me to talk about that. But we know that the left atrial strain is a really good tool to assess the left atrial function and to explore patients with decrease of left atrial function and to decrease of the prognosis of patients with preserved ejection fraction. The main issue of this disease, heart failures with preserved ejection fraction, is that it's hard to explore, and as I show, it's hard to make the difference between normal patients in patients with heart failure and the strain. I think from my point of view, I think that the strain, it's a powerful tool to make the difference between normal patient and patient with a decrease of the left ventricular function of left atrial function.
Thank you. We have a question for Professor Evan Donat. How about the cutoff point for the worm thickness to distinguish cardiomyopathy hypertrophy from the atelic cardiomyopathy? It is a 12 or 13 millimeter.
Yes, it's a good question actually, because usually we have this cutoff of 13, but it's funny. I'm smiling a bit because Olivier did a paper about this cutoff of 12 to look for cardiomyopathy, and I think it's a good way to do, because if you use this cutoff of 12, it means that you will perform exams to patients who are normal, but you will not miss any patient with an abnormality. So the goal when you have an athlete is to make sure that everything is perfectly normal. So to use this cutoff of 12, it's a way to perform more exams in patients that are potentially abnormal with a cardiomyopathy. So it's a way to don't miss any Fabry disease, any sarcomeric hypertrophic cardiomyopathy. So if you have 12, you do an exercise stress echo, you check for the strain and so on. And most of the time you do also the CMR to make sure that there is no LGE.
Yeah, we have another question from the audience. So is there any difference between the sport? For example, if one patient run a marathon and another one is usually like a weightlifting, so is there any difference in terms of size and structure of the LV for that?
Sure, there is a difference, but it's not a very impressive difference actually. Of course, if you are doing a marathon, you increase the size more than the thickness. But the fact is that sometimes you have patients, or you are normal athletes who can't adapt their RV function to the importance of the exercise practice. And I remember one patient who was a very good soccer player, supposed to be in the French team. And actually, these guys practice a lot, and we observe over time an increase in size of the RV. And then it has been necessary to stop him and to stop his career because of this incapability of the right ventricle to adapt to the practice of sport, to the intensive practice of sport. So I think the change in shape and size are not that important usually, but if you see something wrong, if you see that the size of the RV is increasing, you have to think about the arrhythmic right ventricular cardiomyopathy, whatever the sport practiced.
Yeah, thank you. We have another question for Professor Olivier. So is there any way to assess this synchronization in the LV and RV, and is there any important for the screening for the atelic people?
You mean for heart failure with preserved ejection fraction or athletic people?
Yeah, I mean, so the question is for the heart failure preserved EF. But we want to extend a little bit further for the people with the atelic, because sometimes we screening for the patient and we see the RV size and function, LV size and function, and sometimes we did not notice very much about the synchronized between the LV and RV. So is there any important for this kind of the index?
Yeah, there is a asynchronism between right ventricle and left ventricle in patients with heart failure in the wide population of patients with heart failure, and particularly that's true also with patients with heart failure and preserved ejection fraction. But from my point of view, this is not enough to make to the diagnosis of heart failure with preserved ejection fraction, because I think it's really hard. I mean, not hard, but it's tricky. It's hard to assess, and I think we cannot make the diagnosis on this only point. this is well known. There is a asynchronism, but I think it's not enough to make the diagnosis of heart failure with preserved ejection fraction. But actually, Erwan Dolal will be better than me to talk about that.
No, I think the look, if we can look at the desynchrony or the heterogeneity in peaks, it's something that can be used to just say that the patient is potentially abnormal, but it's not enough to make a diagnosis.
And the last question before we move to the next part of this symposium, is there any cutoff for the LVA size, like LV?
The RS size, normally it shouldn't be greater than 34 milliliter per meter square.
Yeah.
So it's the same as the LA actually.
Okay.
And you measure the volume only in apical four-chamber view.
Yeah, I think we still have a few more questions, but we move to the second part, and we continue with the discussion later on. So for the next talk, we would like to invite Professor Olivier Laser. We continue with another topic on update on the role of the multiple imaging modality for diagnosis and prognosis of the cardiomyopathy.
Thank you for the introduction, and once again, thank you for the scientific committee to give me the opportunity to do this talk. And this is a trick topic with a lot to say about the multimodality imaging of the exploration of cardiomyopathies. To do this talk, I use this position paper of the Heart Failure Association of the EC, and there is a different step to explore cardiomyopathy according to the left ventricular ejection fraction. But we saw previously in the talk of Erwan Dolal that the right ventricular function is probably also important to explore, but we will see that later. And I would like to show you the different steps of this workup in the diagnosis of cardiomyopathy. And the first step is probably to do a clinical examination, to do the ECG, and to do the biological exploration with typically biomarkers. And the second step, we will see that the echocardiography is probably the first step, I mean the first line imaging to explore patients with cardiomyopathy, and we are always using echocardiography in this indication to explore systolic function, diastolic function, and to explore the structure of the heart. And in this step, there is a way to rule out a valvular disease, and echocardiography will be the most important tool to rule out a valvular disease. And in this way, we have to rule out coronary artery disease, because we know that in all patients with cardiomyopathy, there is a risk of coronary artery disease. And the first step before treating a disease is to be sure this is not a coronary artery, I mean the ischemic cardiomyopathy with preserved ejection fraction or decrease of ejection fraction. And after that, we have to check for the etiology, and if we check for the etiology, we will see that CMR, cardiac MRI, will be the first tool to explore the etiology of the cardiomyopathy, because it's probably the best tool to explore the myocardium. And why MRI is so important? Probably because it's able to give the etiology of the cardiomyopathy. We will see that MRI is really a really good tool to explore the prognosis of the patient, and MRI it's a really good tool to follow the patient and to monitor the treatment. And why MRI is so good? Probably because there is a really good contrast and morphology without the need of a specific contrast product, and MRI is able to give the late gadolinium enhancement, and we will see that, and we already saw that in the previous talk. This is a really good tool to assess the myocardium and to assess the prognosis of the patient. And we know that MRI is able to give the T1 mapping with the extracellular volume, and this is a tool to assess the fibrosis of the myocardium, and really good tool to assess the prognosis of the patient. And we saw that in this workup, it's really important to be able to rule out coronary artery disease. And if there is a low probability of coronary artery disease, but we want to be sure that there is no coronary artery disease, maybe the most useful tool is probably the CT, because the CT is able to rule out coronary artery disease. The CT is also a good tool to explore the calcification of the valve, but it's really a good tool to rule out coronary artery disease. And it's not a good tool to explore coronary artery disease, but when we want to be sure that there is no coronary artery disease, CT is probably the most useful tool. Because we know that in patients without coronary artery disease and without calcification on the CT, there is a really good prognosis of the patient. So now if we consider the different phenotype of patients with cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, or right ventricular enlargement, we are going to see that MRI will be the best tool to explore all the patients with a myocardial abnormality. And the first step, it's the first classification is probably patients with dilated cardiomyopathies. Here you can see a patient with a decrease of the left ventricular ejection fraction, and you can see that there is a really good contrast with, you can see here, there is thrombus at the apex of the left ventricle, and you can see there is a lot of trabeculation in this patient, and you can see that, and I guess that we in this patient we will not be able to see the thrombus at the apex without I mean using echocardiography, and you can see that the contrast using MRI is really good and is able to quantify the trabeculation, and this is probably the first diagnosis to explore when you are dealing with the dilated cardiomyopathy. It's to be able to make the diagnosis of left ventricular non-compaction. And we know that when we are using MRI, we can make the diagnosis using the non-compacted to compacted ratio with a cutoff value of 2.3 at the end diastole, and that's it's really useful using MRI because it's really easy to see the trabeculation of the patient, and that's why in the study of Marseille in France, they were able. This is a little bit time consuming, but they were able to quantify the trabeculation and to quantify the mass of the trabeculation, showing that there is a difference between a dilated left ventricular non-compaction, dilated cardiomyopathy, hypertrophic cardiomyopathy. So MRI is probably one of the best tools to explore this kind of diagnosis, but the main issue, and we saw that in the study, is that when there is a left ventricular enlargement, left ventricular dilatation, there is an increase of the trabeculation, and there is probably an overdiagnosis of left ventricular non-compaction using MRI because we can see perfectly the trabeculation of the left ventricle, and this is probably an issue leading to the overdiagnosis of left ventricular non-compaction. And that's why nowadays we should do genetics in all patients because the diagnosis of left ventricular non-compaction is probably hard to make using only MRI. The other way, when we are dealing with dilated cardiomyopathy, is to consider that among patients with non-obstructive coronary artery disease, there is a small part. It's not really a small part. It's 13% of patients with really myocardial scare using with late gadolinium enhancement and myocardial scare at the MRI. without stenosis at the coronary angiography. And MRI is the only one tool able to make the diagnosis of ischemic cardiomyopathy on the basis of myocardial infarction with late gadolinium transmural or endocardial late gadolinium enhancement. And we know that since the study of the Danish population, we know that can impact the prognosis, because we know that in patients with dilated cardiomyopathy, there is always a question: are we going to put an implantable cardiac defibrillator, or are we going to lead the patient like that? And if there is the ischemic scare, I mean, if there is myocardial infarction, we know that the prognosis is not the same, and maybe we are going to change the treatment and probably to change the follow-up of the patient. And we know that, and I already saw this slide previously, we know that the fibrosis is the common pathway of the organ failure and the aging population. And when we are dealing with heart failure, we know that fibrosis, it's an important part of the exploration of the myocardium. And we know that the fibrosis is going to change the prognosis. And if you look at the patient, we know that the prognosis is not good. But if you look here, you can see there is a lot of scare within the myocardium. There is a lot of late gadolinium enhancement. And we know that this patient will not have the same prognosis. And you can see here in blue that the patient with late gadolinium enhancement, in red, patient without late gadolinium enhancement. And we know that late gadolinium enhancement is going to increase the all-cause mortality, increase heart failure hospitalizations, and increase the sudden cardiac death of patients. And this is the same for the T1 mapping, that the increase of the extracellular volume means that there is an increase of the fibrosis of the myocardium, and this is gonna lead to the decrease of the prognosis. And what is really interesting is that we know nowadays that this is the same whatever the ejection fraction. And if you consider patient here in red with late gadolinium enhancement, there is an increase of the cardiovascular event. And if you consider the left ejection fraction, you will see that this is the same in all the condition of ejection fraction. I mean, when there is an increase of the late gadolinium enhancement, increase of the myocardial fibrosis, there is an increase of cardiovascular events, and cardiac MRI is the only tool to be able to give this kind of information, because this is not depending of the left ventricular ejection fraction. And what is a little bit more surprising is that we know that the extent of late gadolinium enhancement is going to increase the cardiovascular event, but we know that the late gadolinium enhancement localization will lead to different prognosis according to the localization. And when there is, for example, septal involvement, the prognosis is decreased, and only MRI is able to give you this kind of information. And we know that depending of the pattern of the late gadolinium enhancement, we will have different prognosis of patients. And probably one other tool, but a little bit less common, is the opportunity to use the MIBG imaging to assess the prognosis. And MIBG is able to quantify the sympathetic nervous system, and when there is a decrease of the uptake of the MIBG on the heart, there is an increase of the sympathetic system, and we know that patients will have an increase of the risk of the cardiac death. So MIBG is not really useful in the daily practice, but maybe that's a really good tool to assess the prognosis of patients with dilated cardiomyopathy. And in my practice, if I want to know if the patient has a risk of sudden cardiac death, I use this tool to make the difference between patients with a risk and with patients with high risk. The second part is the exploration of patients with hypertrophic heart with the increase of left ventricular thickness. And we already saw in the previous talk that the first step is probably to rule out a patient with athletic heart. And we know that in this patient, if there is late gadolinium enhancement, and we already saw that in the previous talk, that this is a pathologic heart. And we know that late gadolinium enhancement is not normal in patient. And if there is late gadolinium enhancement, we know that this is a pathologic heart, and this is not because of the sport. And we know that in patients with hypertrophic cardiomyopathy, there is a lot of condition and different diagnosis with sarcomeric cardiomyopathy and rare disease. And actually, we did a study regarding patients with left ventricular hypertrophy, and we know that one of the most common diagnosis is probably the sarcomeric hypertrophic cardiomyopathy, but there is also a lot of patients with cardiac amyloidosis. And I think that the cardiac amyloidosis, you can see here, it's 1/3 of the patients with left ventricular hypertrophy. I think that cardiac amyloidosis is probably one of the most common conditions, not the most common, but one of the conditions to rule out when we have patients with hypertrophic cardiomyopathy. And we know that in this situation, echocardiography is probably one of the best tools to explore, to rule out, and not to rule out, but to do the diagnosis of cardiac amyloidosis, because we know this typical situation with the relative apical sparing of the longitudinal strain. And if you add this relative apical sparing to the diastolic dysfunction here with the deceleration time of the E wave at the mitral valve, you can see that you are able to discriminate patients with cardiac amyloidosis. And in this situation, the most powerful tool will be probably to perform bone scintigraphy, because we know that bone scintigraphy, it's a really good tool to explore patients with suspicion of cardiac amyloidosis. And bone scintigraphy will be able to make the diagnosis of TTR cardiomyopathy. The main issue will be probably the light chain amyloidosis, because we know that the bone scintigraphy is not a good tool to make the diagnosis of light chain amyloidosis. But you can see here, regarding the heart to the whole body ratio, you can see that in all patients with TTR amyloidosis, the bone scintigraphy will be able to make the diagnosis of cardiac amyloidosis. So after rolling out cardiac amyloidosis, I think that MRI is the most powerful tool to explore this kind of patient, because there is a lot of because of the late gadolinium enhancement, and there is a lot of different late gadolinium enhancement pattern allowing to make the diagnosis of hypertrophic cardiomyopathy, or allowing to suspect Fabry disease, or allowing to suspect light chain amyloidosis, for example, if the bone scintigraphy is negative, and allowing to suspect sarcoidosis, for example. And if we suspect sarcoidosis, probably the nuclear medicine will be necessary to in the diagnosis workup using myocardial perfusion imaging, and we will see kind of microvascular obstruction leading to the suspicion of sarcoidosis, because we know that in the sarcoidosis there is microvascular obstruction. And the FDG imaging will be really important, because the FDG imaging will be able to show the inflammation of the myocardium. That's why nowadays, if we are suspecting cardiac sarcoidosis, and I think we are not suspecting cardiac sarcoidosis enough, but if we are suspecting cardiac sarcoidosis, MRI is probably the first step, but after MRI, we have to use FDG imaging to show the inflammation of the myocardium. And as I already say, and I already show you, MRI is probably the best tool when there is no etiology of the cardiomyopathy. And in hypertrophic heart, MRI using T1 mapping is able to make the difference between amyloidosis, myocarditis, inflammation, and other conditions. And that's why MRI is probably, after the echocardiography, one of the best tools to make the difference between different cardiomyopathy. And it's important to remember that Fabry disease is the only one cardiomyopathy leading to the decrease of the T1 mapping. There is a decrease of the extracellular volume, and that's why MRI is probably a really good tool to explore hypertrophic heart. Finally, MRI also is a really good tool to explore the prognosis of the patient, because we know that when there is an increase of the extracellular volume, there is an increase of the risk of the sudden death. And MRI can be probably a really good tool if there is a gray condition and we are not sure if we have to put an implantable cardiac defibrillator or not to put it. If there is late gadolinium enhancement, we know that there is an increase of the risk, and probably in this condition, MRI is a really good tool to say that there is a bad prognosis and we probably have to put an implantable cardiac defibrillator. Finally, and I'm going to be fast in these two slides, we already saw in the previous talk that the right ventricular dilatation can be a tricky condition to explore. And MRI, it's a good tool to explore the right ventricle, because we can explore the right ventricle in all the situations, and we can see the right ventricular enlargement, and we can see the wall motion abnormality with some part of akinesia and some part of dyskinesia of the right ventricle, leading to the diagnosis of arrhythmogenic cardiomyopathy. And we know that we will have different prognosis according to the wall motion abnormality using MRI and to the right ventricular or left ventricular involvement in a patient with arrhythmogenic cardiomyopathy. But maybe the future in this field will be the CT, because we know that the CT can discriminate between the fat tissue and the normal tissue. And we know in this kind of patient, the main issue is the fibrosis involvement, but also the fat involvement of the right ventricle. And probably the CT is the most powerful tool to explore the fat inside the heart, inside the myocardium. And in the future, I guess that the CT will be used to explore patients with arrhythmogenic cardiomyopathy. So if I have to summarize what I said regarding the exploration of cardiomyopathy, obviously, transthoracic echocardiography is the first line tool to explore, to make the diagnosis and to do the follow-up. The CT, I think it's really efficient to rule out coronary artery disease and to explore the calcification of the valve. But in practice, I think that cardiac MRI is the most powerful tool and the most useful tool to explore the etiology of the cardiomyopathy and to assess the prognosis of the patient using late gadolinium enhancement and T1 mapping. And we saw that nuclear medicine has a specific indication when there is a suspicion of infiltrative or inflammatory cardiomyopathy. Thank you for your attention.
Thank you, Professor Olivier, for the great talk and a very comprehensive review of the cardiac MI. So to continue, we would like to invite Professor Philippe Charon from the Hospital Saint-Pétier Paris Français to give a talk about the genetic testing in diagnostics of cardiomyopathy. It is already clinically relevant or still premature?
Thank you very much for this introduction. And good morning from Paris. So I will share my screen. I think it should be okay now.
Yeah.
Okay. So first, I would like to thank the scientific committee for the kind invitation. It is my pleasure indeed to speak about genetic testing and cardiomyopathies. And I will try to show you that it is indeed already clinically relevant. So this is my declaration of interest. The starting point is that we know now that cardiomyopathies are frequently of genetic origin, very frequently, in fact. Regarding hypertrophic cardiomyopathy, we know that this disease is considered now as being of genetic origin in nearly all cases, even if we cannot identify the mutation in all cases. And the main mutations are in sarcomeric genes, especially in two genes, beta-myosin heavy chain and myosin binding protein C gene. Regarding dilated cardiomyopathy, we know that this disease is of genetic origin in up to 50% of cases. And the most frequent gene is the titin gene. And there is also another interesting gene we'll speak about, is the lamin AC gene, nuclear membrane protein. And regarding IRVC, arrhythmogenic right ventricular cardiomyopathy, we know now also that it is considered as a genetic disease in nearly all cases. And most mutations are in desmosomal genes, especially the first one is plakophilin-2 gene. Even for a given cardiomyopathy subtype, there are in fact a lot of genes associated with a given cardiomyopathy. For example, in hypertrophic cardiomyopathy, there are more than 50 genes associated with this disease. Most mutations we previously mentioned are related to sarcomeric genes, with the two main genes we mentioned. And they are associated with an autosomal dominant inheritance, so 50% risk for the first degree relatives. But interestingly, there are also genetic but non-sarcomeric genes involved in this disease, especially in the pediatric population. Up to 25% of children with hypertrophic cardiomyopathy are related to a genetic disease in these non-sarcomeric genes, such as Pompe disease, Noonan disease, Friedreich disease. And in adult patients with hypertrophic cardiomyopathy, probably about 10% have a mutation in non-sarcomeric genes, such as Fabry disease and TTR for cardiac amyloidosis. Genetic testing is performed now through next generation sequencing, high throughput sequencing, which is a major recent evolution in the sequencing technology, able to perform massive parallel sequencing. So all the genes of interest can be analyzed at the same time. And we are using now panels of genes for the routine diagnosis. I show you here some of the panels we are using in Paris. Restricted panel level 1 for HCM, 16 genes, and then additional panels for more extended analysis and for other cardiomyopathies. And the perspective is also to perform whole genome sequencing directly in the near future, and we are conducting a pilot study in France regarding this use of genome sequencing for diagnostic purpose. So what about genetic testing in the real life? How frequent is genetic testing performed? We have some insight from the European Society of Cardiology Cardiomyopathy Registry. I had the pleasure to chair. This registry is a prospective registry. Consecutive patients were enrolled by 69 centers from 18 countries. We were able to include more than 3,200 patients, and the main results were reported a few years ago in 2018. And more recently, we focused on the genetic results in this ancillary study conducted by Tina Elio. And you can see here, for example, some of the results. The percentage of the familial forms from a clinical point of view was 48% for HCM, 25% for DCM, for example. Interestingly, genetic testing was performed in this daily practice, in this real life. Genetic testing was performed in 46% of HCM patients, less in DCM, 18%. And you can see also the yield of mutation screening. A mutation was identified in about 43% of HCM patients, 33% of DCM patients, and so on. So the conclusion here is that genetic testing is performed quite frequently in the daily practice also, and this study was conducted some years ago. So it is a good progress in the use of this genetic testing. Indeed, genetic testing diffused quite rapidly in Europe, as an example, because of the various recommendations we have from national or international societies. You can see here some of these recommendations for more than 10 years. And what is very striking is the high level of recommendation for genetic testing for all these guidelines or position statement. Class 1 is recommended for genetic testing in cardiomyopathies. So why such a high level of recommendation for genetic testing? There are several reasons. The first reason for performing genetic testing is the diagnostic workup to assess the etiology of a patient with a cardiomyopathy. And for example, for hypertrophic cardiomyopathy, it is especially important not to miss some specific rare disease, non-sarcomeric disease. We already spoke about some of them because there might be very specific management based on the etiology of cardiomyopathy related to the mode of inheritance that can be different. X-linked, for example, so genetic counseling will be different because of extra cardiac complication, so specific management, and above all, some specific treatment for some of these diseases. For example, in lysosomal disease, such as Pompe disease, Fabry disease, there are enzyme replacement therapy. And for other diseases, such as cardiac amyloidosis related to TTR, transthyretin, there is also a new treatment for that. Tafamidis was shown to be highly relevant because it decreased the mortality of patients with cardiac amyloidosis related to TTR. So it is very important not to miss this particular disease. And another example is Fabry disease, an X-linked disease with alpha galactosidase defect. And we previously mentioned the fact that there is specific therapy with enzyme replacement therapy. And you can see that, once again, the level of recommendation for genetic testing for diagnostic workup is very high, class 1, as compared to other diagnostic tools for the daily practice. And this was confirmed not only in the ESC guidelines about HCM here, but also in the recent US guidelines related to HCM. The second reason for performing genetic testing in a patient with a cardiomyopathy is to improve the prognostic stratification, at least for some situations or some disease, some genes. Here is an example related to dilated cardiomyopathy related to the lamin AC mutation. When you find a mutation in the lamin AC, this is an important point because this is a particular gene associated with high mortality. This was confirmed in this meta-analysis of more than 8,000 DCM patients. This gene was associated with the highest rate of conduction disease and related sudden cardiac death, highest rate of ventricular arrhythmia, and highest rate of heart transplant. So when you identify a mutation in this gene in a patient with DCM, this should lead to early implantation of pacemaker and defibrillator. How to select the patients for ICD in this group of patients? We have now some predictors that were identified to better select ICD implantation. You can see here one of the first study about that with 4 predictors that were identified. and more recently through French collaboration and extended to European and international collaboration, we were able with Karim Wehbi to develop a new model to predict sudden cardiac death related to ventricular arrhythmia with a risk calculator that is useful, I think, in order to better select the subgroup of patients who will benefit from early ICD implantation. Regarding the prognosis stratification, there is also another example I will show you regarding hypertrophic cardiomyopathy. There are several recent studies about the fact that the prognosis might be stratified by genetics. In fact, when you compare patients who carry a mutation in sarcomeric genes, the simple way to have a mutation in sarcomeric genes as compared to patients without mutations is associated with bad prognosis, with an increased risk of cardiovascular death, heart failure death, sudden cardiac death. And this was recently confirmed in a larger population of more than 2,700 HCM patients with the same message. A third reason for performing genetic testing is to improve the family screening, the family management. And this is indeed important because of the delayed cardiac expression of the disease in cardiomyopathies, late onset of the disease. This is illustrated here on the left for hypertrophic cardiomyopathy. You can see the progressive increase with age of penetrance, the percentage of mutation carriers who express hypertrophy. You can see that most express hypertrophy only in adults and sometimes very late at 50, 60 years of age. And on the right, you can see a similar figure for dilated cardiomyopathy related to Lemin mutation. Here, there is a progressive decrease of the cumulative probability to remain free of disease. So it's the opposite way to show that. So the first recommendation in relatives is to perform cardiac screening to detect the cardiomyopathy and to have a very early management, early therapeutics in relatives. So the recommendation is to perform a cardiac examination in all first-degree relatives at least at 10 years of age with ECG, echo, and to repeat the periodic cardiac screening, even if the first examination is normal because of this late expression of the disease, and to continue until 50 to 60 years of age. But when you perform genetic testing, when the mutation is identified in the family, you can propose predictive genetic testing to the relatives in order to better stratify the follow-up. Indeed, if the relative carry the mutation, also you should, of course, continue the cardiac follow-up. But if the relative do not carry the mutation, then you can discharge the relative. So about half of the relatives can be discharged through this use of genetic testing for the family screening. And this is also considered as a high level of recommendation through the recent US guidelines. There are also additional interests. Genetic testing can also be performed in additional situations, but particular situations, so relatively different. But for example, for procreation, some patients do not want to transmit the disease because of severity of the disease in the family. So some ask us for the possibility to perform prenatal diagnosis and then to discuss pregnancy termination if the mutation is present in the fetus. So this is discussed only on a case-by-case decision. And more recently, there is also another option that is pre-implantation diagnosis in order to perform in vitro fertilization and select the egg without the mutation and implant the egg without the mutation. And this leads, for example, to the birth of this baby, which is a son of a patient of mine that was born through this pre-implantation process. And finally, I would like to say that there is promising perspective regarding the therapeutics of the cardiomyopathies based on genetic testing. There are a lot of research programs underway with innovative therapeutics, either due to new small molecules based on new pharmacological targets, new knowledge on the pathophysiology. And probably one good example is the mavacamten drug, a new drug that is proposed in sarcomeric HCM. This is a myosin inhibitor that was last year shown to be efficient to reduce the symptom of the patients with obstruction. And there are also additional new therapeutics regarding gene manipulation, microRNA, gene editing, antisense oligonucleotide. And there are quite a lot of papers on the way. And for example, this one about dilated cardiomyopathy due to phospholamban mutation with preclinical studies, very interesting with antisense oligonucleotides. So probably in the near future, there will be very different therapeutics based on this gene manipulation. So as a conclusion, the key messages are that cardiomyopathies are frequently of genetic origin with various genes and mutations. Genetic testing is based nowadays on next generation sequencing with a comprehensive analysis of panels of genes. Genetic testing is part of clinical management, should be, I think, and it is recommended by international societies. And probably the two most important applications are diagnostic workup, etiology assessment, not to miss rare disease with particular management. And the second one is to improve the family screening in order to select the appropriate patient who need a follow-up and to discharge the other one. And genetic testing can be considered in additional situations according to a case-by-case decision. And finally, I would like to thank the colleagues from my center here, a multidisciplinary team for the management of this disease. Thank you very much for your attention.
Thank you very much, Professor Philippe Charron, to give a very comprehensive application of the genetic testing. So we move to the discussion part, and we have a few questions for the speaker. First of all, we have a question from the audience for Professor Olivier about the role of the CT. What kind of the CT you mentioned the last slide? Is there any different compared to the normal CT now?
In my practice, actually, I'm not using CT for the exploration of the myocardium. I think that the CT is really convenient for the exploration of the coronary, for the coronary arteries, I mean, and so it's really convenient to rule out coronary artery disease. But I think this is not a really good tool to explore the myocardium. There is only one exception, I think, and Philippe Charron knows well this exception because they are using it at the hospital of La Pitié-Salpêtrière to explore the arrhythmogenic cardiomyopathies and to explore the right ventricular dysplasia. Because we know that the CT is really convenient to make the difference between fat tissue and normal tissue. And I think this is probably the only one indication to explore the myocardium. But in my practice, I'm using MRI to explore the myocardium and not CT.
We agree with Olivier. We are more and more practicing CT, but for the specific issue of IRVC suspicion.
Yeah.
Fat characterization is very interesting.
Professor Philippe Charron, so when you're finding a very rare mutation, how do you can connect with the other kind of mutation and how to make it relevant for the testing?
I'm not sure how I have understand the meaning of the question.
Okay, so when you perform the sequencing, the home sequencing genome gen analysis, and then you find some very rare mutation, and how you make sure that it is got very close.
Okay, so very important question. In fact, it is very important to be sure about the causal link between the genetic variant indeed and the disease. So there are quite a lot of rules in order to be sure to characterize. We use the comparison with the frequency of the variant in the various databases in the normal and abnormal population. We use prediction softwares in order to predict the consequence of the genetic variant and so on. And another good also mean to progress is the analysis of the segregation in the family. So there are quite a lot of rules at the international level in order to classify the genetic variant either as a pathogenic variant or a variant of unknown signification or a variant which is a polymorphism. So it is very important to have a good expertise in the laboratory in order to make the appropriate classification before giving the result to the clinician.
Yeah, thank you very much for this answer. So the next question for Professor Olivier. How about the role of the scintigraphy? Is it any advantage or outrage in terms of cost and benefit compared to the cardiac MRI?
Yeah, that's a good question. And actually, I didn't talk about scintigraphy, but I think that's a really good tool to explore the perfusion. I think from my point of view, this is the best tool to explore the perfusion of the myocardium. There is a lot of studies showing that MRI is really good tool also, and I'm not saying that MRI is not a good tool, but I think that it's easier to use scintigraphy to explore the perfusion of the myocardium because it's really it's quite easy to interpret and to give to make the difference between a coronary artery disease and no ischemic abnormality. And this is not the same for the MRI. In my practice, I'm using scintigraphy for the exploration of the perfusion, and I'm using MRI for the exploration of the myocardium.
Yeah. Thank you. So we have one question for Professor Philippe Charron. How long? I see the question number 3 on the chat box. So how long the period of time to reclassify the mutation that was previously classified as unknown or uncertain significant in patient with hypertrophic cardiomyopathy?
When we are facing to a variant of unknown significance, so this means that we cannot be sure that this variant is pathogenic or not pathogenic. So this is a situation where we are facing to in a number of cases that is very increasing. So in this condition, to progress in the interpretation, there are two ways. One is to analyze the variant in the family, to compare the cardiac status and the genetic status in the family, to be sure there is a good segregation of the variant with the patients in the family, to help us to conclude. And the second way is to perform functional analysis in the laboratory, which is not so easy. It is more related to research, but it is progressing. For example, the analysis of mRNA can be useful for some of these genetic variations. So this may require some time in order to achieve this interpretation. So this is really an issue that is still open to progress in the interpretation of the variant of unknown significance.
Thank you. We have a question for Professor Olivier. What is the difference between the late gadolinium pattern on cardiac MRI in ischemia and non-ischemia focal cardiomyopathy?
That's a good question, and that's, I mean, the value of MRI because there is different pattern of late gadolinium enhancement. For ischemic cardiomyopathies, there is a subendocardial or transmural late gadolinium enhancement, because the coronary artery disease are going from the epicardial layers to the subendocardial layers, and the ischemic pattern starts to the subendocardial layer and is going to the transmural extension. And this is fully different if you consider cardiomyopathies, because most of the times the late gadolinium enhancement is inside the myocardium. It's a midway of the myocardium, or sometimes when there is inflammatory condition, it's a subepicardial. But most of the time, for example, in the hypertrophic cardiomyopathy, there is late gadolinium enhancement inside the myocardium and not at the subendocardial condition localization. That's make the difference between ischemic and non-ischemic cardiomyopathy. And I think that MRI is the only way to make the difference between both cardiomyopathies.
Yeah, thank you. We still got a few questions, and we try to catch up as much as we can. So for Professor Philippe Charron, so what do you think about the genetics cause for the Takotsubo cardiomyopathy or post-Perfume cardiomyopathy?
Interesting question. This field will remain open because there are not so many data about genetic causes for Takotsubo. We know that there are some familial cases, but not so many. We have some familial cases. So until now, there is no important data supporting a major role of genetics in Takotsubo. So there is no recommendation for performing systematic familial screening, for example, and something like that. And this is more related to research, and we have also some research underway on this topic. But for now, I would say we have no definitive data and conclusion about that. So it is still more considered as a multifactorial disease until now.
Thank you. And I think it is a very open area for every people to jump in and do more research. And although the time is a little bit over, but we have a last question for Professor Olivier. So we know that the cardiac MRI is the first line tool, but how about the echo? And if you can apply the AI into the echo, can be like a tool for screening for cardiomyopathy?
I think that the echo is the first line tool to explore the cardiomyopathies. And when I'm saying that MRI, it's really important. I think that we actually echo, it's probably more important than MRI, because now with the new tools of the echo, and you just said artificial intelligence, we have a lot of tools to assess the prognosis and the diagnosis of the patient. And I think that, for example, the strain imaging can make the difference between different etiologies and can assess the prognosis of the patient. So I think that we are all cardiologists, and echo is probably the first line and one of the best tools to assess the myocardium and cardiomyopathies.
Yeah, thank you. And Professor,
if I may just add a few words. For relatives, do not forget ECG. ECG can provide very early abnormality, sometimes before imaging. So ECG.
You're right. I'm talking about imaging, but the first step is probably the ECG and the clinical examination. You're right, Philippe.
Yeah. Thank you. And I think this is a great symposium for the cardiomyopathy. We hope that next year we can go further deeply in some specific type of the cardiomyopathy, and we really welcome both of you to come back and to join with us for the next year. Thank you very much again for the great presentation and discussion for this talk, and we hope that we can receive you in Hanoi or in French after the COVID is even better. So thank you very much again, and we look forward to see each other very soon. Bye-bye.
Thank you for the invitation.
Thank you very much. Bye.
Thank you. Bye.
Oh, très bien.
Recording in progress.
Hi, Professor.
Hi. Hi. Yeah, thank you. Very nice to meet you, Dr.
Hi.
Hui.
Yes, hi.
Yeah, very good. Thank you. So I think our session will be start something about 2 minutes.
Sure. You would like just wondering whether you will introduce the speakers, yeah?
Yes.
Okay,
I will introduce the first speaker, and then you, and then
Okay.
introduce you, and then sorry, because I will introduce also
good.
president and speaker, and also ask you to introduce the first speaker, and then I introduce you as a second speaker, right?
Okay. Yeah,
Okay.
up to you. I just want to verify that I know the sequence.
Okay, very good.
Okay. So I will introduce the first speaker. Is that correct?
Yes.
Tim mạch học
Great.
là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách. Nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Xin phép ban thư ký cho phép phiên hội nghị phép bắt đầu. Và xin phép ban thư ký cho tạm dừng cho hội nghị nó bắt đầu. All right, thank you. So, good afternoon, everybody. So, welcome to the session S35, update on evaluation and management of functional mitral regurgitation. I'm Dr. Phạm Mạnh Hùng from Vietnam National Heart Association. So today, we are very happy to have Associate Professor U.C. Hui, my co-chair from Singapore, and we also have some of our colleagues from France, Dr. Joan Lavie-Betty and Professor Erwan Donner and Professor Patrick Orman. So I would like to take the opportunity to thank all our colleagues in over the world to support us for this local meeting, but I think it's a very international meeting. So I would like to start with the first. I would like to ask my co-chair, Professor E.C. Hui, will introductions for the first speaker.
Thank you, Professor Pham. It is really a great pleasure to be here, and although we cannot meet in person, but the spirit is there, and certainly it was great to have these invitations and to chair these sessions. Without further ado, let me introduce the first speaker. He is Dr. Joan Lavie-Betty. He is from France, and he's going to give us a talk on tips and pitfall for quantifications of mitral regurgitation severity. using multi-imaging modality. Dr. Navi Badi is actually from France and he's currently practicing cardiology in Heart Valve Center, Ranguet University Hospital in Toulouse. Dr. Navi Badi, please.
Hello, thank you for attending this session dedicated to secondary mitral regurgitation. I'm Yohan Lavibadi from Toulouse-Ranguet University Hospital in France, and I'm going to talk about the tips and tricks for quantification of mitral regurgitation.
So. Okay, very good.
These are my conflicts of interest. So before dealing with the quantification of secondary mitral regurgitation, the first step is to know how to correctly identify patients. To sum up, there is three main phenotypes of secondary mitral regurgitation. The first one is ventricular functional mitral regurgitation. Here it is due to dilatation of the left ventricle in the context of dilated cardiomyopathy. And indeed, the ventricular dilatation will lead to a displacement of the papillary muscle and a tethering of the mitral valve. The second one is ischemic mitral regurgitation. Here, the valve is asymmetrically deformed due to ventricular remodeling secondary to necrotic scarring, as you can nicely see here. And the last one is atrial dilatation that's caused mitral annulus dilatation, which lead to atrial functional mitral regurgitation. So of course here it's caricatural, but you can nicely see that the annulus, the mitral annulus is dilated and lead to a severe mitral regurgitation. So, of course, in most of cases, transthoracic echocardiography is enough to identify the valve phenotype, but you can use transesophageal echocardiography if you want. It allows better resolution and analysis of the mechanism. And of course, it allows the realization of 3D images of high resolution, allowing a very, very precise analysis of the mechanism. So what about CMR? For CMR, from my point of view, it's mainly interesting in the case of ischemic mitral regurgitation by allowing the visualization of the necrotic scar. You can see here in white. Interestingly, the risk associated with ischemic mitral regurgitation is more comprehensively described as an interaction between the severity of the mitral regurgitation and the severity of the myocardial scar size. As you can see here in this study, this curve with a very poor outcome is patients with severe MR, severe ischemic MR, and a large necrotic scar. What about CT scan? Of course, CT brings a precision in the measurement, a very high spatial resolution, but from my point of view, it's only of interest to prepare a percutaneous intervention like TMVR. So, let's talk about quantification now. So when talking about quantification, the first pitfall is the loading conditions. Here you have the same patient before and after a diuretic treatment, and you can see a clear decrease of the regurgitation. So if you can, you have to wait before assessing mitral regurgitation, and the assessment should be undertaken in stable clinical condition with controlled blood pressure and optimal medical therapy. So if you have a patient hospitalized for acute heart failure, you have to wait to have a definite assessment of the severity of the mitral regurgitation, ideally as an outpatient. The second pitfall is about the indirect severity criteria of mitral regurgitation. As you know about the guidelines, the evaluation of mitral regurgitation severity ideally integrates multi-parameters because all methods have intrinsic limitation. So you have to answer the first question in every time. So does MR meet specific criteria for mild or severe MR? In fact, in a secondary MR, those criteria are often abnormal due to the underlying cardiomyopathy. For example, if we take a pulmonary vein systolic flow reversal, in most patients with cardiomyopathy, they have a systolic blunting of the pulmonary venous flow pattern due to elevated LA pressure. And in another way, because of elevated LA pressure, dilated and compliant LA and depressed LV systolic function, a systolic flow reversal is not commonly seen in secondary mitral regurgitation. So be careful. Another major pitfall is the use of the PISA method in secondary mitral regurgitation. It's a very common problem. Why? Because in fact, in secondary mitral regurgitation, the regurgitant orifice is often crescent-shaped. And in such cases, the assumption of circular orifice geometry inherent to 2D PISA may result in underestimation of secondary MR. So, how we can deal with it? One solution is you can solve it by direct measurement of the vena contracta area with 3D echo. So you do multiplanar reconstruction, you orient orthogonal plane through the long axis of the jet, and the last plane is a perpendicular, and you can measure by a manual planimetry the area of vena contracta. As we've seen, accurate estimation of effective regurgitant orifice area is potentially a source of error. Okay, but the situation becomes even more complicated when we try to define a severity threshold. Why? Because in heart failure patients, even mitral regurgitation with an effective regurgitant orifice area of more than 20 square millimeter is associated with a poor prognosis, as you can see here. So, from a purely prognostic point of view, a threshold of 20 square millimeter can be used to define severity. So, caution is required. Why? Because for a therapeutic point of view, surgical data show no survival benefits of valve repair on top of revascularization in patients with a cutoff for inclusion of 20 square millimeter. As you can see here, no benefits to mitral valve repair in secondary mitral regurgitation with this cutoff of 20. Moreover, in the MITRA-FR study, was used a cutoff of 20 square millimeter as a trigger to treat secondary mitral regurgitation by MitraClip therapy, and shown no significant reduction in heart failure rehospitalization on top of medical treatment. On the contrary, the COAPT trial used a cutoff of 30 square millimeter and show a significant reduction in death from any cause. So, In the last European guidelines, they recommend that the echocardiographic criteria to define severe secondary mitral regurgitation do not differ from those used in primary mitral regurgitation. However, it acknowledges that lower threshold may be applied to define severe SMR. So from my point of view, an effective regurgitant orifice of 30 square millimeter or more per 2-day proximal ISO per 2-day PISA likely correspond to severe SMR. An interesting thing is to understand that in heart failure patients, the total forward left ventricular stroke volume is lower. So a small regurgitant volume can still have a significant impact. In this way, the calculation of the regurgitant fraction could be of interest. The regurgitant fraction is a hybrid parameter that calculates as the ratio of the regurgitant volume to total stroke volume. This parameter is of specific interest because it includes information not only on the severity of the regurgitant load, but also on its relation to cardiac size and function. Indeed, in echocardiography, the estimation of the regurgitant fraction is known to be not very reproducible. So in this purpose, CMR can be a very valuable tool. Indeed, this method allows an automatic calculation of the regurgitant fraction, which is robust and very reproducible. So, what are the messages? The messages you have to take on is beware of the loading condition on MR severity. Always prefer to assess the mitral regurgitation severity in an outpatient under optimal medical therapy. So beware of PISA method and prefer, if you can, if you have 3D, the 3D vena contracta area measurements. If you have to keep in mind a threshold, I think 30 square millimeter can be used as a cutoff and mainly to lead to transcatheter therapy like MitraClip. And don't forget the regurgitation fraction with very interesting parameter in this patient because it integrates all the parameters. And thank you for your attention.
Thank you so much, Dr. Ruan Labib Badi, for the very interesting presentation. So next speaker, I would like to invite Associate Professor Yu Si Hui. Associate Professor Yu Si Hui from National Heart Center, Singapore. She's now the Senior Consultant, Department of Cardiology, National Heart Center, and the Director of Echocardiography, National Heart Center, Singapore. Dr. Hui, please.
Thank you very much, Professor Fan, for the kind introductions and the kind invitations for this Congress. This will be my talk. It's my pleasure to be here. For the purpose of this talk, I do have conflicts of interest. I also would like to say that my specialty is that of imaging. I'm not a heart failure specialist, but I will do my best to give this talk. This will be the outline of my talk, basically discussing the mechanism of FMR as well as clinical implications of FMR, to propose the conceptual framework of proportionality of MR in patients with LV dysfunctions, and then how do we go about managing such patients. I think it has been spoken to by previous speaker that mitral valve apparatus is very complex and very dynamic. It does house the two leaflets, mitral annulus, chordae, pec muscles, as well as supporting structure, that's the LV. And it really requires a perfect coordination to prevent mitral regurgitation during systole, that you need to have an overlap of both mitral leaflets very well. In patients with functional mitral regurgitations, it is primarily caused by the left ventricular remodeling, either global or regional remodeling. And sometimes, obviously, you do not have mitral valve that is degenerating in terms of regurgitation from flail, but over time, the mitral leaflet do adapt in terms of change in size as well as fibrosis, including annular dilatations. The typical reasons for functional MR is that of leaflet tethering, and this has been alluded to by previous speaker, and I shan't spend too much time on it. But there are really two tethering patterns that is typically seen in patients with functional mitral regurgitation, that of an asymmetrical tethering due to posterior leaflet restrictions, and that is typically seen in patients with regional heart problems, such as that of posterior MI. And in these cases, you tend to really have patients with eccentric MR and posteriorly directed kind of MR. And sometimes you do miss this and thinking that this is an anterior prolapse. So do pay attention to the leaflet morphology. The more commonly seen is that of chronic LV dilatations, and that causes a symmetrical tethering of the leaflets with apical displacements of the pec muscles, and as well as the coarctation. And it does give rise to central mitral regurgitations that's quite hard to miss on transthoracic echoes. As has been alluded to, sometimes we do see functional mitral regurgitation in the presence of concomitant annular dilatations. I think the next speaker, Professor Donald, will speak more about it later. The pathophysiology of functional MR is really very complex. There is a variety or degree of myocardial remodeling and dilatation, because there's also a degree of leaflet tethering that is not so categorical, either localized or global. And MR, as alluded to by the previous speaker, is dynamic. So we do have to take into considerations all these measurements when we assess patients. And the reason why MR occurs is really an interplay between the reduced or reductions in closing forces and the increase in tethering forces. And this interplay and relationship will determine whether the MR is going to be predominant or not. A degree of mitral valve tethering has been described previously, and we understood this better because of the surgical literature. These are the poor prognostic indicator of MR persistence after surgery. And the dynamic nature of FMR has been alluded again by the previous speaker, and I do like to actually highlight the importance of only using TE to assess MR mechanism, to understand why MR occurs, and not to assess the severity of MR during TE because of the change in loading conditions. Sometimes medical therapy does change a lot in terms of the acute decompensations of heart failure with MR. After optimizations, then you assess the mitral regurgitation on transthoracic echoes. Patients who have discordant in terms of symptoms with regards to the left ventricular systolic functions, or they have symptoms when they exercise, is good to perform exercise echo to elucidate the symptoms and prognosis of such patients. Now, why do we spend so much time on functional MR? It's because in patients that has post-MI, for example, the presence of mitral regurgitations has got a poor prognosis, even if you have corrected for the baseline characteristic of age, EF, and functional status. And also, the Mayo Clinic data has shown us that if you have an EROA of more than 20, this has got worse outcome compared to those with EROA that is less than 20 for mild mitral regurgitations. Both for ischemic and non-ischemic CMP, severe MR, if it's present, has a poor prognosis sign, and they have increasing mortality. More importantly, with the latest data from the mitral FR and PROACT trial, we can see that when the patients have severe, moderate severe functional MR, 2-year survival of these patients is only about 30%. To some of them even 40%. So about 1/3 of patients will die after they have been diagnosed with severe MR despite medical therapy. So the intent, of course, is to reduce mitral regurgitations using some sort of medical therapy or interventions to reduce the remodeling and perhaps interrupt this vicious cycle of functional mitral regurgitations. As has been alluded to, medicines work. However, the surgical mitral valve reduction therapy doesn't work very well, and not so, it's quite disappointing. And of course, you probably heard very much about the MITRA-FR as well as the GOAP trial. That's two randomized studies that randomized patients with functional mitral regurgitation and impaired EF to either a medical therapy or transcatheter edge-to-edge repair, which is not an open heart surgery, but a percutaneous way of reducing the MR. However, they are discordant in terms of the outcomes. In MITRA-FR, there is no difference in primary outcome of heart failure and death in 1 year after medical therapy or device therapy. However, in GOAP trial that randomized to about 2 times the number of patients in the MITRA-FR actually shows a reduction in primary endpoint of heart failure hospitalization. In fact, the number to treat to prevent 1 hospitalizations over 2 years is 3. And then when you have the mortality data, the number to prevent heart death in patients with heart failure with reduced EF and functional MR is at least 6. So there must be some reasons why GOAP as well as MITRA-FR are so different. And of course, it has been alluded to that the MITRA-FR recruit patients who are only mild in the latest guidelines, EROA are more than 20. Whereas in GOAP trial, we actually include patients of at least EROA of more than 30 millimeters squared. And what is important is not only the severity of MR is more severe in GOAP, but the degree of LV dilatation is less in GOAP, i.e. the GOAP actually recruit patients with mean LV size that's smaller, but more degree of MR. And also in GOAP, we actually have an echo collab to adjudicate the severity of MR before randomization into medical therapy versus device therapy on MitraClip. What is more important is that in GOAP study, all patients has to be maximally tolerated on GDMP. They have to be optimally medically treated by a heart failure specialist before they are randomized. So this tells us the rigorous of the GOAP study in terms of heart failure optimizations. Obviously, there were some slight differences in the acute technical results of the GOAP, which is a bit better. I would like to allude you to the importance of what GOAP do. Here, they actually only include patients who have an EF that is more than 20 and an upper limit of 70 millimeter on left ventricular and systolic diameter. This is set in the GOAP criteria such that they exclude subjects whose LV dysfunction is so advanced that their symptoms or prognosis will be dominated by LV dysfunctions and not MR. So correcting the MR do not or may not have good outcomes or change their prognosis of the patients. Hence, it tells us that for functional MR is actually a very heterogeneous group. It's very hard for us to predict and how to reconcile these two trial data. There was so much of variability in terms of degree of remotely as well as the severity of MR. Herein, where Graben actually proposed the proportionality of MR in patients with LV dysfunctions. He basically used the Gaudian formula and do a mathematical relations of EROA with regards to the left ventricular functions and LV volumes. And if, in other words, what he's trying to say is when we interpret MR in functional mitral regurgitations in terms of the severity, EROA, or regurgitation fractions, or regurgitation volume, we have to interpret this in the presence of the LV size and the LV function. And this is pretty much analogous to the aortic valve area in aortic stenosis. When we say calculated aortic valve area, we do this in relation to LV function, EF, as well as stroke volume. So similarly, in patients with functional MR, we would like to analyze the MR severity depending on the LV diastolic volume. For example, if you have a patient with EF of 30 and assuming that regurgitation fractions is pretty as severe, in a patient with normal LV size, we would expect the EROA to be 20 or 0.2 centimeters squared to be severe mitral regurgitation. When the LV dilates to that of normal heart failure patients, it has to be probably a EROA of more than 0.3 to be considered as severe mitral regurgitation. When there is extensive LV dilatation, this threshold for severe MR will be even higher. And this relationship not only depends on LV volumes, but also depends on the pressure gradients between the LV and LA during systole. For example, in a patient with poor LV function and low heart blood pressure, usually the MR severity velocity is not high, it's probably around 4. In such patients, the threshold of severe MR is probably going to be higher than the usual 0.3 or 0.4 centimeters square. So this concept is helpful to understand the two types of patient population that is recruited in COAPT as well as mitral FR. And the concept of proportionality is really to determine who are the patients who are more severe because of, or patients who are symptomatic, or patients who are worse in prognosis. Is it because of MR that is driving it, or is it an LV that is driving it? For example, in those with patients in mitral FR, you have a mean LV volume that's large and ERA that's small. And this probably belongs to the proportional MR group in terms of the LV dilatations. Whereas for severe, for COAPT patients, you do have a small LV functions, LV volumes, and you have ERA that is larger, and this is disproportionate to the degree of LV dilatation, and it belongs to disproportionate MR. And perhaps the MR dominants are the ones that we need to be paying attention to, and reducing MR will probably help these patients. Of note, EROA of 0.2 seems to be in the lower threshold for anyone with LV dilatation. So it means that if we use this cutoff as a severe MR in functional MR, we are probably underestimating the level of mitral regurgitations. So in such patients, we probably need to take into considerations the guidelines cutoff, and it's good that the guidelines has now changed to 0.4 centimeters square as severe MR, because it actually takes into considerations that if LV is dilated, you need more than 0.2 to be severe in terms of significant in hemodynamics in the LV. So this slide really summarizes what I've said earlier. When we treat or manage patients with heart failure, with reduced EF and functional MR, we want to actually categorize in our head whether this is more of LV dominant versus MR dominant. For LV dominants are the ones where the degree of MR is expected to be related to the degree of LV dilatation. And in this case, the treatment really is to aggressively treat neurohormonal antagonists, such as that of anti-heart failure therapy. And the whole purpose is to reduce LV dilatation and cause reverse remodeling, reduce the tethering, and improve the MR. Whereas in patients who have disproportionate MR to the degree of LV dilatation, meaning the MR is very severe despite the fact that LV is not too dilated, and this typically found in those with asymmetric tethering of the mitral valve that I spoke on in the first two slides. And the way to treat this is really, despite medical therapy, and patient is still symptomatic and residual MR is a lot, you may want to intervene on the mitral regurgitations, and this will help improve in terms of prognosis of the patient. And this is really summarized in this slide, where depending on whether this is LV dominant, patient should be focused very much on the neurohormonal therapy, such as the anti-heart failure medicine. And in patients with MR dominant, despite medical therapy, we probably need to intervene on the mitral leaflet such that it will actually oppose and reduce mitral regurgitations. However, I must say that the current concept is only a conceptual framework. These measurements are really measured based on the Gaussian formulas of the EROA, LV dimensions, or LVEF. And this is not the commonly used parameters that we see in our clinical practice. We use echo. Although I'm an echocardiologist, there are limitations based on the echo-derived parameters. So this concept is nice, but the specific values should not be applied on individual patients. Here is good time that I probably need to stress on the importance of heart failure therapy. This is really the mortality benefit of all classes of heart failure therapy, including the SGLT2. In fact, if we have exhausted all this medical therapy, the MitraClip can be applied in these patients, in select patients. I would also want to draw to the attention that most of the trials that we have today, that of mitral FR as well as COAPT, do not include patients with ARNI, or very few of them were on ARNI, and SGLT were not commonly used. So this is the latest analysis that look at the comparing between conventional therapy using ACE and ARB and beta blocker, and the latest, which is the 4 pillars of anti-heart failure therapy. And you realize that patients will gain an extra 8 years just taking these 4 pillars of medicines diligently. So this highlights the importance of heart failure therapy. Since when we have patients with symptomatic severe mitral regurgitations, there is no single parameters that is helpful. It is then important for us to optimize medical therapy very aggressively. In our center, we usually refer all these patients to a heart failure specialist, and they will be very aggressive in reducing, optimizing the medicine, usually within 1 to 3 months. And then we repeat the echo parameters and repeat and transtrust the echo to properly assess the MR severity. Here, we have to pay attention to the MR EROA as well as the regurgitation fraction as used by the COAPT protocol. And also, apart from measuring the MR severity, it's important for us to look at LV size as well as LV functions. The patient is symptomatic despite all these measurements, and the patients do satisfy the criteria of COAPT. We then will actually refer to our heart team and to assess whether there's visibility of MitraClip. Of course, we do have to consider whether the patient is too advanced into heart failure dysfunctions that MitraClip may not help. Then we have to refer them to either heart transplant or LVAD therapy. So in conclusion, ladies and gentlemen, the concept of MR proportionality in patients with heart failure, it is a nice conceptual framework. It allows us to identify which sort of patients are more predominant LV or MR causing the heart failure decompensations. However, it cannot be applied to individual patients because of the limitation and variability in the current method of assessment using imaging. And also, I would like to highlight that there is individual variability into the response. Even in COAPT study, those on medical therapy, apparently about 10% of them do improve despite no receiving clip therapy. And the last thing about this concept is that we assume that there's a linear relationship between EROA to LV and diastolic volume or volumes. It may not be true in patients with very advanced LV dilatations. I would like to conclude by saying that it's important for us as a community to emphasize that all these patients should be on guideline-directed medical therapy because the benefit is huge. And with the 4 pillars, which is SGLT2 inhibitors, and this should be started early as well. And then after optimizing medical therapy, we will then apply the COAPT protocol in measurement of such patients if they are still symptomatic. And with that, I thank you for your attention.
Thank you so much, Professor Yêu Hui, for very interesting presentation. So now we have some minutes between 2 parts of our session to have some question. And as here I can see in my chat box a question for you. I think for all of the previous speakers, the question one is. What are superiority of 3D echocardiography in comparison with the 2D TE in MR regurgitation evaluations? So, Dr. Hui, please, can you answer this question? Yeah.
I think you are directed to me or the first speaker, but I can take the questions. No issues.
Okay, because I think the Dr. Juan Nabibadi is here.
Yeah, I'm not sure whether he's here.
Okay, maybe Dr. Juan may be busy another session. So, please, can you have some comment about this question?
Sure. Well, when COAPT comes out and the difference in mitral funds, we always question whether is it because the echo modality is the reason why this concept doesn't work. And the truth is that, you know, there are many reasons to account for this. And as a practicing clinical echocardiologist, we actually look at 3D very much because 3D allows us to assess the LV volumes much more accurate than a 2-dimensional echoes. And 2-dimensional echoes has a lot of foreshortening, and with LV that is so huge, most of the time you don't get a good image. And I find that not only 3D is important for quantifications of volumes, but I think with contrast is probably something that can be helpful too if you really have poor image. If you have poor image, it doesn't matter. 3D is going to give you a poor image either or. So we do very much use contrast because contrast echo allows you to visualize the left ventricle volumes very much better. Now, when it comes to MR quantifications, I do 3D mainly to understand the limitations of 2D PISA, because 2D PISA usually will underestimate the MR severity. We would always say that, PISA do not accurately assess because it doesn't account for the non-circular shape of the orifice, so it's always underestimated. So we do that for 3D. Especially when you do TE, because TE, the MR severity is usually underestimated because we give sedations. So we look at the coaptations, we look at the 3D vena contracta area, especially on TE, where the image is so much better. I would like to conclude that in these patients, not only is the measurements important, the measurement is important because you are looking out for it. I think if you have optimized medical therapy, you should bring the patient back for a transthoracic assessment, because when the patient is well, then the transthoracic assessment is much more accurate assessments of the MR severity, because that's when you can do a bit better. And also with ProBMT, I don't know whether you use it very routinely. We do ProBMT very much in our clinic as well. So if the ProBMT is elevated and you know the patient is congested, they actually up-titrate the medicines very aggressively in my center. So after we have optimized that, then we do a transthoracic assessment, because we know that a loading condition changes a lot. Maybe I talk too much, but anyway.
Thank you so much. It's wonderful. So the second question is, how about the role of the CRT in the functional MR management?
Okay.
How do you do it in your center?
Yeah, I will take on this as well. Now, CRT is very clearly explained in our guidelines, which are the ones who should consider CRT. In fact, CRT should be part of the on top of the 4 pillars of heart failure therapy. So, but not everyone satisfy the criteria of CRT. So we would actually definitely do CRT first before MitraClip. You probably know MitraClip is very expensive. In fact, a lot of time we are debating, should we do it or should we not do it for a patient with poor LV function? When the patient is so poor, the mortality is so bad, 40% is going to die. Can we or should we, in terms of health economics, do these patients? So I think there's always a debate, but definitely CRT before MitraClip.
Thank you so much. So I think the last question in this session. So besides the echocardiography, how do you think the role of the another imaging modalities such as MRI or MSCT in detect of the severity of the MR for functional MR?
I didn't get the question. I think the question is there any other modalities on top of echo to assess this patient?
Yes. For success, CT and MRI.
Okay. Well, I think this is a very excellent question. Actually, in my mind, it's not just the volumes and the MR severity that's important. I think what is important is how much of the scar of the LV we are dealing with. And unfortunately, scar on echo is really not a good way to for measuring them. So we would actually, if you are conflicted in terms of offering a MitraClip therapy, which is very expensive, sometimes I think we should also look at the CMR, looking at the extent of the scarring. The scarring will probably predict the poor prognosis of patients that you may want to be less aggressive in terms of expensive therapy. These are my thoughts. As for CT helps very much when you want to do other kinds of more novel mitral valve therapy, such as mitral replacement. But TMVR is not something that we have in this part of the world. So I don't think CT will be the way I use in functional MR assessment. I will only use it if I need to assess the coronary status. For example, if these patients have, LA that is LAD that's infarcted, and you're not sure whether there is CTO, whether there is small diffuse that those surgeon wants to go in, and that's probably when you do a CT to assess whether the vessel size is worthwhile going to do a Lima LAD.
Okay, thank you, Dr. Hui. So I think we come to the next speaker. I would like to invite Professor Erwan Donald. Professor Erwan Donald is come from the hospital Pontchartrain of Rennes from France. So Dr. Erwan Donald will present the topic about atrial functional mitral regurgitation.
Dear colleagues, dear friends, it's a real pleasure and I should say an honor for being invited to discuss about mitral regurgitation during your Congress. I'm Erwan Donal from Rennes in France, and I have to discuss about atrial mitral regurgitation, and I will try to integrate this entity with the others in the purpose of deciding how to treat this mitral regurgitation. Should we send the patient to surgery? Should we use clips? Or should we treat the patient with medical treatments only? So first of all, I think it's quite important to keep in mind that the mitral valve apparatus depends on the intricate and balanced function of all individual components. I mean, the mitral annulus, which is quite important, the leaflets, of course, the chordae tendineae, the papillary muscles, the LV wall, and this is quite important also to never forget about the left atrium size and geometry. So when you have a patient with a mitral regurg, a secondary mitral regurg most of the time, you have to look very carefully at all these components that might impact on the degree of the mitral regurgitation. So it's quite important to have in mind that there are different kinds of secondary mitral regurgitation. Of course, we started with the ischemic cardiomyopathy with the scar tissue related to a myocardial infarction, and this scar tissue was associated with a tethering, an asymmetric tethering of the mitral valve leaflets. And this is the first entity that we call secondary mitral regurgitation or functional mitral regurgitation. But it is not the only one. We also have the non-ischemic dilated cardiomyopathy with a symmetric tethering of both the posterior and the anterior leaflets. And this is quite important to have in mind too. And we have also to consider the fact that sometimes the secondary mitral regurgitation is related not to the LV enlargement, but to the LA enlargement. And this LA enlargement is associated with an annulus enlargement, with a flattering of the annulus of the mitral valve. And this flattering of the mitral valve annulus is most of the time not associated with any tethering, as it could be the case for the dilated and the ischemic cardiomyopathy. So look at the LA, look at the LV, look at the papillary muscle, the chordae, the annulus, and the leaflets. If we discuss about the atrial secondary mitral regurgitation as compared to the LV-related ones, dilated or ischemic, then you see that the degree of the annulus enlargement is quite the same, but without any tethering of the leaflet, because most of the time when you have an atrial mitral regurgitation, the LV size is about to be normal and the LV function is not that abnormal. But the LA is enlarged, the mitral annulus is flattered, and the size is increased. And the coaptation area is decreased too, as much as it is the case in secondary mitral regurgitation related to the left ventricle. In that slide, you have the two different entities that are called LV secondary mitral regurgitation. You have the symmetric tethering related to a non-ischemic cardiomyopathy, and you have the asymmetric tethering related to the ischemic cardiomyopathy. And I should say, I'm sorry, that when you consider the mitral regurg, this is a balance between the tethering forces, the closing forces, the desynchrony of the LV walls, and the degree of the dilatation of this LV as well as this LA. So you have to consider the size of the cavities, the synchrony of contraction of all these cavities, and of course, the loading conditions are very important because they will impact on the closing forces and the tethering forces. So don't forget the loading conditions. So the failing LV disturbs the balance by increasing the tethering forces and reducing the closing forces when you have a secondary mitral rigor related to the left ventricle. But when you have a LV related secondary mitral regurgitation, you have this tethering, you have this decrease in closing forces, but you have some degree of increase in size of the leaflets of the mitral valve over time. So the size of the leaflet might increase over time when you have some degree of tethering. But of course, when you have a LV dysfunction, it impacts also the balance between tethering and closing forces by increasing the loading condition. And this increase in LA pressure will, of course, impact the degree of the mitral rigor and the degree of abnormality of the mitral annulus. We have this abnormality when we have a patient with a systolic heart failure. But as you can imagine, we also have this abnormality when we have a patient with heart failure with preserved ejection fraction and a chronic atrial arrhythmia. So my message is quite important. We have to check and recheck and check again all the patients with symptoms and severe secondary mitral regurgitation. We have to understand the anatomy, the function of the LA and the LV, and we have to make sure that we understand about the loading conditions. So we can use the TTE, we can use the TEE, and sometimes, or I should say most of the time, we have to do also a right heart catheterization to make sure that we understand perfectly the hemodynamic condition that is related with the symptoms and with the severe mitral regurgitation. And it is quite important to keep in mind that if we have a secondary mitral regurgitation related to the left ventricle or related to the left atrium, this mitral regurgitation can change over time. And the fact that it can decrease over time is associated with a much better prognosis that if you have an increase in degree of mitral regurgitation despite the medical treatment. So you have a patient with symptoms. You see that this patient has a mitral regurg, a secondary mitral regurg. You increase the medical treatment and then you check again the patient. If you have a decrease in mitral regurg, you are confident that the medical treatment is good enough. If you have a stabilized mitral regurgitation or an increase in mitral regurgitation despite the medical treatment, then you have to consider another treatment, clips or maybe surgery. And of course, if you have a mitral regurg that you find severe over the time, then the prognosis of the patient, it's something that you have to take into account because it is not a good prognosis in ischemic as well as in dilated cardiomyopathy, but also as well as in heart failure with preserved ejection fraction, with arrhythmia and LA enlargement. So really, it's important to understand about the mechanism of the mitral regurg, and for that you use the TTE, but most of the time you have also to look at the TEE and the 3D capabilities of your TEE. You try to focus on the mitral valve, but not only the leaflets, the apparatus with the chordae, the papillary muscle, the annulus, the LV, the LA. And if you don't understand if the mitral regurg is the cause of the symptoms, if you are not confident about the relationship between symptoms and the degree of the mitral regurg, because you have also the diastolic dysfunction or the systolic dysfunction, then you have to check for the relationship between symptoms and the mitral regurg by an exercise stress echocardiography. And of course, you have to assess quite precisely the degree of LA and LV remodeling. And for that purpose, the 3D capabilities of your echo machine is the most. So if you compare a patient with a LA mitral regurg with a patient with a LV related mitral regurg, you see that in the atrial related functional mitral regurg, you have a dilatation of the mitral annulus and a flattering of the mitral annulus that is somewhere the same as the one that you have when you have a LV related mitral regurg. But when you have a LV secondary mitral regurg, you have a tethering, you have a tenting, you have something that is wrong with the leaflets, which is not the case when you have an atrial related secondary mitral regurgitation. So you have to check for the TTE, the TEE, and you can quantify all these things using the 3D tools that are available on your echo machine. You see for this example, the degree of tethering that is related to the LV and not to the LA abnormality. And which is important, I told you about this before, but when you have a LV-related mitral regurgitation, most of the time you have a leaflet remodeling related to the LV abnormality, and you have an increase in size and thickness of the leaflets over time. And you don't have this change in size and thickness of the leaflets when you have an atrial-related secondary mitral regurgitation. So the tethering is not existing when you have an atrial-related functional mitral regurg, but the defect in coaptation might be the same as the LV-related one because the size of the leaflets is higher or greater when you have an LV-related mitral regurg than when you have an LA-related mitral regurg. So really, when you have a patient, you have to think about symptoms, you have to think about the medical treatment, and you have to integrate all the echo parameters with the clinical status of the patients. And you have to consider not only the leaflets, but all the mitral valve apparatus, and it should integrate the LV as well as the LA. And then you have an integrative interpretation of the degree of mitral regurgitation and the severity of the mitral regurgitation. And you will check that over time, not only one time, but you have to check time to time when you increase the medical treatment to check if the medical treatment has an impact of the degree of the mitral regurg. And it is important to check for the severity of the mitral regurgitation. And nowadays we know that we have to consider that the secondary mitral regurgitation is severe if the regurgitant fraction is greater than 50%. We can discuss about vena contracta, we can discuss about regurgitant orifice area, but the most important parameter is the regurgitant fraction greater than 50%. And if you have this regurgitant fraction greater than 50%, then you have an increase in the risk of symptoms, hospitalization, and death. And then you have to consider something else than the medical treatment. And nowadays, we think about clips. And you see that if the LV function is not too decreased, if the LV is not too enlarged, if the pulmonary pressure are not too high, if the RV function is okay, if the tricuspid regurg is not too severe, if the patient is stable with medical treatment, then if you have a regurgitant fraction greater than 50%, then the treatment by clip might be associated with an improvement in symptoms risk of hospitalization, and risk of death. So it's quite important to consider the assessment, the precise assessment of the size and the function of the left ventricle, as well as the size and the function sometimes of the left atrium. And if you have a not too weak LV function, a too enlarged left ventricle, then the patient with a regurgitant fraction greater than 50% might take advantage of the clip. If the patient is too sick, if the LV function is too severe, with a regurgitant fraction lower than 50%, then the patient shouldn't be treated with clip, but only with medical treatment. And sometimes you have a patient with a very severe enlargement of the left ventricle, a severe decrease in LV systolic function, but also a very severe mitral regurg, and these patients might take advantage of the mitral clip. So it's complicated sometimes. And the fact is that if you check the patient time after time, then you will best understand the fact that the symptoms are related to the mitral regurg or not. And then you will be more confident in the fact that you have to implant clips or not. And if you look at COAPT that you know, of course, the best results are obtained when the LV function is not too decreased and when the mitral regurg is very severe, of course. So the regurgitant fraction greater than 50% is very important. And the fact that the LV function is not too decreased, it's something that is quite important too. So secondary mitral regurg is a complex entity related to ischemic cardiomyopathy, related to dilated cardiomyopathy, but also related to heart failure with preserved ejection fraction and chronic permanent atrial arrhythmias. It's not a black and white issue. We have to check the patient several times, and we have to understand better the mechanisms of the regurg and the mechanisms of the symptoms. And if we understand that quite well, then we can decide for the medical treatment versus the clips. And if we decide for the clips, the patient should then take advantage of these clips if the LV function is not too decreased, if the LA is not too enlarged, as well as the LV. And of course, we shouldn't forget about the right ventricle. Thank you for your kind attention.
Thank you very much, Professor Evan Donu. I thought that was really comprehensive, that he touches really everything about what you need to know about functional mitral regurgitations. Well, I think we come to our last speaker. It is my great pleasure to invite Professor Patrick Altman, who will give us the last talk on should we treat all severe functional mitral regurgitations by transcatheter edge-to-edge repair. And Professor Altman is from the University Hospital of Strasbourg in France. Professor Altman, please.
Hello everyone, my name is Patrick Altman and I'm working as an interventional cardiologist at the University Hospital of Strasbourg, France. The title of my talk today is Should we treat all severe functional MR by transcatheter edge-to-edge repair, TEER? These are my conflict of interest. I have no conflict of interest according to this presentation. We are talking about a very frequent disease. Mitral regurgitation is the most frequent valve disease in the world. The prevalence of moderate to severe MR is similar in men and women and is increasing with age. These are data coming from the Mayo Clinic group in Rochester. MR was functional in 65%, organic in 32%, and mixed in 2% of cases. Mitral valve surgery was performed in 37% of patients with organic MR and 3 to 4% of patients with functional MR, underlining that FMR is undertreated. The prognosis of FMR was severe with 50% mortality rate at 5 years. The mechanism of FMR is related to a disease of the left ventricle which occurs despite normal mitral leaflets. Left ventricular remodeling and dysfunction lead to an apical and posterior displacement of the papillary muscle causing mitral leaflet tethering and reduced closing forces of the valve. Mitral annulus enlarge, resulting in a default of leaflets coaptation. FMR occurs on ischemic and non-ischemic cardiomyopathy. These are the last ESC guidelines for FMR treatment. The main treatment of FMR is the treatment of heart failure with optimal medical treatment associating ACE or ARB inhibitors, beta blockers, SGLT2 inhibitors, and when indicated, cardiac resynchronization. And if needed, the treatment of CAD or other cardiac disease like aortic stenosis by TAVI, for example. If the patient remains symptomatic and still presents an important MR, mitral valve surgery should be considered, especially in case of indication of other cardiac surgery like CABG. TEER should be considered in selected patients after exclusion of heart transplantation or LVAD. In patients with CAD or other cardiac disease, mitral valve surgery is recommended in patients undergoing CABG with a class 1 level B indication. TEER is recommended after appropriate PCI and TAVI procedure in case of persistent severe FMR. In patients without other cardiac disease requiring treatment, TER should be considered in patients fulfilling criteria suggesting an increased chance of responding to the treatment, the COAPT criteria, with a level of indication 2A. Isolated mitral valve surgery has a 2BC level of indication in FMR, and TEER may be considered level 2B in selected patients not fulfilling all the COAPT criteria. What are the evidences we have so far for the treatment of FMR with TEER? These are the data from several MitraClip registries showing a 30-day mortality of less than 5%, showing the safety of TEER procedure, and it shows also that FMR represents 70% of mitral regurgitation in MitraClip registry. In this meta-analysis, the predictors of adverse outcome after MitraClip were procedure failure, NIA class 4, very elevated NT-proBNP, TR more than 2, GFR less than 30 milliliter per minute, and ischemic etiology. All of you have heard about the opposite results of the two controlled randomized study of MitraClip versus optimal medical therapy in patients with FMR. MITRA-FR study showed on one side no difference in death or heart failure in patients randomized to optimized medical therapy versus optimized medical therapy plus MitraClip. COAPT study showed on the other side striking beneficial of adding MitraClip to optimal medical therapy in terms of free hospitalization for heart failure and in terms of all-cause deaths. Those two studies have been analyzed side by side to try to understand the differences in the results. It showed that lower LVEF and larger left ventricle were allowed in MITRA-FR. Less severe MR were allowed in MITRA-FR with an ERA of 20 versus 30 square millimeters in COAPT. The same with the regurgitation volume, 30 versus 45 milliliter. This difference was due to the differences between the ESC and the American guidelines in 2018 for the definition of severe FMR. No exclusion in MITRA-FR of patients with systolic pulmonary artery pressure of more than 70 mm mercury or severe right ventricle dysfunction. In addition, the follow-up in MITRA-FR was shorter, 12 versus 24 months for the primary endpoint. MITRA-FR patient presented smaller MR with an ERA of 31 versus 40 square millimeter. The percentage of patients with an ERA above 40 was only 16% in MITRA-FR versus 41% in COAPT. MITRA-FR patient had larger left ventricle with a volume of left ventricle of 135 versus 101 per square millimeter. MITRA-FR patient had higher systolic pulmonary pressure, 54 versus 44 millimeter mercury, and MITRA-FR patients were more frequently hospitalized in the year before the procedure, 100% versus 57%. All those differences favor the fact that MITRA-FR patients had more severe and more advanced heart failure disease than patients included in the COAPT trial. In terms of procedure, we observe less procedural success in MITRA-FR, 90% versus 95%, and more patients with MR above 3 at 1 year, 17% versus 5% in MITRA-FR versus COAPT. This slide showed that in the guideline-directed medical treatment group, the occurrence of the outcome is similar at 1 year, favoring that both populations today are comparable. This slide shows a subgroup analysis of the COAPT study. Patients presenting an ERA below 30 square per millimeter and larger left ventricle volume on left panel, smaller left ventricle volume on the right panel. In those patients, MitraClip was associated with a beneficial effect only in patients with less dilated left ventricle. See the right panel, suggesting that MitraClip in FMR have an effect when left ventricle is not too dilated. However, in case of an ERA below 30 mm square and larger left ventricle, MitraClip show no effect on the outcome. See the left panel. The analysis of MITRA-FR and COAPT study led to the concept of proportionate and disproportionate FMR. In the MITRA-FR study, patients presented more dilated left ventricle and moderately severe FMR, which were proportionate to the dilatation of the left ventricle. In the COAPT study, patients presented less dilated left ventricle and more severe MR that were not proportionate to the dilatation of the left ventricle. This proportionate severe MR might be improved by TEER, like in the COAPT study. On the opposite, proportionate non-severe MR might not be improved by TER procedure, like in the MITRA-FR study. The inclusion criteria for TEER for FMR, according to the latest ESC guidelines, are the following: severe FMR, NER more than 2, LVEF between 20 to 50%, LVEDD below 70 mm, 1 episode of heart failure in the last year or increased BNP levels, anatomy suitable for TEER. Exclusion criteria are the following: systolic pulmonary artery pressure more than 70 mm mercury, hemodynamic instability, cardiogenic shock, moderate or severe RV dysfunction, other indication for heart surgery. Technically speaking, 4 different MitraClip devices are available currently. NT device with arm length of 9 mm and arm width of 4 mm, XT device with arm length of 12 mm, NTW is the regular NT device with larger arms of 6 mm and XTW device with long and large arms of 12 by 6 mm. The complexity of TEER procedure should be anticipated according to the mitral valve anatomy as shown in this slide from the last ESC guidelines. Easiest case involve central A2P2 disease with no calcification, mitral valve area of more than 4, posterior leaflet of more than 10 mm and tenting height below 10 mm, normal leaflets and mobility. On the opposite, expert cases involve grasping zone with calcium, mitral valve area below 3 square centimeter, posterior leaflet length below 7 mm, and rheumatic anatomy. In between, intermediate case involve commissural A1P1, A3P3 cases, posterior leaflets between 7 and 10 mm, and tenting height of more than 10 mm. This is a case example of a patient with very large left ventricle and moderate MR. As you can see, this 71 years old woman with a ischemic cardiomyopathy and previous anterior MI in 2013 has a very low left ejection fraction of 20% and a very dilated left ventricle of 85 mm. This lady presented also a moderate MR with an ERA of 18 square millimeter and a regurgitant volume of 35 milliliter. Since the left ventricle was very dilated, the LVF very depressed, and the MR moderate, MitraClip procedure was not performed in this patient according to the COAPT criteria. This is another case of a 77-year-old man with dilated cardiomyopathy. The LVF was 30%, the NIA class was 3, and the MR presented an ERA of 52 square millimeter and a regurgitant volume of 60 milliliter. Systolic pulmonary artery pressure was 50 millimeter mercury. Auricles were dilated in chronic atrial fibrillation. You can appreciate on this slide the severity of the MR and the non-coaptation of the mitral leaflets. This patient was treated with 1 clip on A2P2 with a very good result, no residual leak and follow-up and regression of symptoms. In conclusion, no, all severe functional mitral regurgitation should not be treated by TEER. You should select patients under stable optimal medical therapy, presenting severe MR with ERA of more than 30 square millimeter or a regurgitant volume of more than 45 milliliter, presenting not too large left ventricle with LVDD below 70 millimeter. Avoid patient with right ventricular dysfunction. Avoid patient with severe pulmonary arterial pressure. And TER should be technically feasible with long enough leaflets, no calcification at the grasping spot, no mitral valve stenosis or rheumatoid disease. Also, patients should have reasonable comorbidities. Thanks for your attention.
Thank you so much, Professor Patrick Oman, for very nice presentation. I can see you are here, Professor Patrick Oman.
I'm connected.
Hello.
Hello.
Hello, how are you doing? Very good, very nice to see you again. Yeah.
Thanks for this invitation for this very nice meeting. Congratulations to you for organizing this meeting.
Thank you so much. So there are some questions for you. Here is one question for you. That's in your practice. I know you are one of the members for the MITRA-FR. So do you think we have a case like this? It is a little bit very silver FMR with the EF very low, and LV and DD is a little bit large, more than 70. But after 6 months, for example, very good practice medical treatment, everything a little bit improved, and the patient gets the criteria of the co-op. So should we still consider to do TEER for this patient or not, or should we wait for another time to re-evaluate?
Okay, thanks for this very good question. Sure, according to the guidelines, the patient you described as the optimized medical therapy with a very nice outcome after optimized therapy. So if the MR is still important at follow-up, and the left ventricle have decreased in size, so this patient became a good candidate probably for TEER, especially if he has symptoms. So I think the response is yes. If the patients switch from MITRA-FR status to a co-op status, so he become candidates.
Thank you. So there another question I have here is how many percent of practice the patient with FMR need two procedures? One is TEER and combined with the CRT. How many percent of the patient need a CRT besides the TEER?
Okay, it's a good question. I'm not sure I have the answer to your question. In our experiment in our center, I guess maybe 50% of patients had already resynchronization before TER, but I cannot be sure of these numbers. But in our population, many patients has CRT before TER, and the important thing is also that we should wait after resynchronization that left ventricle remodeling due to resynchronization occur before thinking about TER indication. So it may take three months at least.
Thank you. So yeah. So Dr. Hu, yeah.
Hi.
Yeah, I thought that you've given a very good overview of the indications for FMR. I would actually like to hear from your experience the treatments of TEER or MitraClip in patients with chronic atrial fibrillations. I asked that I just want to hear what are your feeling and the results, like what sort of patient you would choose. I have experience looking after these patients, and a lot of time they also have concomitant tricuspid regurgitations. And I just want to hear your thoughts on selecting patients with purely just mitral regurgitations from atrial FMR, or do you actually think that by treating only selecting those with purely atrial functional MR and not the atrial tricuspid regurgitations? How do you, yeah.
If I well understand your question, you speak about patient with chronic atrial fibrillation and very dilated left auricles, and those patients are becoming frequent nowadays. For now, if the TR is really important, And if the TR cannot be amenable to a TR clipping, maybe we should not indicate clips on those patients. According to the guidelines, also they insist about right ventricular dysfunction and large TR. But I think in the upcoming meeting, you are going to have a session on TR clipping, and probably this question will be addressed by the speakers of the ongoing session.
Yeah, I think you're right, Professor Oman. A lot of time, these atrial functional regurgitations tend to happen on both sides, and looking after this part or this select patients group, it's really tough. Medical therapy doesn't work very well because they go into atrial fibrillation, and fast AF makes it very complex. So I actually find that functional mitral regurgitations from ventricular MR seems to be a little bit more understood now. We have the experience from COAPT as well as mitral FR, so we know a bit more about the kind of substrate we are dealing with. But the atrial FMRs are really tough. Yeah.
Okay.
Thank you. I think Zaria question come to Dr. Hui. Compare with the CMR, is scintigraphy overweight in terms of cost and benefit in diagnosis and prognosis of cardiomyopathy?
I'm not sure to well understand the question. So the question is better to do a scintigraphy than CT scan to screen those patients. Is that right?
Yeah, I think this is an imaging question, so probably I'll take that. I think the question is asking about scintigraphy. That will mean the nuclear scintigraphy. So normally that detects more of viability in the nuclear imaging. To be honest, I think the question is whether which is better, CMR or is it a nuclear PET imaging? So to be honest, it all depends on what you're looking at. Just to illustrate, PET imaging looking at the the cells, whether they are viable in terms of glucose metabolism. Whereas for CMR, you actually look at scar. To me, I think more sensitive is to look at PET scanning, although scar tells you whether they are likely going to not improve. So I normally looked at it in multiple ways. If the patients have more access to CMR, I actually tend to use CMR because we have more access to CMR. Whereas nuclear imaging, at least for PET, is not something that we have in Singapore on a routine basis. So I don't normally use the nuclear imaging very much in that sense. So yes, the answer is probably CMR more in terms of the extent of fibrosis, because we want to select those who really do not do well for clip therapy, for example. We will try the very best with medical therapy for optimizations anyway, irregardless of whether the patient has got poor LV function versus none. The fact that they are heart failure, they will be treated very aggressively with medical therapy.
Thank you so much. So I think there's a question for Professor Patrick Oman. Do you have any experience to do the TER for the patient with post-rheumatic heart disease? It's a mitral regurgitation, but have some costs before. Yeah.
To now, we didn't clip those patients because often they have mitral stenosis associated to mitral regurg, and the size of the annulus is small. So no, I don't have experiences. We do not did TR on those patients.
Thank you. Thank you. Very good. So may I ask our secretary, is any question and answer? So I think the time is almost over. So On behalf of the chairperson for session today, I would like to thank our co-chair, Professor Yiu Si Hui, Professor Patri Oman, and our speaker today to give us very interesting experience about the diagnosis and treatment of the FMR. So I think in the future, actually we have done some cases in Vietnam, the TER, and nowadays the case I think increase time by the time. But once again, on behalf of Vietnam National Heart Association, I would like to thank you again for the very valuable contribution to our this very wonderful meeting. And we hope in the future, when the pandemic is over, we can meet each other face by face everywhere in the world. So I would like to close this session today, and thank you, and take a good care for you. Thank you, and bye-bye.
Thank you very much.
Thank you very much.
Thank you. Bye-bye. See you.
Sequent Please Neo enables the treatment of de novo lesions without stent-related disadvantage. During an inflation of just 30 seconds at nominal pressure, Sequent Please Neo's therapeutic agent paclitaxel is released into the vessel wall with the help of the excipient iopromide. This implant-free treatment requires only 1 month of DAPT.
Tim mạch học là một chuyên ngành y học hết sức sôi động và thường xuyên được cập nhật. Đại dịch Covid đã và đang thay đổi sâu sắc thế giới. Mọi khía cạnh của đời sống xã hội bị ảnh hưởng nghiêm trọng và đặt ra những vấn đề thách thức chưa từng có đối với các thầy thuốc nói chung và các bác sĩ chuyên khoa tim mạch nói riêng.
Vinh dự và tự hào khoác trên mình chiếc áo blue trắng, mỗi người thầy thuốc chúng ta luôn tự nhủ, ngoài sự cảm thông, yêu thương người bệnh, chúng ta luôn cần phải trau dồi và cập nhật các cái kiến thức chuyên môn của mình. Học tập là một quá trình liên tục và xuyên suốt trong cả sự nghiệp hành nghề của chúng ta. Học từ các thầy cô, từ anh chị em đồng nghiệp và từ chính người bệnh của chúng ta. Vì thế, các hội nghị, hội thảo khoa học, các khóa đào tạo liên tục luôn là những cơ hội để học tập và trao đổi kỹ năng nghề nghiệp của các thầy thuốc tim mạch chúng ta.
Ngành tim mạch Việt Nam trong những năm vừa qua đã có những bước phát triển vượt bậc. Các trung tâm tim mạch trên khắp cả nước đã có sự phát triển về cả chiều sâu và bề rộng. Hội Tim mạch Việt Nam cùng các phân hội là những tổ chức nghề nghiệp đã quy tụ được đông đảo các bác sĩ chuyên ngành tim mạch cũng như cộng đồng y khoa thông qua việc tổ chức các hội nghị, hội thảo và các khóa đào tạo liên tục. Hội nghị khoa học tim mạch toàn quốc năm nay là một minh chứng với sự tham gia của trên 300 các báo cáo viên, diễn giả nổi tiếng trên thế giới và trong nước, được phát cùng lúc trên 10 kênh trực tuyến và hàng loạt các chương trình đào tạo liên tục.
Chúng ta đã trải qua nhiều mất mát và thử thách, nhưng hơn bao giờ hết, các bác sĩ chuyên khoa tim mạch sẽ nỗ lực đoàn kết hơn. Sự nghiệp bảo vệ tim mạch sẽ không bao giờ nghỉ ngơi, không giới hạn và không khoảng cách giữa mỗi chúng ta. Chào mừng quý vị đến với Hội nghị Tim mạch Toàn quốc Việt Nam 2021.
Vâng, alo ạ. Xin kính chào các quý vị đại biểu đang theo dõi chương trình. Chúng ta sẽ vào cái phiên cuối cùng ở trong ngày ở cái kênh này ạ. Chúng ta cái chuyên đề của cái phiên này là thảo luận về cái câu chuyện hở ba lá và cái biện pháp can thiệp hở ba lá của đường ống thông. Ở phiên này thì chúng ta có phó sư tiến sĩ Nguyễn Sinh Hiền, Bệnh viện Tim Hà Nội, và tôi là cùng chủ tọa. các báo cáo viên nước ngoài đã tham dự và đóng góp gửi video cho chúng ta. Để mở đầu thì có lẽ là chúng tôi xin phép được mời người báo cáo viên đầu tiên, Dr. Yvonne Lavier Badi ở Bệnh viện Trường Toulouse của Pháp sẽ trình bày câu chuyện là khi nào thì hở ba lá thực sự là ảnh hưởng đến tiên lượng của người bệnh ạ.
Hello, thank you for attending this session about tricuspid regurgitation. I am Yvonne Lavier-Badi from Rangueil University Hospital in Toulouse, France. I will talk to you about tricuspid regurgitation and especially when it becomes clinically relevant and need to be evaluated. This is my disclosure form. So, background. To begin, a few data about tricuspid regurgitation epidemiology. In this recent study performed in China, in more than 100,000 patients, the prevalence of tricuspid regurgitation was 3% for mild tricuspid regurgitation, 2% for moderate tricuspid regurgitation, and 1.5% for severe tricuspid regurgitation. So the rate of tricuspid regurgitation rose significantly with increasing age, as you can see, for an age more than 80 years old, severe tricuspid regurgitation was about 4%. So about pathophysiology. So the vast majority of the patient had secondary tricuspid regurgitation, and primary tricuspid regurgitation accounts for only 5%. The main etiology were left side ventricular heart disease and dilated cardiomyopathy. So in summary, there are three main morphologic types of tricuspid regurgitation: the primary, the secondary, and isolated. In the primary form, you have here on the left, which is rare, as we've seen. It is an anomaly of the valve leaflet, for example, a leaflet prolapse. In the secondary form, in the middle, which is very frequent, it is most often a leaflet tethering related to the dilatation of the right ventricle, itself secondary to an increase in its afterload. So the increase in the right ventricle afterload is mainly due, as we've seen before, to left side ventricular heart disease or dilated cardiomyopathy. And lastly, isolated tricuspid regurgitation, which is mainly related to dilatation of the tricuspid annulus and the dilatation of the right atrial, most often in patients with chronic arrhythmia. About the natural history of tricuspid regurgitation, there is two factors. We are independent factor related to the severity of the annulus diameter and the tethering area. As you can see here, as soon as one of them is significantly present, they act as a vicious circle leading to torrential regurgitation. So if you had a dilated tricuspid annulus, you will have a more severe regurgitation, which will lead to right atrium dilatation, which will lead to more dilatation of the tricuspid annulus, which will lead to right ventricle dilatation, which will lead to tethering, and after that we'll have a massive or torrential tricuspid regurgitation. So what about prognosis? So Is tricuspid regurgitation has a prognostic impact? Of course, the response is yes. Simply having a tricuspid regurgitation, regardless of left ventricular function, for example, is associated with an increase in mortality. If we want to refine the gradation of the severity of the regurgitation as a net prognostic impact, if we take into account the effective regurgitant orifice area, there is a threshold of 40 that can be used to define the severity, but it's not the only parameter. It's not the only prognostic parameter. Vena contracta, regurgitant volume, and regurgitant fraction have the same impact. So the same is true here. This is a study in CMR with regurgitant volume and regurgitant fraction. But in this curve, the thing you have to note is that there is an exponential association with mortality, between mortality and tricuspid regurgitation severity. So it's more serious to have tricuspid regurgitant volume of 80, for example, than 40. But in the two cases, you have a severe tricuspid regurgitation. So if you see that, you can understand that a simple threshold of severity appears insufficient. So in this way, a new classification with two new thresholds of severity was proposed by Rebecca Hahn, and from my point of view, should be widely used. So the severity of the regurgitation is not the only prognostic factor. Finally, I think it will be a mistake to take into account only the severity of the tricuspid regurgitation. So remodeling and right ventricular function are of primary importance. For example, here we have shown that taking into account the cardiac output could be very interesting. You can see here, if you have a severe tricuspid regurgitation and you have a normal cardiac output, your survival is not so bad. But if you have abnormal cardiac output, you have poor outcome. The same is true with tricuspid diameter and right ventricular dysfunction in echocardiography. And to sum up, ventricular function seems to be the main prognostic parameter, well beyond remodeling. You can see here a very interesting study with patients with a severe tricuspid regurgitation, and they looked at the right ventricle with 4 patterns with the RV size and function. So it was normal size and function, dilatation and normal function, normal size and dysfunction, dilatation and dysfunction. As you can see here, finally, it was really the dysfunction which was associated with poor prognosis. It was the green and the brown curve here, even if the RV was normal or dilated. So finally, to complete the picture, it is necessary to know the prognostic factor impacting the therapeutic management of tricuspid regurgitation. Here we have shown in a large cohort in France that in case of tricuspid isolated surgery for severe tricuspid regurgitation, that the presence of signs of right heart failure, like NYHA class 3 or 4 right heart signs, like edema, or RV dysfunction or dilatation were associated with a very poor prognosis. So in this way, we recently developed an online tool to calculate the predictive risk of mortality in case of tricuspid surgery. And you can see here that, for example, if you have a patient and you wait until he has a symptom of right heart failure, so 2 points, right ventricular dysfunction, 1 point, and of course, a high dose of diuretics, 2 points, is predicted mortality. If you want to propose him a tricuspid surgery, is 14%. So if you wait too long, the mortality during surgery is catastrophic. The same is true with transcatheter therapy, with TriClip. They compared here massive and torrential regurgitation with severe tricuspid regurgitation, and even if the procedure was, if the result of the procedure was good, the prognosis was poorer with massive or torrential tricuspid regurgitation. So it's now time to answer the question: when does tricuspid regurgitation become clinically relevant? In summary, the prognosis worsens as the severity of the regurgitation and its impact on the right ventricle increases. So here, the main difficulty is that the symptoms occur very late and the surgical prognosis is very poor when the disease is advanced. So if you follow the guidelines, the very recent European guidelines, a surgical correction should be proposed in case of severe tricuspid regurgitation as soon as symptoms of right ventricular dilatation appear. Here, symptomatic RV dilatation and before the appearance of right ventricular dysfunction. And in case of severe right ventricular dysfunction, you can't propose a surgery because the prognostic is catastrophic. So this is my take-home messages. First, about natural history of tricuspid regurgitation. In the presence of more than mild tricuspid regurgitation, tricuspid annulus dilatation, or valve scissoring, it is the beginning of the disease, and that must be identified. From here, the vicious circle will set in and lead to a severe and torrential tricuspid regurgitation. So, the RV function will decrease and the symptom will appear. But symptoms often occur too late in the disease and should not dictate follow-up. So, in the first step, when you identify a large tricuspid annulus, an abnormal valve tethering, tricuspid regurgitation other than mild, you have to follow the patient. You have to begin the follow-up because, again, the vicious circle is on. Now, when the regurgitation is severe, but the right ventricular function is still preserved, it's here that therapeutic management should be considered, even in the absence of symptoms. So you have a patient with a severe tricuspid regurgitation. His right ventricular is still okay. He have right ventricular dilatation, maybe some symptoms. So it's the target. It's the target. After, it's too late. And of course, if you wait an extreme remodeling with torrential regurgitation, with right ventricular dysfunction, surgical management becomes futile and the prognostic is catastrophic. Okay, so my message is don't miss the target. Okay, the target, it's in the middle of the natural history of the disease, often with very discrete symptoms. It's now where tricuspid regurgitation is clinically relevant. It's now you have to treat the patient. Thank you for your attention.
Vâng, chắc là cái đường micro của anh Hiền đang bị trục trặc rồi ạ.
Alo.
Vâng.
Được chưa ạ?
Rồi ạ, được rồi ạ, nghe thấy rồi.
Không nghe rõ, ông nói kết thúc chưa nhỉ? Giáo sư Quang.
Dạ xong rồi ạ, vâng.
Ok. Merci beaucoup de la présentation de Dr. Juan Lavie-Badi. Sau đây thì chúng ta sẽ đến với bài thứ hai trong cái chủ đề về hở van ba lá, đó là làm thế nào để đánh giá mức độ hở van ba lá của Professor Erwan Donald đến từ Rennes, Cộng hòa Pháp. Xin mời tổ thư ký ạ.
Dear friends, dear colleagues, it's a real pleasure, and I should say also an honor, to be able to discuss with you about tricuspid regurgitation. I'm Erwan Donald. I'm a cardiologist in Rennes University Hospital in the west part of France in Britain. I think tricuspid regurg is still an incompletely understood issue for us cardiologists and clinicians. And then, as we don't understand quite perfectly the mechanisms related to the tricuspid regurg and the consequences of the tricuspid regurg on the symptoms and how we should treat the patient, we should be systematic. And we shouldn't forget about the fact that if we have a chronic severe TR, it increases the load, it increases the stress on the RV walls, and this increase in stress might decrease the RV function as well as it will increase the size of the right ventricle as well as the right atrium. And then when we have a patient with a tricuspid regurg, we should assess him precisely using TTE, using TEE, and we should look for the anatomy and the function of the cavities, the LV, the LA, the RV, the RA. And of course, we should look at the anatomy of the tricuspid valve. We should understand about the etiology of the tricuspid regurg, and we should assess the impact of the regurgitation on the right heart cavities. There are two main mechanisms related to the tricuspid rigors, which are most of the time secondary tricuspid rigors. I mean, functional tricuspid rigors. These are related to the increase in pulmonary pressure, so the increase in afterload of the right ventricle. And if we have an increase in afterload of the right ventricle, we will have a change in shape and size of the right ventricle. But also, we have a large number of patients without any increase in load, but an increase in size of the right atrium related to the permanent chronic atrial arrhythmias. And these permanent chronic atrial arrhythmias lead to an enlargement and a flattering of the tricuspid annulus that might lead to a severe tricuspid rigor that might induce symptoms and increase of risk in death and hospitalization for chronic heart failure. So we have to consider both the change in afterload and the change in right atrial function and size related to the atrial arrhythmias. So we really have to look at the RV, to look at the RA, and not only to the tricuspid valve. And as you can see, you can keep the triangular shape of the RV in apical four-chamber view, or the shape can change with an enlargement that is mainly observed in the mid part of the right ventricle when you have an increase in afterload. So just looking at the shape of the right ventricle might help you to understand if the tricuspid rigor is related to the increase in afterload or not. And of course, you shouldn't look only at the shape and the size of the right ventricle, despite the fact that the recent guidelines emphasize or underscore the fact that it's important to look at the size of the right ventricle. But you have also to look at the RV function. And of course, it's difficult. You have several parameters. You have the right ventricular fractional area change, which is not the best tool to use when you have a severe tricuspid rigor. You can look at the TAPSE or the S prime, but according to the recent papers that have been published, it seems that the best parameter you have to consider when you have a severe tricuspid rigor is to look at the RV strain, and this RV strain shouldn't be below 23%. And this parameter is really associated with the risk of rehospitalization or death. So look at the RV size, shape, and function. Look at the RV strain, and then look at the tricuspid annulus shape, size, and function. The function of the tricuspid annulus can be assessed looking at the size in systole and diastole. And nowadays, in TTE as well as in TEE, we can have a 3D assessment of the tricuspid annulus, which is quite interesting to look at the flattering of the tricuspid annulus and to look at the symmetry of the dimensions that shouldn't be found in a normal heart. When the size of the tricuspid annulus is enlarged homogeneously, then it means that there is a very severe, actually, enlargement of the tricuspid annulus. And then you have to consider that if you look very precisely at the tricuspid valve, because the patient is symptomatic, it's because you think about the treatment. And then you have to understand about the anatomy and the mechanisms of the tricuspid rigor. And you shouldn't forget to look not only in echo, but also using the right heart catheterization to the pulmonary pressures to make sure that the pulmonary pressures are not too high, because if the pulmonary pressures are too high and you want to treat the tricuspid rigor, you might affect the right ventricular function, and it is not a good idea. So the tricuspid valve is quite complex, actually. You have the anterior leaflet, you have the posterior leaflet, and the septal one. The septal is more ventricular, is related to the septum of the left ventricle, and the posterior leaflet is much more complex than the anterior leaflet. And when we treat the patient with clip, most of the time we start with a clip between the anterior and the septal leaflet, and then we have to move on to another clip between the septal and the anterior leaflet, and or to implant also a clip between the posterior and the septal leaflet. But we never implant any clip between anterior and posterior leaflets. So we look at the TEE actually, and we look at the transgastric view. And this transgastric view is quite convenient to understand about the posterior, the anterior, and the septal leaflet. And you have this classification that is quite interesting to keep in mind, considering the size of each of the leaflets and the fact that sometimes, most of the times, should I say, the posterior leaflet is made by several scallops, and it's difficult sometimes to know where is the posterior ending or when is the anterior leaflet ending. So for that purpose, TEE and transgastric view dedicated to the tricuspid valve are fundamental. It's a must. So the anterior leaflet is the longest valve, the septal leaflet is the shortest one, and the posterior leaflet is made most of the time made by multiple scallops, and it's much more complicated to understand this leaflet. We can assess the anatomy using the TTE 3D modalities, as you can see on these two examples of a patient with a pacemaker. And I use this example of a patient with a pacemaker because nowadays, when we have a secondary tricuspid regurg, which is the main cause of tricuspid regurg, we have to distinguish the patients who have a tricuspid regurg related to a lead, related to a pacemaker, from the one who are related to the atrium and the one related to the right ventricle. And of course, there are also some patients with a primary tricuspid regurg, but these patients are quite rare. So we have to look very carefully using the TTE as well as the TEE at the anatomy of the tricuspid valve. You see the septal leaflet, the anterior leaflet in parasternal long axis view. You see the posterior leaflet and the anterior leaflet in parasternal short axis view. And of course, in TEE, this is the same. You will have to assess the anterior and the posterior leaflet when you see the aortic valve or the LVOT. And when you don't see the LVOT, it means that you have the septal and the anterior leaflet instead of the posterior and the anterior leaflet. So when you see the aortic valve, you have the anterior and the posterior. When you don't see the aortic valve, you have the septal and the anterior leaflet in apical four-chamber view, as well as in apical, as well as in TEE mid-esophageal view. And as I told you before, you can use the 3D capabilities of your echo machine in TTE as well as in TEE, but you shouldn't forget about the fact that you have to assess the right heart in mid-esophagus, in the mid-esophagus, as well as in the deep esophagus. And you shouldn't forget, and you should learn actually, about the assessment of the tricuspid valve using the transgastric view, with the posterior leaflet, the septal, and the anterior leaflets. And then you will have to understand the mechanisms related to the tricuspid regurg, and you will have to quantify the tricuspid regurg. And nowadays we consider 5 grades of tricuspid regurg according to the vena contracta, to the regurgitatory orifice area, and to the regurgitant flow that we can measure or assess in the hepatic vein flows. So you have the cutoffs on the slide. But of course, when you assess the patient with a secondary tricuspid regurg, you first of all should have to optimize the volemia and then to increase the diuretics to make sure that you assess the patient with the hemodynamic is optimized. Because if you assess the patient when he's hypervolemic, then of course the gap between leaflets could be extremely important and could be abnormally important and can lead to the fact that you will consider the patient as unsuitable to a therapy, which might not be the case if you optimize the hemodynamic, because when you optimize the hemodynamic, you will see that the gaps between leaflets could be much less important than previously. So look at the patient where the hemodynamic is optimized, quantify the regurgitation using all these parameters, and measure the gaps between the leaflets, the anterior and the septal leaflet first, because this is the most important leaflets. And after that, you can look also at the posterior leaflets. So it's very important to look at the TTE as well as the TEE. You have to consider the hepatic vein flows. The vena contracta is important as well as the regurgitant orifice area. And if you can, please try to understand and to get an habit of the use of the 3D vena contracta, because this is the best parameter we can have nowadays to quantify the regurgitation of the tricuspid valve when we think about the secondary tricuspid regurg relative to the RA as well as relative to the RV. So look at the patient in TTE, look at the patient in TEE, look at the regurgitant flow in the hepatic veins, look at the morphology and the velocity of the continuous Doppler across the tricuspid valve. You see the triangular shape, the velocity about 2.5 meters per second. That is related to a severe tricuspid regurgitation with some degree of laminar flow between the RA and the RV. This is an example of a patient with a grade 5 of the tricuspid regurgitation. And of course, you will measure the gaps in TTE as well as in TEE, considering the mid-TEE, the deep TEE, as well as the transgastric view. And never, never forget to use the right heart catheterization, because sometimes you have a discrepancy between the echo and the right heart catheterization. And when you have a discrepancy between both measurements, this is a way to select the patient with the worst prognosis, actually. So you have to combine clinics, echo, TTE, TEE, and right heart catheterization to best understand about the importance of the regurg and the consequences and the prognosis. So my key messages is that tricuspid regurg is quite frequent, actually. It's associated with the prognosis in many clinical situations: heart valve diseases, heart failure with pulse of ejection fraction, atrial arrhythmias, heart failure with decrease in ejection fraction. We have to look very carefully at the right heart, RV, RA, and tricuspid valve. For the RV function, the RV GLS is quite convenient. And for the assessment of the tricuspid valve, it is important to be trained about the use of transgastric view to get a best way to assess septal, anterior, posterior leaflets. And it's very important to have these views very well done if we have to discuss a patient for CLIP or for another therapy to treat the tricuspid regurg. Thank you very much for your kind attention.
Vâng, xin cảm ơn giáo sư Ekwan Tonan vì đã có cái phần trình bày rất là chi tiết về cái cách mà là lượng giá, cái mức độ hở van ba lá, cũng là cái phần mà chúng ta thường ở trên lâm sàng chúng ta cũng ít chú ý, và đôi khi chúng ta nghĩ rằng cái việc đó là không quan trọng mà chúng ta không làm, mặc dù là đâu đó như cái phần trình bày của Dr. Iwan lúc đầu, nếu như mà đã có cái rối loạn chức năng của thất phải thì cái việc đó thực sự là sẽ ảnh hưởng đáng kể đến cái tiên lượng. Và chúng ta sẽ, trước khi đi đến phần thảo luận thì chúng ta sẽ kết thúc cái phần báo cáo bằng một cái bài cuối cùng. Chúng tôi xin kính mời Dr. William Roland từ Bệnh viện Đại học Trường của Rennes, Pháp sẽ trình bày cái chủ đề là can thiệp qua đường ống thông có thể làm gì cho cái hở ba lá.
Hello, my name is Dr. Guillaume Laurent. I am an interventional cardiologist in the University Hospital of Rennes, which is in the western part of the France. Thank you very much to the Vietnam National Heart Association for this kind invitation. I'm glad to be with you today, even if it's virtually and a record speech. And so the topic today of my talk is about the transcatheter tricuspid valve intervention in patients with secondary tricuspid regurgitation. Here are my disclosure. Please note that I have a potential conflict of interest with the Abbott Medical Society, who developed and distributes the MitraClip and TriClip device worldwide. As I am sure previous speakers told you, tricuspid regurgitation, and mostly severe tricuspid regurgitation, is associated with a poor outcome independently of age, independently of the left ventricular function. And those data, of course, concern patients treated with medical treatment only. And that proves that medical treatment is, in most of the case, not enough for those patients, since it's efficient for congestive symptoms, but not for the improvement of the outcome. And potentially similarly, the surgery of the tricuspid regurgitation is perhaps not associated with an improvement of the outcome of those patients compared to medical treatment only. Therefore, there is a large room for a third way, which is the transcatheter treatment of those tricuspid regurgitations. And when the factories developed during the last decades all the different way of management of those patients, of course, they get inspiration on the surgical approach. So, of course, the annuloplasty, the improvement of the coaptation, we can talk also about the neocardiac repair, of course, the replacement of the valve, and maybe the leaflet augmentation. So all those are all the different surgical strategy who may be tried to be reproduced in a transcatheter way. Of course, we can wonder about a potential room for a transcatheter tricuspid valve replacements. And here is the very promising results about the GATE transcatheter tricuspid valve. This was presented by Rebecca Ann last year in the JACC intervention. But as you can see here, it's about a small number of patients. Those are preliminary data, very interesting data, but preliminary data. And we can see that the transcatheter valve replacement for tricuspid valve is not for today, not even for tomorrow. Also, I'm sure you know that a very frequently used surgically approach is the annuloplasty. And you may also know that it exists a mitral annuloplasty technique, the so-called cardioband, and some interventional cardiologists and some cardiac surgeons reproduced these techniques in the tricuspid valve, and so they applied the cardioband in the tricuspid annulus in order to reduce the annular diameters. And here you can see here presented by Nick Koenig in the Eurointervention journal last year. You can see very, very interesting data with sustained results, with sustained reduction of the tricuspid regurgitation, sustained reduction of the septolateral annular diameter, and sustained improvements, functional improvement of this patient. However, it should be acknowledged that we are talking about a very small population, 25 patients at baseline, only 11 patients at 2 years. So once again, those results are very good, very interesting, very promising, but we have to keep in mind that those results are preliminary data. Why is it so difficult to treat those patients with tricuspid regurgitation? Because of many anatomical challenges who are resumed here. Of course, we are talking about a very large annulus. There is no things for a device anchoring, and mostly there is a lack of calcium. We are talking about very fragile and thin leaflets. We are talking also, and we will talk about this later, about a valve with a lot of anatomical considerations. I want to say that many patients don't have 3 leaflets. It's called a tricuspid valve, but actually a tricuspid valve is very frequently a quadricuspid, a 4 leaflet valve. And of course, this anatomic variability has important issues for percutaneous treatments. Also, the angulation between the tricuspid annulus and the vena cava can be an issue. Those patients frequently have pacemaker or defibrillator leads. And of course, there is a proximity of numerous structures who can complicate the transcatheter correction. A couple of years ago, the 3-valve registry aimed at encompassing all the worldwide procedures of percutaneous treatment of tricuspid valve. So here are the preliminary, the first results of this very important registry. It was about 312 high-risk patients with severe tricuspid regurgitation, mostly functional tricuspid regurgitation. And you can see that an important number of many devices were tried, but the mostly used device was the MitraClip device, 66% in this preliminary experience. And very interestingly, this is efficient with a significant reduction of the severity of the tricuspid regurgitation at 30 days, a significant improvement of the functional class of the patient at 6 months. And interestingly, the patients, the functional improvement is mostly found in patients with tricuspid regurgitation reduction. So as I said, the mostly used device, the mostly used approach is the edge-to-edge approach. At the very beginning, the interventional cardiologist and the cardiac surgeon use the MitraClip. So the MitraClip is the device initially developed for the mitral valve in order to reproduce in a percutaneous way the Alfieri edge-to-edge stitch. So we used the MitraClip device in tricuspid position. initially the NT generation, and then we have the next generation with NTR and XTR with longer arms. And of course, it was a bit more easier to catch the leaflet with longer arms. And last year, the Abbott company launched the new generation, the TriClip device. And the TriClip device is different from the MitraClip because there is a new knobology. The knob are different between the TriClip and the MitraClip device, and the catheter deflection is now adapted to the tricuspid anatomy. And very lately, Abbott developed the last generation, the J4, with 4 different sizes of TriClip. This slide is very important because it resumes all the anatomic criteria for a patient for tricuspid edge-to-edge repair. Of course, some patients should not be referred to such procedures because we can suspect a futility of such a procedure. I'm talking about the patient with severe pulmonary hypertension or patient with severely altered right ventricular function. In some patients, the procedure will be very, very difficult and sometimes very impossible. And those patients are those with very poor echographic windows. You have to know that this procedure is very, very, very difficult for both the interventional or the cardiac surgeon, but also and mostly for the echo specialist, because the leaflets are very difficult to see. The device is very difficult to see. All the anatomic apparatus or the anatomic structures are very, very difficult to see. And so it's a very tough procedure. So if the echographic windows is not perfect, it will be mostly impossible to do such procedures. Of course, we only speak here about patients with secondary tricuspid regurgitation with normal appearing leaflets. But last, there are 3 identified anatomical criteria which can make the procedure impossible. First is a large coaptation defect. The larger the coaptation is, well, a good procedure is a good patient is a patient with a very small coaptation defect, less than 3 millimeters. But in some patients, an important number of patients have very large coaptation defect, more than 7 or 8 millimeters. Those patients cannot be treated with such a procedure. Well, at least there is a very high risk of failure of procedures. The second point is the location of the jet. Ideal patients are patients with a jet located between the anterior and the septal leaflet. And the third criteria, which is not presented in the previous slide, but in this slide, is the morphology of the tricuspid valve. As I said a couple of minutes ago, many patients don't have a 3 leaflet, but a 4 leaflet configurations. And those patients with the 4 leaflet configurations have a lower risk of a very good results of transcatheter edge-to-edge procedures, independently of the size of the gap and independently of the location of the jets. What is the strategy with the edge-to-edge repair? Because you know that the mostly adopted surgical strategy is an annuloplasty. The surgeon aimed at reduce the perimeter of the tricuspid annulus, and so is the interventional cardiology. And you may know that when the annulus will be dilated, and that's the mechanism of the tricuspid regurgitation, the septal leaflet will remain in same place. I mean, the dilatation is mostly because of the anterior and posterior part of the annulus. So the clip will use the septal leaflet as an anchor. So generally we put a first or a second clip between the septal and the anterior leaflet. Sometimes we add a third clip between the septal and the posterior, sometimes a fourth one, in order to reduce the size of the tricuspid annulus. So it in real life, it gives you this kind of images, and those of you who are familiar with the mitral valve, and especially the MitraClip procedures, they may find that those are poor imaging. And believe me, when for tricuspid procedure, this is pretty good imaging, and that gives you an idea of the difficulties of the visualization of the leaflet. So here you can see in white the clip between the anterior and the septal leaflet. And then in these patients, we added a second clip between the septal and the posterior leaflets in order to reproduce the shape of a clover with a bit of imagination. What are the results of the TriClip? The TriClip has been evaluated in the TriLuminate single-arm study, was published in the Lancet 2 years ago. And this, the primary endpoint was effectiveness, so the TR reduction of at least 1 grade at 30 days post-procedures. And there were also an endpoint about the safety at 6 months. About 85 patients, the TriLuminate reported a high implant and a high acute procedural success rate. Also, the primary safety endpoints of major adverse events at 6 months were clearly successfully met with a couple of additional safety endpoints. Interestingly, at 1 year, this trial found durable tricuspid regurgitation repair, and also a continued symptomatic improvement in those patients as presented here. And last, it was associated with a positive remodeling of the right cavities for those patients. Last, I have to say that the MitraClip is not the only available device, since the Edwards company developed and commercialized the Pascal device, whose characteristics I presented here. And the Pascal also had a very interesting results. Considering all those presented elements, the very recent European guidelines for the management of valvular heart disease gave a small room, but that's a beginning, with a 2B class of recommendations for a tricuspid, for a transcatheter tricuspid regurgitation treatments in inoperable patients at heart valve centers with expertise in the treatments of such valvulopathy. So what are the next steps? Of course, this will be the evaluation of those both devices, the TriClip and the Pascal, in the setting of large registry, and mostly in the setting of randomized trials who evaluate the potential benefits of MitraClip, of TriClip or Pascal on the top of an optimal medical treatment compared to optimal medical treatment in patients with severe and symptomatic secondary tricuspid regurgitation. Meanwhile, is it relevant to treat those patients? I dare say yes, considering this very recent meta-analysis of all the published procedures who reports, we're talking about 771 patients. This meta-analysis reports a clear improvement of the New York Heart Association functional class, an improvement of the 6-minute walking distance, and of course, a reduction of the severity of tricuspid regurgitation following such procedures. Also, this is a non-randomized, but this is an analysis of the TreeValve registry who show an improvement of the outcome in patients treated with percutaneous treatments of tricuspid regurgitation. And this benefits is mostly observed in patients with procedural success, whereas control patients or patients without procedural success have the similar poor prognosis. So this is my conclusion slide. I just wanted to say that the percutaneous treatments of tricuspid regurgitation is clearly safe and feasible. It may improve the functional status of the patients. It seems to give sustainable effect over times. However, there are still pending issues for such treatments, mostly about the patient selections, mostly about the timing of intervention. You don't want to treat the patient too early in order to, because you don't want to do a futile procedures, but you don't want to treat the patient too late. And last, we don't know which approach is the best. We don't know which device is the best. Thank you very much for your attention. Once again, if you have any question, please do not hesitate to send me an email. Here is my email address. I will be glad to answer to your answer, and I wish you to your question, and I wish you a very good Congress.
Cảm ơn Dr. William Lawrence đã cho chúng ta một cái bài tổng quan rất là quan trọng về cái việc mà làm thế nào để có thể can thiệp được qua đường ống thông đối với cả mức độ hở van ba lá. Bây giờ chúng ta sẽ sang cái phần thảo luận. Chúng ta cũng nên biết chú ý một chi tiết là cái cùng với cả cái hội nghị của chúng ta đợt này thì cũng chính là cái hội nghị ở TCT về tim mạch can thiệp ở Hoa Kỳ, và có một số lượng lớn các báo cáo viên của chúng ta cũng đã phải tham gia cái TCT cũng là con đường online như thế này. Đâm ra nhiều khi đã không có thể có mặt được cùng với cả chúng ta ở đây. Hiện tại thì chúng ta có ở đây là có Phó giáo sư Nguyễn Sinh Hiền, và việc đầu tiên là chúng tôi cũng muốn nhờ Phó giáo sư Nguyễn Sinh Hiền chia sẻ cái góc nhìn của ngoại khoa về câu chuyện là hở van ba lá. Chúng ta có thể làm được cái gì với cả hở van ba lá khi là phẫu thuật, và cái quan điểm của ông về cái chuyện mà chỉ định mổ những cái trường hợp mà hở van ba lá nặng là như thế nào ạ? Vâng, xin mời anh Hiền ạ.
Xin cảm ơn cái gợi mở của Phó giáo sư Nguyễn Ngọc Quang. Thế thì về cái hở van ba lá thì đúng là giai đoạn trước ấy, nhiều khoảng độ 10-20 năm trở về trước ấy, thì chúng ta đúng là chúng ta coi nhẹ cái chuyện hở van ba lá. Nhưng mà cùng với trong cái giai đoạn hiện tại thì cùng với cái sự phát triển của những cái phương tiện đánh giá cái chức năng thất phải và đánh giá cái mức độ hở van lá nó chính xác hơn, cùng với cái việc mà các cái nghiên cứu trên thực tế trên những cái bệnh nhân mà có hở van ba lá kèm theo những cái bệnh lý tổn thương van hai lá hoặc động mạch chủ hoặc những cái bệnh lý khác của tim ấy, thì chúng ta mới thấy rằng là cái van ba lá nó rất là quan trọng. Tức là khi mà hở van ba lá mức độ nặng, trước đây chúng ta cứ nghĩ rằng là chúng ta điều trị nội khoa nó ổn, áp lực phổi nó xuống, các cái van kia xử lý xong thì van ba lá nó kín lại, nhưng thực ra không phải như vậy, mà cái van ba lá nó không hoàn toàn nó kín lại mà nó vẫn tiếp tục nó hở một cách tiến triển, và người bệnh có những cái triệu chứng lâm sàng nặng, ví dụ như là gan to, ví dụ như là bệnh nhân mệt, ví dụ như là rối loạn nhịp tim, vân vân. Do đó mà cái hở van ba lá bây giờ thì được chú trọng một cách đúng mức. Và đối với vấn đề ngoại khoa thì hiện tại thì cũng đã có những cái khuyến cáo mới nhất của Hội Tim mạch Hoa Kỳ cũng như là châu Âu về cái việc xử lý van ban lá. Thế thì với ngoại khoa chúng tôi thì tất cả những cái trường hợp mà nếu mà trong khi chúng tôi xử lý van hai lá, ví dụ thay van hoặc là van động mạch chủ, cái van ba lá nếu nó có hở mức độ 3/4, 3 hoặc là 4/4, tức là mức độ vừa hoặc nặng trở lên, thì bao giờ chúng tôi cũng sẽ xử lý cái van ba lá đó tùy theo cái cơ chế. Ví dụ như là nó hở do cái type 1 tức là giãn vòng van thì chúng ta sẽ đặt một cái vòng van cho bệnh nhân. Thế còn những trường hợp mà xa van thì chúng ta phải có những cái kỹ thuật khác. Ví dụ như là trong lúc mổ thì chúng tôi sẽ làm các cái làm thu ngắn cột cơ hoặc dây chằng, hoặc là làm cái kỹ thuật S2S. Chúng tôi khâu các cái phần van ba lá nó bị xa và để đánh giá để sửa chữa cái sự xa đó và để cho van ba lá nó kín. Thế còn trong những trường hợp mà hở van ba lá mà mức độ trung bình nhưng mà cái vòng van nó lớn, ví dụ như là trên 40 mm cái đường kính ấy, thì cũng nên đặt cái vòng van ba lá để tránh một cái hiện tượng sau này nó sẽ hở van ba lá tiến triển. Và trên thực tế thì trước đây chúng tôi sau khi hồi cứu lại thì rất nhiều bệnh nhân trước đây được vá thông liên nhĩ, nhưng trước đó đã có hở van ba lá vừa rồi và thất phải giãn lớn rồi, mà chúng ta không đặt vòng van thì sau khoảng 5 năm 7 năm là bệnh nhân quay lại với một cái hở van ba lá rất nhiều và cái triệu chứng rất là bệnh nhân rất khó chịu do có những cái triệu chứng cơ năng. Cho nên là cái việc mà chúng ta chú trọng và chúng ta xử lý thích đáng cái van ba lá là hợp lý. Vâng, xin đấy là ý kiến của về phía ngoại khoa. Xin tiếp tục ý kiến của phó giáo sư Nguyễn Ngọc Quang.
Vâng, rất cảm ơn cái phần chia sẻ của anh Hiền, vì thực ra là chúng ta các báo cáo viên của chúng ta cũng đang vướng một cái báo cáo khác, cho nên là đã không thể tham dự được trực tiếp cái phần trả lời này. Và chính vì thế nên chúng tôi muốn dành nhiều thời gian hơn để chia sẻ cái góc nhìn từ phía ngoại khoa cho nó trọn vẹn một cái nhìn khía cạnh là từ lúc chẩn đoán tiên lượng. Và rõ ràng những phần trình bày đầu tiên của Dr. Yvonne thì chúng ta nhìn thấy rõ là khi mà cái giai đoạn đầu tiên là mới chỉ là thất phải giãn nhưng mà chưa có ảnh hưởng đến chức năng thất trái, rồi sau đó nó biến dạng, xin lỗi, thất phải, và sau đó mới là biến dạng của nhĩ phải, của thất phải, và sau đó mới là rối loạn chức năng thất phải, và khi đó thì mọi việc đã trở nên rất là tồi tệ. Và vì thế nên là đúng là như anh Hiền nói là trước đây chúng ta không chú ý nhiều đến câu chuyện mà sửa van ba lá để nó tự nhiên, nhưng rồi sau này chúng ta mới nhận ra rằng là cái việc đó thực sự là nó đem lại một outcome rất là tồi. Đã có rất là nhiều các báo cáo của các đồng nghiệp ở trong nước, ở khu vực miền Nam, ở Viện Tim Thành phố Hồ Chí Minh, nơi mà đã sửa van hai lá rất là nhiều, thì cũng đã có những tổng kết lại và cho thấy là cái ảnh hưởng nghiêm trọng của cái hở ba lá đến cái tương lượng chung. Và đúng là chúng ta phải làm một cái gì đấy. Tuy nhiên là cũng phải chia sẻ là với anh Hiền là ở đây nó có một chi tiết là các cái kỹ thuật mà sửa van ba lá có vẻ là nó chưa được chuẩn hóa, và đôi khi là rất là khó để đánh giá được cái, không thể mình đôi khi là khó để chắc chắn được cái kết quả của hở van ba lá, có đúng không ạ? Bởi vì đối với cả câu chuyện hở van hai lá thì nó đã là một cái gì đó nó được tương đối chuẩn hóa và chúng ta có thể biết chắc được là câu chuyện là thế nào.
Dạ vâng, tôi nghĩ rằng là hở sửa van ba lá nó là một nghệ thuật. Chúng ta cứ nghĩ rằng là cái van ba lá nó không quan trọng và chúng ta nghĩ rằng là sửa van hai lá nó mới khó, nhưng thực ra sửa van ba lá vừa dễ và lại vừa khó. Dễ là khi nào mà cái vòng van nó chỉ giãn đơn thuần thôi, chúng ta chỉ đặt một cái vòng van với một cái cỡ vừa thích hợp thì đương nhiên là cái van đấy nó sẽ kín và kết quả rất là chắc chắn. Tuy nhiên trong những cái trường hợp mà cái cơ chế hở van nó phức tạp, ví dụ như là trong những cái trường hợp như cái bệnh Epstein chẳng hạn, hoặc là những trường hợp mà van ba lá tổn thương nhiều cơ chế, vừa xa vừa giãn lại vừa có rút, trong những trường hợp mà thấp tim thì cái việc sửa van là khá là phức tạp. Cho nên cái việc sửa tôi nói nó như là một cái nghệ thuật ấy, và phải nhiều khi nó theo những cái nguyên tắc chung của các băng chê rồi của các cái lý thuyết đưa ra, nhưng nhiều khi nó thực sự nó là một cái sự linh cảm. Khi nào ta đặt vòng van, khi nào ta mở rộng mô van, khi nào ta cắt cái dây chằng co rút, khi nào ta thêm cái dây chằng, khi nào ta sliding cái lá van, rất nhiều các cái cơ chế. Và đặc biệt là cái kỹ thuật S2S chẳng hạn, nó nhiều khi nó rất là hiệu quả, nhưng đôi khi nó cũng gây, nếu chúng ta làm không tốt, nó sẽ gây hẹp cái lỗ van, và nó sẽ gây tác dụng là ngược lại, tức là nó gây hẹp cái van ba lá. Cho nên cái việc mà sửa van ba lá nó thực sự là nó là một cái nghệ thuật, và nó cũng rất là thích thú, đưa lại một cái challenge cho người phẫu thuật viên, nhưng mà nó cũng là một cái phải nói là rất là thích thú.
Vâng, cảm ơn anh Hiền đã chia sẻ cái góc nhìn đó. Thế thì một cái chi tiết ở đây là có một cái bạn đồng nghiệp có hỏi một câu thế này, tức là nếu như cái hở ba lá đó đã ảnh hưởng đến cái chức năng của gan cũng như là của thận, thì cái kinh nghiệm của anh trong cái việc sửa van ba lá này nó có hiệu quả không? Sau này cái việc nó chức năng gan thận nó có hồi phục được chút nào khi hở van ba lá đã nặng đến cái giai đoạn muộn đấy không ạ?
Vâng, xin cảm ơn cái câu hỏi đấy. Câu hỏi đấy rất thực tế, và thực ra nhiều khi chúng ta đứng trước một bệnh nhân như vậy, chúng ta cũng phải đắn đo rất nhiều. Chúng ta phải xem là một là cái mức độ hở van, hai là cái cơ chế van nó hở ra làm sao, thứ ba là chúng ta phải đánh giá được cái kích thước của thất phải, cái chức năng của thất phải dựa trên MRI và cả trên siêu âm nữa. Và chúng ta cũng đôi khi phải dựa trên những cái xét nghiệm về sinh hóa, xem cái chức năng gan nó như ra làm sao, thì chúng ta mới đưa ra một cái tổng hợp để có thể quyết định sửa hay không. Nhưng mà theo tôi, trong những trường hợp mà bệnh nhân vẫn còn có cơ hội, ví dụ như là chúng ta sau khi điều trị một đợt nội khoa mà các cái triệu chứng lâm sàng nó khá lên, thì hoặc là trên cái CT trên MRI chúng ta thấy là chức năng thất phải nó không quá tệ, thì chúng ta vẫn có thể tiến hành phẫu thuật sửa gan. Ngoài những cái tổn thương tim khác thì chúng ta sửa van ba lá. Và đặc biệt là trong những cái nghiên cứu cũng phải đến 20 năm rồi của ekip của giáo sư Các Anh Chê thì chúng ta thấy rằng là trong những trường hợp mà van ba lá mà tổn thương nặng, chức năng thất phải giảm nặng, chúng ta ngoài cái việc sửa van ba lá, chúng ta làm thêm một cái phẫu thuật nữa là chúng ta cắt cái tĩnh mạch chủ trên, chúng ta nối với động mạch phổi phải, tức là làm cái phẫu thuật cavopulmonale hay là gọi là phẫu thuật Glenson đấy. Thì lúc đó cái tỷ lệ thành công nó sẽ tăng lên, và tỷ lệ tử vong của những cái suy tim phải đấy nó sẽ giảm đi, có ý nghĩa thống kê rất là lớn. Bởi vì khi đó này cái gánh nặng của tim phải nó đỡ đi, nó giảm đi rất là nhiều. Thì ngoài cái việc mà chúng ta sửa van ba lá thật tốt, chúng ta nên làm những cái kỹ thuật khác nữa phối hợp, ví dụ như là tôi nói làm thêm cái phẫu thuật cavopulmonale.
Vâng, ở đây còn một chi tiết nữa mà một số các bạn cũng đồng nghiệp cũng có hỏi tới, là cái câu chuyện mà cái chỉ định thay cái van ba lá thì hiện nay là như thế nào? Chúng ta có làm nhiều câu chuyện đó không? Bởi vì là một trong những cái chúng ta phải đối mặt đó là cái biến cố khi và liên quan đến câu chuyện dùng chống đông đối với cả cái van ba lá, nếu mà chúng ta thay một cái van cơ học vào đó. Vâng, thì nhờ anh Hiền lại tiếp tục trả lời câu này ạ.
Vâng, chúng ta biết rằng là cái áp lực của buồng thất phải nó không quá lớn, và cái việc cái mô van ba lá nó cũng tương đối phong phú, và cái việc mà chúng ta có thể dùng các cái màng tim để tạo hình cái van ba lá nó khá là dễ dàng. Cho nên cái việc mà thay van ba lá rất ít khi đặt ra. Chúng ta hầu hết là chúng ta sửa, và chúng ta chấp nhận có thể là một cái trường hợp hở ba lá mức độ 2/4, mức độ vừa, và điều trị nội khoa, thì còn hay hơn là cái chuyện chúng ta mang cái van đó chúng ta cắt đi mà chúng ta thay bằng cái van khác. Chúng ta chỉ thay cái van đó khi mà cái van nó đã bị phá hủy, không thể sửa chữa được. Ví dụ trong những trường hợp bị Osler van ba lá, nó ăn tất cả những cái cục sùi và cái mô van nó hỏng hết, chúng ta không thể sửa chữa được nữa, thì chúng ta đành phải cắt bỏ đi, chúng ta thay một cái van ba lá mới. Hoặc trong những trường hợp mà chúng tôi mổ rất nhiều cái bệnh lý Epstein thì hầu hết chúng tôi sửa chữa bảo tồn, nhưng trong một số cái trường hợp thì cái Epstein hầu như không còn mô van, tức là mô van lá vách và lá sau không có, còn mô van lá trước thì nó chỉ có một chút xíu, nó bám dính chặt vào cái thành thất, thì lúc đó không thể nào mà tạo hình được nữa, thì chúng tôi thường là thay bằng một cái van cho bệnh nhân. Thì cái van thì thường thì chúng tôi thay van sinh học, thế còn cũng có trên thế giới cũng có những cái thống kê thay bằng van cơ học, nhưng mà thường thì ở vị trí cái van ba lá chúng ta thay một cách rất là nhanh chóng. Một cái van sinh học nó có thể tồn tại 15 năm, sau đấy nếu sau này nó hẹp hoặc hở lại, chúng ta có thể tiếp tục mổ một lần nữa và mổ thay một cái van ba lá, nó không có khó khăn gì ngay cả khi mà mổ lại. Thế còn trong những cái trường hợp mà đó, chỉ có 2 cái trường hợp mà chúng tôi hay thay, và đặc biệt là chúng ta biết rằng thay cái van ba lá nó rất dễ bị block nhĩ thất, cho nên theo kinh nghiệm của chúng tôi thì chúng ta không khâu vào cái vòng van giải phẫu của nó, mà thường chúng tôi sẽ khâu vào phía trước thì khâu vào vòng van giải phẫu, nhưng phía cái nút nhĩ thất ấy thì chúng tôi sẽ bó hít, chúng tôi sẽ khâu về phía buồng nhĩ để tránh cái đó, và thường là kết quả nó rất là tốt và không bao giờ có block nhĩ thất nữa.
Vâng, ở đây có một cái câu hỏi khá là lý thú và dành riêng cho đích danh cho phó sư Sinh Hiền. Những bệnh nhân mà thông lên nhĩ có mức độ hở van ba lá vừa trở nên thì có nên bít bằng dụng cụ hay không? Hay là chúng ta sẽ làm luôn phẫu thuật để cái sửa van ba lá? Bởi vì nếu mà bít bằng dụng cụ thì có thể là cái tiến triển của hở van ba lá nó vẫn còn tiếp tục ạ. Vâng, xin mời anh Hiền cho ý kiến câu này chuyện này.
Vâng, câu hỏi cũng rất là hay và thực tế. Nếu mà những cái chúng ta phải xem cái cơ chế của hở van ba lá như thế nào. Ví dụ trong những trường hợp mà chúng ta thấy là thông liên nhĩ, rõ ràng là cái việc bít khi mà các cái G nó đủ kích thước thì chúng ta bít có chỉ định. Nhưng nếu cái hở van ba lá mà nó do cái buồng thất phải nó giãn rất là nhiều rồi thì chúng ta nên phẫu thuật. Chứ còn nếu chúng ta không phẫu thuật để sửa cái van ba lá đó mà chúng ta chỉ đóng cái thông liên nhĩ đấy, thì cái khả năng mà tiếp tục sau này nó giãn và bệnh nhân có những cái triệu chứng cơ năng là cái khả năng cao. Tất nhiên không phải các bệnh nhân đều diễn biến như vậy. Theo như kinh nghiệm của tôi, tất nhiên chúng tôi chưa có một cái thống kê chính thức, nhưng mà cũng có những cái bệnh nhân nó diễn biến nặng hơn, cái van nó sẽ hở nhiều hơn, nhưng cũng có bệnh nhân nó dừng lại ở cái mức đó và chúng ta phải điều trị phối hợp với lợi tiểu chẳng hạn. Và đặc biệt là trong thời gian khoảng độ 5 năm lại đây ấy, thì cái việc mà chúng ta mổ nội soi cái thông liên nhĩ kèm hở van ba lá nó rất hiệu quả. Chúng ta mổ cái đường rạch nó chỉ khoảng độ 2 cm thôi, và chúng ta có thể mổ nội soi và chúng ta đã vừa khâu thông liên nhĩ, chúng ta vừa sửa cái van ba lá. Như vậy thì mà cái nguy cơ biến chứng và tử vong của nó thì cực kỳ thấp. Như vậy thì bằng một cái đường mổ rất là nhỏ chúng ta có thể giải quyết cả 2 cái vấn đề như vậy. Thì bao giờ đứng trước bệnh nhân thì chúng ta cũng phải cân nhắc dựa theo cái tổn thương chính thức này, thứ hai là dựa theo cái mong muốn của người bệnh, thứ ba là dựa theo trình độ của ekip, thì chúng ta sẽ cân nhắc nên đi theo hướng nào.
Vâng, rất cảm ơn câu hỏi rất là đầy đủ và của phó sư Nguyễn Sinh Hiền. Đúng là trên thực tế chúng ta cũng đã gặp những cái tình huống mà cái lỗ thông liên nhĩ nó nhỏ nhưng mà cái luồng sân rất là lớn và gây ra cái hở ba lá đáng kể. Và chúng tôi cũng đã thấy là nhiều trường hợp thì hở van ba lá nó cũng đỡ đi và có những nhiều trường hợp thì vẫn còn giữ nguyên. Tuy nhiên là đối với cả câu chuyện hở van ba lá tồn dư đấy ạ, mà nó tiến triển tiếp thế nào thì chúng ta còn phải tính toán đến một câu chuyện nữa là cái rung nhĩ. Bởi vì nếu mà cái rung nhĩ nó đi thường nó sẽ xuất hiện trong cái trường hợp hở van ba lá nặng như vậy, và nếu chúng ta kiểm soát nhịp không tốt thì chúng ta lại còn có một cái bệnh lý cơ tim liên quan đến nhịp nhanh, liên quan đến rung nhĩ, và nó sẽ làm nặng hơn cái tình trạng gốc, và lúc đó chúng ta đôi khi sẽ rất khó phân định nguyên nhân gốc của câu chuyện đấy là cái gì. Đấy cũng là một cái khía cạnh khác mà chúng ta nên chú ý khi mà chúng ta cân nhắc cái việc mà chúng ta điều trị cho bệnh nhân thế nào. Chúng tôi rất đồng ý với cả ý kiến của anh Hiền về cái câu chuyện mà chúng ta cần phải có một cái HT team để bàn đối với cả cái câu chuyện là đứng trước một bệnh nhân cụ thể chúng ta sẽ lựa chọn là can thiệp qua đường ống thông hay là chúng ta can thiệp qua cái đường mổ nhỏ xâm lấn mà đồng thời chúng ta có thể sửa cả hai. Bởi vì đại đa số những trường hợp mà can thiệp bằng ống thông có thể chúng ta phải đưa một dụng cụ đóng ru rất là lớn, và như thế thì đâu đó nó có thể ảnh hưởng đến cái chức năng của nhĩ sau này khi mà cái ru nó quá lớn và nó chiếm gần như hết cả buồng nhĩ. Thì đấy là những cái khía cạnh mà chúng ta cần phải cân nhắc. Ở đây nó còn có một vài cái câu hỏi khác nữa liên quan đến cái câu chuyện mà hở ba lá đối với cả cái điện cực thì như thế nào, và liệu cái clip của van ba lá có giải quyết được không. Câu này thực sự là chúng tôi không có kinh nghiệm và chúng tôi sẽ chuyển đến Dr. Julian Laurent để hỏi qua email, và chúng ta sẽ tiếp tục cái câu thảo luận này trên trang web. Có một câu hỏi khác để dành cho Dr. Bardier, nhưng mà chúng tôi nghĩ rằng anh Hiền cũng có thể trả lời được hộ câu này. Tức là trong thực hành lâm sàng thì anh có nhắc đến cái câu chuyện là dùng cộng hưởng từ cũng như là siêu âm tim để đánh giá mức độ hở ba lá thì lúc nào anh sẽ chỉ định cho những bệnh nhân để làm cộng hưởng từ như vậy ạ?
Thường thì nếu chúng ta trên siêu âm chúng ta thấy rằng là cái chức năng tim cả thất phải thất trái nó còn tốt ấy, thì chúng ta không dùng đến cộng hưởng từ. Nhưng nếu mà chúng ta hở van ba lá nặng mà chúng ta lại thấy là chức năng thất phải nó không được tốt, thì thường là cái cộng hưởng từ nó khảo sát rất tốt về cái chức năng tim, cho nên là chúng tôi thường có cái chỉ định là sẽ dùng cộng hưởng từ nữa. Tất nhiên là cái này cũng cần phải có một cái sự thống kê, bởi vì cái việc mà chúng tôi chỉ định cái này cũng chỉ có một vài năm gần đây và nó chưa có những cái nghiên cứu dài hạn, và chúng tôi hy vọng là trong tương lai thì sẽ có những cái kinh nghiệm để có thể phổ biến rộng rãi hơn. Nhưng mà nhìn chung nếu chức năng tim giảm, chúng ta sẽ chỉ định cộng hưởng từ kết hợp với cả siêu âm.
Vâng, đó cũng là có lẽ là đó cũng là một cái cần thiết, vì cộng hưởng từ nó còn cho phép chúng ta biết thêm được nhiều cái thông số khác nữa, ví dụ như mức độ sơ hóa cũng như là cái vận động của các buồng tim khác bên cạnh. Đấy là những cái phần mà chúng ta đã có một cái buổi thảo luận về cái hở van ba lá. Đây cũng sẽ là một cái chủ đề mà chúng tôi nghĩ rằng về phía Hội Tim mạch Việt Nam sẽ còn tiếp tục theo đuổi cái câu chuyện hở ba lá trong những kỳ đại hội tiếp, bởi vì đây thực sự là một cái vấn đề rất là khó, phức tạp, và giống như anh Hiền nói, lúc đầu chúng ta tưởng rằng là hở van ba lá là đơn giản, là dễ làm, dễ đánh giá, nhưng thực ra càng đi sâu vào thì chúng ta mới càng thấy là câu chuyện nó trở nên phức tạp hơn rất nhiều, về cái việc mà nhận định trong các cái thông số nào để đánh giá. Ví dụ như là những cái thông số mà chúng ta vẫn thường nói như là TAPSI rồi vân vân đấy ạ, thì liệu có đủ để đánh giá mức độ hở ba lá không, hay là chúng ta sẽ phải dùng đến cái độ sức căng cơ tim của thất phải, hay là đồng bộ giữa cái thất phải thất trái, rồi câu chuyện sửa như thế nào, câu chuyện chúng ta sẽ làm gì theo con đường ống thông. Thì hôm nay thì các speaker của chúng ta đang vướng một cái báo cáo ở bên TCT nên đã không thể tham gia trả lời trực tiếp. Chúng tôi sẽ liên lạc với cả các báo cáo viên để có thể có được những cái câu trả lời thỏa đáng hơn với các bạn đồng nghiệp. Chúng tôi sẽ còn tiếp tục quay trở về cái chủ đề này trong các cái kỳ đại hội khác, hoặc là các cái hội nghị hội thảo khác liên quan đến kèm theo. Hôm nay chúng ta cũng đã có khá nhiều thời gian để cùng với cả phó giáo sư Nguyễn Sinh Hiền có một cái góc nhìn về phía ngoại khoa, câu chuyện đánh giá cái mức độ hở ba lá như nào, sửa ba lá thế nào, và đặc biệt quan trọng là cho thấy chúng ta cần phải có một cái hát tim liên quan giữa cái đội ngũ là làm siêu âm tim để đánh giá, điều trị, chăm sóc bệnh nhân, cũng như là có ý kiến bác sĩ can thiệp phẫu thuật viên, để chúng ta có một cái giải pháp tổng thể và toàn diện đối với các hở van ba lá. Về mặt thời gian thì cái phiên của chúng ta cũng đã hết, và một lần nữa chúng tôi xin rất là cảm ơn phó sư Nguyễn Sinh Hiền đã dành thời gian bận rộn của mình để tham gia cùng với chúng tôi, chia sẻ những cái kinh nghiệm quý báu và những cái góc nhìn liên quan đến một cái vấn đề rất là khó khăn với cả chúng ta trên thực hành lâm sàng. Rất cảm ơn các bạn đồng nghiệp đã theo dõi cái chương trình đến cái giờ muộn như thế này, vẫn tiếp tục đặt ra các câu hỏi và tiếp tục là làm cái nguồn cổ vũ động viên cho ban tổ chức chúng tôi để tiếp tục xây dựng các cái chương trình tốt hơn cho tương lai. Một lần nữa xin cảm ơn tất cả mọi người, cảm ơn phó giáo sư Nguyễn Sinh Hiền, và chúng ta hẹn gặp lại trong các phiên khác của đại hội ngày mai ạ. Vâng, xin chào anh Hiền ạ.
Chào giáo sư Quang, xin chào tất cả mọi người. Xong rồi, về anh.